චමත්කාරජනක උදෑසනක අපහා එකුණු සම්භාවනීය ඔබ හැමට සුබ උදෑසනක් වේවායි සුභාසිංචනය කරනුයේ සුපුරුදු සෙනෙහසින් හා හදපිරි ආදරේනි. 15 වසරක් පුරා අභිමානවත් වූ ඓක්‍යා සන්නාමය ශ්‍රී ලාංකීය දෘෂ්ටි සේවාවේ නිම්වලලු පුළුල් කරන්නට දේශීය හා ජාත්‍යන්තර විද්වතුන් හා විද්වත් සංවිධාන සමග සහයෝගයෙන් මහජන අක්ෂි සෞඛ්‍ය අන්ධ බව දුරලීමේ දෘෂ්ටි විද්‍යා සම්මන්ත්‍රණයේ සමාරම්භය සනිටුවන් කිරීමට සූදානම්. මේ පිළිබඳ ද්‍රවිඩ බසින් කරුණු දැක්වීම සඳහා දෘෂ්ටි විශේෂඥ සුලක්ෂණාට ஆராதனை.
நன்றி மிஸ் ரஞ்சித் பிரேமரத்ன. அனைவருக்கும் இனிய காலை வணக்கம். நாங்கள் அனைவரும் இன்று இன்முகத்துடன் ஒன்று கூடியிருப்பது ஐக்கிய கல்வி நிறுவனத்தின் 15வது ஆண்டு நிறைவு விழா கொண்டாட்டத்திற்காக. இக்கருத்தரங்கானது பொதுமக்களின் கண் சுகாதாரம் மற்றும் கண் குறைபாட்டை தடுக்கக்கூடிய வழிமுறைகளை கண்டறியும் சிறப்பு கருத்தரங்காக அமைய உள்ளது. நன்றி.
We have an elaborate packed program laid out for you, and it is hoped that you will find today's activities to be great value and benefit to all those who are gathered. The key speeches will be followed by 2 working sessions, which will include panel discussions on crucial topics and coverage of a range of vital subjects matter by eminent professionals. In between the 2 working sessions, we plan to break for lunch at 1:45, with the second session scheduled to commence at 2:30 and to wind up the day's activities by 4:45. And I greatly appreciate and welcome all the guest speakers, panelists who are joined virtually with us today. Professor Madhuvanti Disanayaka will be joining with us, consultant eye surgeon, professor at Faculty of Medicine, University of Colombo, Professor Asrin E.B. Arifin, Deputy Vice Chancellor and Dean, Faculty of Optometry and Vision Sciences, Professor Kovin Naidu, Senior Vice President, Social Impact, Dr. Rajiv Prasad, the Secretary, Indian Optometry Association, Vice President, Asia Pacific Council of Optometry, Dr. Prakash Paudal, Research and Evaluation Officer at Brand Holding Foundation, Adjunct Senior Lecturer, UNSW, Australia, Ms. Junu Shretha, Policy and Advocacy Manager, IAPB, Southeast Asia, Mr. Deepak Kumar Shah, Spokesperson, Nepalese Association of Optometrists. And we also warmly welcome our virtual audience. We are pleased to announce the arrival of the chief guest, Dr. K. Selwyn, the consultant eye surgeon, who is also President College of Ophthalmologists.
මහජන ආර්ථික සෞඛ්‍ය 2022 අන්දව දුර්ලීම සඳහා සම්මන්ත්‍රණය සඳහා අද ශ්‍රී ලංකා අක්ෂි ශෛල්‍ය වෛද්‍ය විශේෂඥගේ සංගමේ ගරු සභාපති තැන්පත් අක්ෂි ශෛල්‍ය වෛද්‍ය විශේෂඥ ඒ සැල්වින් මැතිතුමා පෙරටු කරගෙන ප්‍රධාන ආරාධිතින් මේ ස්ථානයට මේ අවස්ථාවේ ඉතාමත් ගෞරව සම්ප්‍රයුක්තව පැමිණෙන ආකාරය අපිට පෙනී යනවා. අයිකා වෙනුවෙන් අපි මේ අවස්ථාවේ ඉතාමත් සතුටට ප්‍රමෝදයට පත්වෙච්ච අවස්ථාවක් විදිහට සඳහන් කරන්න පුළුවන්. ගුලච්චනා ආචාර්යවරුන් මහාචාර්යවරුන් ඒ වගේම ශ්‍රේෂ්ඨයේ විද්වත් පිරිස ඒකරාශී කරගනිමින් අද දින ශ්‍රී ලංකා දෘෂ්ටි සේවයට විශේෂ දවසක් වශයෙන් සඳහන් කරන්න පුළුවන්. ශ්‍රී ලංකා දෘෂ්ටි සේවයේ ප්‍රගමනය අනාගත අභිවෘද්ධිය සඳහා මේ සිද්ධ වන මහජන අක්ෂි සෞඛ්‍ය අන්ධ බව දුරලීම සඳහා ජාත්‍යන්තර වගේම දේශීය විද්වතුන් රසක් මේ ස්ථානයට සම්ප්‍රාර්ථ වන අවස්ථාව ඉතාමත්ම සුන්දර උදෑසනක ශ්‍රී ලංකා දෘෂ්ටි සේවයේ ප්‍රගමනය උදෙසායි මේ සිදුවන කාර්ය සිදුවන්නේ. මේ සඳහා දායකත්වය දක්වන්නේ සිලෝන් ඓක්‍ය දෘෂ්ටි විශේෂඥයන්ගේ සංගමය, ඒ වගේම 306 බී සිංහ සමාජය, ඓක්‍ය දෘෂ්ටි විද්‍යා අධ්‍යාපන ආයතනය. මේ මොහොත වන විට අක්ෂි විශේෂඥයන්ගේ සංගමේ ගරු සභාපති තැන්පත් අක්ෂි ශෛල්‍ය විශේෂඥ වෛද්‍ය කේ සැල්වින් මැතිතුමා පිරිවරාගෙන විශාල විද්වත් පිරිසක් මේ ස්ථානයට සම්ප්‍රාප්ත වන ආකාරය අපට දැක ගැනීමට ලැබෙනවා. ඉතින් මේ අවස්ථාව පිළිබඳව තවදුරටත් කරුණු දැක්වීම සඳහා ඉංග්‍රීසි බස මෙහෙවන මම ආරාධනා කරනවා අපේ නිවේදිකාව නිශාමනී දුර්ගේ මහත්මියට.
We are pleased to announce the arrival of our chief guest, Dr. K. Salvin, the consultant eye surgeon, who is also President College of Ophthalmologists. We are also delighted to welcome the guest of honor, Dr. Manel Pascal, consultant eye surgeon, and the special guest, District Governor 306B2, Lion Indra Kaushala Rajapaksha, PMJF, PMF. Dr. Nalin Gunasinghe, community ophthalmologist. Senior orthoptist, J.U.C. Kubadu. Mrs. B.L. Padmanandani Vijay Sundara, Ceylon record holder discus throw.
ඉතාමත්ම ගෞරව සම්ප්‍රයුක්තව මේ ස්ථානයට ළඟා වී සිටින ශ්‍රී ලංකා අක්ෂි විශේෂඥයන්ගේ සංගමේ ගරු සභාපති තැන්පත් අක්ෂි ශෛල්‍ය විශේෂඥ වෛද්‍ය කේ සල්වින් මැතිතුමා සහ ඒ වගේම අක්ෂි ශෛල්‍ය වෛද්‍ය විශේෂඥ මානෙල් පැස්කල් මහත්මිය ඒ වගේම සිංහ සමාජය නියෝජනය කරමින් ඍජු නේත්‍රඥයන්ගේ සංගමේ නියෝජනය කරමින් විශාල පිරිසක් මේ ස්ථානයට මේ අවස්ථාවේ සම්ප්‍රාර්ථ වී සිටිනවා. ඔබ සියලු දෙනාම ඉතාමත්ම ගෞරවයෙන් ආදරයෙන් සිලෝන් ඓක්‍ය දෘෂ්ටි විශේෂඥයන්ගේ සංගමය ඒ වගේම 306 ඓක්‍ය සිංහ සමාජය ඓක්‍ය දෘෂ්ටි අධ්‍යාපනික ආයතන වෙනුවෙන් මේ අවස්ථාවේදී මහජන ආක්ෂි සෞඛ්‍ය අන්ධබව දුරලීමේ වැඩසටහන සඳහා වැඩසටහන වෙනුවෙන් මම මේ අවස්ථාවේ පිළිගනු ලබනවා. ස්තුතියි.
We are fortunate to have Dr. K. Selvin, consultant eye surgeon, who is also the President College of Ophthalmologists, as our chief guest today. We welcome you, sir, to the scientific session of IKEA Institute 2022. Let us give a big hand to our chief guest, Dr. K. Selvin. We are also delighted to welcome the guest of honor, Manil Pascal, consultant eye surgeon, and special guest, District Governor 306B2, Lion Indra Kaushal Rajapaksha, PMJF, PMAF, Dr. Nalin Gunasinghe, community ophthalmologist, senior orthoptist J.U. Sikubadu, and optometrist Mihiro Vikramarachi. We warmly welcome you to the IKEA 2022 on the theme of Public Eye Health Eliminates Avoidable Blindness.
இந்நன்னாளிலே தலைமை விருந்தினராக வருகை தந்திருக்கும் கண் மருத்துவர் டாக்டர் செல்வின் ஐயா அவர்களையும் மற்றும் விருந்தினராக வருகை தந்திருக்கும் மரியாதைக்குரிய கண் மருத்துவர் டாக்டர் மானல் பாஸ்குவல் அம்மையார் அவர்களையும் சிறப்பு விருந்தினராக வருகை தந்திருக்கும் கவர்னர் லயன்ஸ் 306B2 இந்திர கௌஷால் ராஜபக்ஷ அவர்களையும் மற்றும் எமது சிறப்பு அதிதிகளாக வருகை தந்திருக்கும் கண் வைத்திய நிபுணர்கள் அனைவரையும் மற்றும் எங்கள் சக நண்பர்கள் அனைவரையும் இருகரம் கூப்பி வரவேற்பதில் மகிழ்ச்சி அடைகிறேன்.
And I greatly appreciate and welcome all the guest speakers, panelists who are joined virtually with us today. And we also warmly welcome our virtual audience.
සුබ උදෑසනක් වේවා. අද දින ශ්‍රී ලංකා දෘෂ්ටි සේවා ඉතිහාසයට නව මාවතක් විවර කරමින් මහජනාක්ෂි සෞඛ්‍ය අන්ධ බව දුරලීම IKEA 2022 15වෙනි සාන්වත්සරික උත්සව වෙනුවෙන් මේ ස්ථානයට ශ්‍රී ලංකාවේ සිටින ශාස්ත්‍රීය සම්බන්ධ විද්වතුන් ඒ වගේම විද්වත් සංගම් රාශියක් මේ ස්ථානයට කැඳවාගෙන ඇවිල්ලා ශ්‍රී ලංකාවේ පමණක් නොවේ ජාත්‍යන්තරයේ සිටින මේ සම්බන්ධව වැඩ කටයුතු කරන විශාල පිරිසක් මේ සමග අපි සමග අද අත්වැල් බැඳගෙන සිටිනවා. ඉතින් මේ සියලු කාරණා සඳහා මේ ස්ථානයට සම්ප්‍රාර්ථ වී සිටින ඔබ සැම දෙනාම පිළිගැනීමට මේ අවස්ථාව තා ස්වල්ප මොහොතකින් අපි සූදානම් කර සිටිනවා. සියලු දෙනාම ගැන සතුටුයි, ස්තුතියි. මේ අවස්ථාව දෙමිළ බසින් ඔබට දැනුවත් කිරීම සඳහා සුලක්ෂණ.
ஐக்கியா நிறுவனத்தின் 15வது ஆண்டு நிறைவு கொண்டாட்டத்திற்காக வருகை தந்திருக்கும் அனைவரையும் நாங்கள் மிக மகிழ்ச்சியுடன் வரவேற்கின்றோம். நன்றி.
It is an important day for those who are gathered here to observe the progress made by various individuals, especially with the theme relevant to current pandemic situation. I am sure it is yet another unforgettable day in IKEA calendar.
IKEA 15 වන සංවත්සර උළෙලට පැමිණි සිටින ඔබ සැම නැවත ගෞරවයෙන් පිළිගනු ලබනවා. මීළඟට චාරිත්‍රානුකූලව පොල්තෙල් පහන් දැල්වීම සඳහා ගෞරවයෙන් ආරාධනා කර සිටිනවා. ප්‍රථමයෙන් අප ආරාධනීය පිළිගෙන මෙහි සැපැමිණි ප්‍රධාන ආරාධිත උපදේශක අක්ෂිරෝග විශේෂඥ ශ්‍රී ලංකා අක්ෂිරෝග විශේෂඥ සංගමයේහි සභාපති K.A. Selvin මහතාට මීළඟට ගෞරවනීය ආරාධිත උපදේශක අක්ෂිරෝග විශේෂඥ මානෙල් පැස්කොල් මහත්මිය. විශේෂ ආරාධිත සිංහාධිපති ඉන්ද්‍රා කෞශල් රාජපක්ෂ මහතා. මීළඟට උපදේශක අක්ෂිරෝග විශේෂඥ නලින් ගුණසිංහ මහතා. මීළඟට ජ්‍යෙෂ්ඨ ඍජුනේත්‍රඥ ජේ.යු. සීකබදු මහතා. මීළඟට වික්‍රමාරච්චි දෘෂ්ටි විශේෂඥයින් හා ශ්‍රවණාධාර සත්කාර ආයතනයේහි සභාපති දෘෂ්ටි විශේෂඥ මිහිර වික්‍රමාරච්චි මහතා. මීළඟට ශ්‍රී ලංකා කව්පෙත්ත විසිකිරීමේ ජාතික ශූරිය පත්මා නන්දනී විජේසුන්දර මහත්මිය. මීළඟට ඓක්‍යා නිර්මාතෘ ජ්‍යෙෂ්ඨ උපදේශක දෘෂ්ටි විශේෂඥ නරේෂ් ප්‍රධාන් මහතා. මීළඟට ඓක්‍යා ජාලයේහි සභාපතිනි ජ්‍යෙෂ්ඨ උපදේශක දෘෂ්ටි විශේෂඥ එම්.ඒ. ධම්මිකා දේශප්‍රිය මහත්මිය. සිලෝන් ඓක්‍යා දෘෂ්ටි විශේෂඥ සංගමයේහි සභාපතිනි දෘෂ්ටි විශේෂඥ නිසංසලා ප්‍රනාන්දු මහත්මිය. ඓක්‍යා සිංහ සමාජයේහි සභාපති දෘෂ්ටි විශේෂඥ ලහිරු රොද්රිගු මහතා. මීළඟට අධිශිෂ්‍යත්වලාභී දෘෂ්ටි විශේෂඥ ප්‍රභාමලී සිරිවර්ධන මහත්මිය. අධිශිෂ්‍යත්වලාභී දෘෂ්ටි විශේෂඥ සුරංග සිල්වා මහතා. අධිශිෂ්‍යත්වලාභී දෘෂ්ටි විශේෂඥ ප්‍රසාද් ගෝමිස් මහතා. මීළඟට පොල් තෙල් පහන් දැල්වීම සඳහා ඓක්‍යා ආයතනයේ සිසුන් දෙදෙනෙකුට ආරාධනා කර සිටිනවා. ස්තුතියි.
Thank you. Now it's time to introduce the guest at the head table. First of all, I call upon the chief guest, Dr. Selwyn, consultant eye surgeon, who is also President College of Ophthalmologists. Kindly take your seat at the head table, sir. Guest of honor, Dr. Manel Pascal, consultant eye surgeon. Special guest, Lion Indra Kaushal Rajapaksha, PMJF, PMAF. The program director, Found Eye Care Institute, consultant optometrist Naresh Pradhan. The chairman Eye Care Group, consultant optometrist Dhammika Deshapriya. The chairman Ceylon Eye Care Association, Optometric Association, optometrist Nisansala Fernando. Please take your seats at the head table. I would like to invite the President of Lions Club of IKEA, Lion optometrist Lahiru Malinga Rodrigo to come to the side table.
මීළඟට ජාතික ගීය ගායනා කිරීම සඳහා නැගී සිටින ලෙස ගෞරවයෙන් ඔබ සමගින් ඉල්ලා සිටිනවා. ස්තුතියි. දෘෂ්ටි ශේෂ්ත්‍රයෙහි උන්නතිය උදෙසා වෙහෙස වී කැප වී කටයුතු කළ මේ වන විට අප අතරින් සමුගෙන සිටින දෘෂ්ටිවේදීන් සිහිපත් කිරීම උදෙසා විනාඩියක නිශ්ශබ්දතාවක් පවත්වන මෙන් ඔබ සියලු දෙනාගෙන් ගෞරවයෙන් ඉල්ලා සිටිනවා.
Thank you. Next on the agenda to declare the Code of Ethics of IKEA Institute. And this will be read by, in English, optometrist Erandi Siruvadana, in Sinhalese, optometrist Geeta Vijay Sundara, and in Tamil, optometrist Arul Kumar.
වෘත්තීය ප්‍රතිඥාව කියවීම සඳහා සිංහල භාෂාව සඳහා ගීතා රූපිණී විජේසිංහ මහත්මිය ඒ වගේම ඉංග්‍රීසි බස සඳහා එරන්දි සිරිවර්ධන දෙමළ බස සඳහා අරුල් කුමාර් යන දෘෂ්ටි විශේෂඥයින් මේ අවස්ථාවට සහභාගී වෙනවා.
நடத்தை நெறியினை உங்களுக்கு சொல்வதற்காக தமிழ் மொழியில் அருள்குமார் நடராஜன், ஆங்கில மொழியில் எரந்தி சிறிவர்தன, සිංහල මොළිயில் ගීතා විජයසුන්දර.
ආයතනික ආචාර ධර්ම ගරු කිරීම. සෑම විටම රෝගියාගේ අයිතිය හා විශ්වාසනීයත්වය ආරක්ෂා කිරීම.
நடத்தை நெறி மரியாதை. ஒரு நோயாளியின் உரிமை, பெருந்தன்மை, சுய உரிமைகளை மதித்து நடத்தல்.
Respect the right and dignity and autonomy of the patient. උපදෙස් අවශ්‍ය අවස්ථාවන්හිදී රෝගියාව අදාළ වෛද්‍යවරයෙකු වෙත යොමු කරමි.
ஆலோசனை. நோயாளிக்கு தேவைப்படும் இடத்து இன்னுமொரு கண் பரிசோதகரிடமோ வைத்தியரிடமோ சுகாதார உத்தியோகத்தரிடமோ அனுப்புதல்.
Advice patients refer to another optometrist or other health professional when necessary. සුරක්ෂිතභාවය සෑම විටම රෝගියාගේ පෞද්ගලික බව සහ වෙනත් සෞඛ්‍ය තොරතුරු පිළිබඳ රහස්‍යභාවය ආරක්ෂා කිරීම.
உத்தரவாதம். நோயாளியின் சொந்த மற்றும் வைத்திய தகவல்களை இரகசியத்தன்மையுடன் பாதுகாத்தல்.
Ensure confidentiality and privacy of patients, protected health and other personal information. උත්සාහය සෑම රෝගියෙකුගේම අක්ෂය සහ දෘෂ්ටි අවශ්‍යතාව වෙනුවෙන් පෙනී සිටීම.
நேர்மையாக இருத்தல். ஒவ்வொருவருடைய நோய் தாக்கம் மற்றும் பார்வை சம்பந்தப்பட்ட கவனிப்புகளை உறுதிப்படுத்துதல்.
Strive to ensure that all persons have access to eye and vision care. උසස් භාවය රෝගියාගේ යහපත වෙනුවෙන් මාගේ වෘත්තීය දැනුම සහ ප්‍රවීණත්වය හා කුසලතා වර්ධනය කර ගැනීම අවශ්‍යතාවයක් බව දනිමි.
முன்னேற்றம். நோயாளி நன்மை பெறும் பொருட்டு நமது தொழில் அறிவு, தேர்ச்சி மற்றும் திறமைகளை வளர்த்துக் கொள்ளல்.
Advance their professional knowledge and proficiency to maintain and expand the competence to benefit their patients. පුහුණුව මාගේ වෘත්තීය හෘද සාක්ෂියට එකඟව අවංකව හා විශ්වාසය රැකෙන පරිදි නිරතුරුව කටයුතු කිරීම.
பழக்க வழக்கங்கள். சமதுறையில் உள்ள மற்றவர்களை விமர்சிப்பதை விடுத்து மனசாட்சியுடனும் நேர்மையுடனும் நமது தரத்தை அதிகரிப்பதன் மூலம் மக்களின் நம்பிக்கையை பெற்றுக்கொள்ளல்.
Practice with conscious and integrity that enhances the status of profession and promotes public confidence. හඳුනා ගැනීම සෞඛ්‍ය හා සමාජ සුබ සාධනය ආරක්ෂා කිරීමට බැඳී සිටිමි.
அறிந்து கொள்ளல். சமூகத்தின் பொதுநல சுகாதார நிலைமையை பாதுகாப்பதற்கும் அதனை வளர்ப்பதற்குமான எமது கடமையுணர்ச்சி இருத்தல்.
Recognize their obligation to protect the health and welfare of society. පැවැත්ම ආදර්ශමත් පුරවැසියෙකු ලෙසටත් අවංක භාවයෙනු සාධාරණ භාවයෙන් හා කරුණාව දයාවෙන් යුතුව වෘත්තියේ නියැලෙමි.
வழிகாட்டுதல். இத்துறையில் நேர்மை, நம்பகத்தன்மை, அன்பு, இரக்கம், வெளிப்படைத்தன்மையுள்ள ஒரு உதாரண புருஷராக எமக்கு நாமே இருத்தல்.
Conduct themselves as exemplary citizens and professional with honest integrity, fairness, kindness and compassion.
අද දින මේ ස්ථානයට සම්ප්‍රාර්ථ වී සිටින ඔබ සැම පිළිගැනීම සඳහා මගේ ගෞරවනීය ආරාධනය ஐக்கியா ජාල සභාපතිනි උපදේශන දෘෂ්ටි විශේෂඥ ධම්මිකා දේශප්‍රිය මැතිණියට.
good morning, good afternoon, and good evening. All a very warm welcome on behalf of the ICAR Institute, Ceylon ICAR Optometric Association, and Lions Club of Colombo ICAR. Our chief guest, Dr. K. Selwyn, Consultant Eye Surgeon, President, College of Ophthalmologists. Our guest of honor, Dr. Manil Pascual, Consultant Eye Surgeon. Our special guest, Governor, Lion Indra Kaushal Rajapaksha. International Agency for Prevention of Blindness, IAPB, Southeast Asian Regional Manager, Mr. Y.D. Sapkota. Senior Vice President, Social Impact, Honorable Professor, University of Wasulu Natal, South Africa, Dr. Kovin Naidu. Deputy Vice Chancellor and Dean, Faculty of Optometry and Vision Science at Segi University, Malaysia, Professor Dr. Azreen. Research and Educational Officer at Brian Holden Foundation, Senior Lecturer, University of New South Wales, Australia, Dr. Prakash Paudel. Policy and Advocacy Manager at International Agency for Prevention of Blindness, Dr. Juno Sestra. Vice President of Asian Pacific Council of Optometry, Dr. Rajiv Prasad. Nepali Association Optometrist Spokesperson, Mr. Deepak Kumar Shah. Consultant Eye Surgeon, Professor Dr. Madhuvanti Disanayaka. Consultant Eye Surgeon, Dr. Amilidi Alvis. Consultant Eye Surgeon, Dr. Asmant Piris. Consultant Eye Surgeon, Dr. Mirna Kumar Das. Deputy Director General, Tertiary and Vocational Education, TVEC, Dr. Janki Jailat. Community Ophthalmologist, Dr. Nalin Gunasinghe. Community Ophthalmologist, Dr. Asela Bedira. Chairman of National Institute for Occupational Safety and Health, Dr. Ms. Champika. Senior Optometrist, Dasanta Fonseca. Senior Orthoptist, JUC Kubadu. Chairman of Vikramarachi Optician, Mr. Mihira Vikramarachi. Senior International Athletics, Ms. Vijay Sundara. Optometrists and opticians from different organizations, invited guests and my dear students. Ladies and gentlemen, welcome everyone to ICAR 2022, Public Eye Health on Eliminating Avoidable Blindness. I am Damika Deshapriya and I am the chairman of ICAR Group. I am speaking to you all today from the land called the Pearl of Indian Ocean, Sri Lanka. We are meeting at such a momentous time in the history of global health. We are all living through a global pandemic. Almost none of us living today have ever seen. A crisis and a challenges affecting every corner of the globe, and we offer our thoughts and best wishes to all those who have been touched directly by COVID-19 and mourn those whose lives we have lost. We are also on the cusp of a new era in global eye health, where more than 800 million people visually impaired just because of not having a pair of spectacles, and more than 100 million people blind due to cataract, just they need a lens replacement. Avoidable vision impairment occurs too frequently as a result of public health policy and healthcare delivery. Eyesight affects how human beings perceive and interpret the world. Vision loss in adults is frequently associated with adverse effect of other chronic illnesses. Vision impairments remain notably absent from many public health agendas and community programs. Undiagnosed or uncorrected refractive errors and other visual disorders in children can lead to developmental, academic, and social challenges. Simply, early detection could save the vision and early prevention of health issues. According to the National Blind Survey conducted by Ministry of Health in year 2014-15, we have 1.7% blind rate on above 40 years age group. Almost half of the population need to be corrected for some kind of visual impairment. More than 4 million school children has no proper eye screening system. As empowering women is making world better. If eye health become the key factors in healthcare system, as a whole public health will improve. Because eye is window to the world and door to the body. I hope presentation will open the door for distinguished panelists for discussion. I'm really grateful to all distinguished guests, panelists, speakers, participants and my ICARE team. Once again, very warm welcome to ICARE 2022. Thank you.
ස්තුතියි ಐಕ್ಯ ಜಾಲ ಸಭಾಪತಿනි උපදේශන දෘෂ්ටි විශේෂඥ ධම්මිකා දේශප්‍රිය මැතිණියට මේ අවස්ථාවේ ස්තුතිවන්ත වෙනවා.
Thank you. It is my privilege to introduce the program director, the founder IKEA Institute, consultant optometrist Naresh Pradhan, who will share with you his experience based on tremendous, tireless efforts he had put in over a 22-year-old period. He has worked with remarkable perseverance in the field of optometry in Sri Lanka. He will talk on the subject of IKEA highlights. It's over to you, sir.
Can you put a presentation? So today actually, right, so when I, right, so especially other Vishesh Davasak, that is mainly IKEA Institute 15 years celebrate karna. IKEA Institute established sune ekak Vishesh Davasaki. Eka tamai mage teacher Dasanta Fonseca ge birthday, right? So mama මෙතන ඉඳලා විස් කරනවා සහ ඔයගොල්ලෝ හැම කෙනාටම මේක හැම IKEA ඩේ එකම එයාව විස් කරනවා මේ එයාගේ බර්ත්ඩේ එක so එයාගේ බර්ත්ඩේ දවස තමයි අපි IKEA Institute එකේ start කරේ right so happy birthday Dasan sir from here right so then especially what I will tell you regarding this is now when it comes to 15 years I will just take you some glimpse of how IKEA Institute has run in this last 15 years right, so as a 15 years anniversary. So if you see this, right, so if you see this, now IKEA Institute was established in 2007, January 28, right, when, as I mentioned you, that was my teacher's, birthday. And then if you see the 2007, so when we started this IKEA Institute, and 2008, we had, one day session, and I remember Madam Pascal was with us, and today also she is with us. Right? And we had this, 2009 we started, we started a World Sight Day. Then 2009 we introduced this Code of Ethics, which we read today, right? And 2000, likewise, 2000, if you take in 2010, actually, we started this optometrist competence standard to develop with TVC, right? And that was one of the milestone program that we have done. So optometrist national competence standard was developed in 2010, right? And subsequently, we started the, this scientification. And scientification, if you see here, the people who are present, right? And the people who are announcing, today also, they are announcing today also. Right? And so if you see in 2012, we started this optician, national competitive standard for optician being developed. And then, so today it is both of this NBQ program is running, and we are looking forward to go for a other level of program, so which is in process, right? So if you see in 2014, we had a, synergy for change, right? So 2012 was transformation is of optometry, and 2014 we say synergy of change. We wanted more and more multiple associations and multiple institute get together and do together certain things, right? And today we are, major organization. We all are in Ceylon comes to optometry and orthopic, right? So it's a great achievement that we have. Then if you see in 2015, we were having a theme of O3, who is an ophthalmologist, who is an optometrist, and who is an optician, right? Because of, it's sometimes people are not aware who is an ophthalmologist, who is an optometrist, and who is an optician. This is very important for public to know what is their role, right? So there's sometimes some people, they, they go out of their, criteria and do certain things which is not acceptable. And then if you see in 2016, we had one of the largest survey program called B, Barrier in Eye Examination, why people are not coming for the eye testing, right? Eye examination. So we had one of the largest, which is because of our students are spread all over the country, right? So if you take from Jaffna to the Hambantota, we have everywhere, our network, and through that network, we did a study, why people, what are the difficulty that they have, what is the barrier that has created for not to, come for the eye examination, right? So that then 2017, it was our 10th anniversary, and there we had a Colombo declaration, which is especially we discuss about role of an optometrist. What is the role of an optometrist all about? So already we have for our health ministry has already given a duty list for the ophthalmic technologists, and we have almost, based on that, we have made this program, and so there were almost 170 people from different categories, so, involved, and we discussed about this and, formulated this. So then 2018, it was just a convocation in this part only. So then 2019, if you take about, 2019, actually, it was one of the longest walk that we had from Kandy to Colombo, right? So to aware the people on World Sight Day, and we had 116 kilometer of walk, and we asked from one single question from the people, that was, how did you have your eye examination one time in your life? Right? And we found that 80% of them says no, right? So this is one thing what we, we did in 2019. And at the same time, 2019, we were very privileged to have, right, Dr. Parras Sekram with us. And so 2019 became very blissful for us. Then after that, 2020, again, we were, having a theme of elimination of refractive blindness. 2019, actually, it was about the occupational ocular health and safety. And so we come to know that there is no policy for occupational health and safety even, not even ocular part, right? So then we took interest on our syllabus. We added occupational ocular health and safety part, right? So then, so this is one thing that we were, this thing today. So we are here for ICA 2022, and today is our 15th anniversary, and we have taken a theme of public eye health, right, to eliminate avoidable blindness. So I would say good morning, good afternoon, and good evening, because of, today we have people listening to us from Australia, from England, from Nepal, from Bangladesh, from India, from Vietnam. So we have, speakers from Singapore, we have speakers from Malaysia, we have speakers from Australia, we have speakers from India, Nepal, so we have, we must have, hundreds of crowd, which is, already joined with us online. And including IAPB, APCO, Asia Pacific Council of Optometry, Brian Oldham National Institute, all these people are, their heads are joining with us today, and they are also in line with us in discussion to see how we can, avoid preventable, eliminate avoidable blindness, right? So what is very interesting is this. Now, if you take in about Sri Lanka, what I was talking to them was also, Sri Lanka is so blessed, right? So I'm blessed to be here. I always feel that. right? Because of, what happens, if you take literacy rate, Sri Lanka is, one of the highest rate in Southeast Asia, right? So if you see healthcare system wise, Sri Lanka is one of the best healthcare system having country in the world, right? So if you take transportation wise, right, all these factor wise, and then if you take social taboos and those thing wise, caste or religion issue wise, we don't have that much of issue. We are not that, conservative in that pattern. But even though, those can be sometime a barrier for this, this blind rate, which Ministry of Health says about 1.7% above 40 group, right? So having all those things, transportation is good, healthcare system is good, education rate is good, is still why we are having so much of this thing. And according to our this work also, and and B program also, we found that many people are not coming for the eye examination, right? So people are not aware, right? Not aware. Generally what happens, if the people are not educated, the literacy rate is low, there is tendency that your awareness level could go down. Or people are, sort of a transportation is difficult, it is not very easily reachable. So there are a mountainous country like Nepal, right, or say Afghanistan or India, so you can see something this. So it's still, having all this kind of so this discussion is actually today discussion is not all about Sri Lanka. Now, actually, this is the same pattern that we see in other part of the countries also. So today's discussion will be a guideline, will be some sort of a discussion for Bangladesh also, for Nepal also, for India also, for, for Uganda also, for Kenya also, right? So all these countries, or Malaysia also, so this will be a, kind of a, similar thing that we have. Like 1914, we have SMI, School Medical Investigation System, which most of the developed countries must have not thought. But today we will see the result, how the SMI programs are running, right? We have extracted from the Ministry of Education itself the data, right? So this is, the system is there, sometimes policy is there, some country doesn't have even a policy, right? Policies are there, but still we are not taking, we are not making out of it, and we have to see what is wrong, where we have gone wrong, right? So today's presentation, today's panel discussion will discuss on all these topics, and we will have some more clarity about, and we will again get together and try to make, right? So this avoidable blindness, so we have to eliminate, right? So this is a long process, but we have to start this journey, and hopefully the international, community as well as the local community will join together and make this happen, right? So, and I hope after today's presentation, international community also will like to have, international seminar in Sri Lanka. So we hope we will get ready for Asian, optometry, conference in Sri Lanka next year. Thank you very much.
Thank you, sir. Once again, I greatly appreciate and welcome all the guest speakers and panelists who are joined virtually with us today. Professor Madhuvanti Disanayaka, Consultant Eye Surgeon, Professor at Faculty of Medicine, University of Colombo. Professor Asrin E.B. Arifin, Deputy Vice Chancellor and Dean Faculty of Optometry and Vision Sciences. Professor Kovin Naidu, Senior Vice President, Social Impact. Dr. Rajiv Prasad, the Secretary, Indian Optometric Association, and Vice President, Asia Pacific Council of Optometry. Dr. Prakash Paudel, Research and Evaluation Officer at Brand Holding Foundation, Adjunct Senior Lecturer, UNSW, Australia. Ms. Junu Shrestha, Policy and Advocacy Manager, IAPB. Mr. Y.D. Sapkota, Regional Coordinator, IAPB, Southeast Asia. Mr. Deepak Kumasa, Spokesman Person, Nepalese Association of Optometrists. We now welcome Mr. Y.D. Sapkota, Regional Coordinator, IAPB, the International Agency for the Prevention of Blindness, Southeast Asia, who will be joining us virtually to deliver his speech. Mr. Y.D. Sapkota, Regional Coordinator IAPB, the International Agent.
Yeah, thank you so much. It's very happy and happy to be in this wonderful event. So can I just share my screen now, I guess?
IAPB, the International Agent.
Yeah, thank you so much. It's very happy and happy to be in this wonderful event. So can I just share my screen now? Is it working? My screen sharing there, and am I audible there? Yeah, I hope so. So good morning, yeah, good afternoon, good evening to everyone. Yeah, distinguished guests, participants, ladies and gentlemen. It's my great opportunity, privileged to participate in this wonderful event. Thank you so much for the organizer for inviting me and then providing opportunity to share some of the IAPB strategy in this wonderful gathering. So we know that we have a IAPB and the WHO jointly launched the strategy in 1999 as Vision 2020. So Vision in this 20 years Vision 2020 era, we have achieved a lot of milestone has been set, but Vision 2020 has ended last year or 2 years back. But the problem, the eye care's problem, blindness and visual impairment problem hasn't ended, and then so does our aspiration and spirit to work towards the blindness hasn't ended. So there is still a lot to do. World Report on Vision in 2019 shows that the still 1.1 billion peoples are still need of the eye care services, which has need to the access need to be expanded to those peoples. And we see that the problem, the visual impairment problem, is not equally everywhere. So most importantly, 90% of those peoples are in a low and middle income country. And then it's more of the women and those with the disabilities, ethnic minority are the most affected. Due to this vision impairment problem, the World Report on Vision shows that almost 411 billion per year productivity loss due to the vision impairment and the poor visions. So this is the issue we have to now address in a new strategy, which is we call it 2030 strategy. That is the post Vision 2020, and then setting the target for 2030. So what we have now is more evidences is there. So we don't need to duplicate everything from the Vision 2020, but we need to complement, and then a lot of success story during the Vision 2020 era we need to be continued also. So we have more evidence that World Report on Vision and the Lancet Global Commission, we have a more global resolutions on eye health. World Health Assembly Resolution 73.4 is highlighted the importance of the eye care, and then suggested integrated people-centered eye care should be the agenda for the years to come. Similarly, last year, UN General Assembly also realized and then highlighted the importance of the vision and the eye health services, in which that the lot of SDG goals, at least 8, to say more precisely, at least 8 SDG goals cannot be achieved without good eye health, or the vision is critical to achieving all these SDG goals. For example, this poverty, no poverty. So as we see that a lot of blindness and visual impairment issues are in a low and middle income country, and then poverty, those vision impairment and the blindness issue makes the individual and the family even more poverty. So achieving this goal, the vision is, and the good eye health is important. Similarly, uh, the zero hunger, like a good eye, and the goal 3, the overall universal health coverage or health system, and the quality educations, decent workplace, and so on. That these 8 goals are very critical to the vision is globally accepted in the UN General Assembly. And as in the past, during the Vision 2020 era also, we were more of the talking about the eye health issue. Eye health issue, among the eye health also is a avoidable blindness issue, which I see in the previous speaker also very much highlighted in avoidable blindness. But now we shouldn't limit ourselves to that avoidable blindness. The previous issue, like a Vision 2020 and the other several global resolution, was more focused on the eye health issue. And then later it has been realized that the eye health should be a part and parcel of the health issue. So is a public health issue. But now it has been realized in the several global event and assemblies that the eye health is not only the health issue, is a social, economical, and then overall human development issue. So that should be considered because it is critical to the so many of the SDG goals, which is related to the Human Development Index. So the future strategy, the 2030 strategy is more focused that the eye care should not be the issue of the optometrist or the eye doctors or the Ministry of Health. It should be the agenda and the issue to be tackled by the other sector as well, other development sector as well. So the 2030 insight is more focused on that to make this eye health issue as a more of the human development or the socio-economical issue of the human beings. So in this mission, what we have, IAPB has aimed or set the objective that no one should experience unnecessary preventable sight loss. Everyone should achieve their full potentials. So should not be limited due to the vision or the vision impairment or the blindness. And then the eye care should be more comprehensive in the days to come, should include the rehabilitation services and should be accessible and inclusive and then the affordable to everyone, everywhere, whenever they are needed. And then people should be aware enough so that they're how to care the eye care services, seeking appropriate health seeking behavior, and then shouldn't be the kind of the eye care service should not be the any social stigma. So as a sector, we need to work harder. As we see the work harder and to reach the hardest to reach. We may have achieved a lot of achievement or set the milestone during the Vision 2020 era with the catching up the low-hanging fruits. Now the more challenges is there, so that and there should be a kind of the equity should be in our heart. That is the kind of the mission of the strategy. So what are the hurdles now we have to overcome in the years to come? So there are 4 main hurdles has been highlighted. So the most importantly, to understanding and awareness. So the understanding the problems and the public awareness is very important. And then it should be kind of the social stigma. So but the awareness should not be limited to only the public and then the health seekers. So there is a greater need for the political awareness also. Political awareness means the politician, the planners, the decision maker should also understand the importance of the eye health, and then eye health need to be further prioritized and also need to be make a part and the parcel of the ongoing development activities or the implementing SDG goals. SDG goals should be a part and parcel of the SDG goals also. That political awareness we need to make in the years to come. Another important factor is a commitment and the finance. As we see that there is a big funding gap. So that old report on vision has highlighted that we need additional approximately $25 billion globally to reach the unreached, to reach those 1.1 billion peoples, and which will give us the return or the productivity loss of the $411 billion per year. So that funding gap and that cost efficient measures exist there, but there is a big funding gap is there. So the eye care need to be made accessible, and then where all the scientific technology should be embraced. So all the eye care service should be a kind of the non-traditional setting, should transform to the non-traditional setting. And then also another important is the integrations in many countries in our region and globally. Eye care services is considered as a kind of the specialized services and lives in a particular and parallel to the government health systems. So that need to be addressed in the years to come. So the eye care should be a part and parcel of the mainstream health care, and then should not be silos, which also gives a problem of the professionals and the lack of professionals when you have a particular programs. So another hurdle we need to address in the years to come in this strategy is a regulation, eye care service regulation in the markets. The eye care service, many of the eye care service commodities like spectacles with needs for refractive error, IOLs with needs for the cataract surgery is still considered as a kind of the business commodity in many countries. So, and then the heavily taxed, and then the service makes bit unaffordable to the many of us. So those things need to be addressed, and then this commercial behavior towards the essential goods need to be kind of the regulated, and then it is considered as one of the hurdle in the eye care strategy 2030. So that need to be addressed. So there are the main three elements has been considered in this 2030 strategy. So those are the eye care need to be elevated. That means it should be embedded as a fundamental of the economic, social and the development issue. So eye care should be integrated. So it should be incorporated eye health in a wider healthcare system or the mainstream healthcare system. Eye health should be the part and parcel of the main health policy and the plans in every country, in every nations. And then another important aspect of this strategy is to activate. Theme is activate, is a drive or the demand-driven service should be there. What is the demand? The people able to make a demand, and then the supplies are based on the demands, and the consumer change the markets, and then more or less is a consumer, the demand-driven service or the demand-driven approach, or if in some country, if possible, it should be make a kind of the right-based approach. So the people who are vision impaired, who are blind, is a kind of their basic rights to get services. So those kind of the people will make aware so that they can demand the services. So there are the three themes is mainly taken as a strategy in this 2030 strategy. So elevate means I already elaborated on it. So the kind of we need to have unlock the political will and financing. So eye health services should be more in a priority in health systems, and then more resource allocation, including the money and the human resource financing system should be there. So it should be make a kind of the part and parcel of the SDG agenda. So all the development issues should have eye health issue also to be addressed. And then we have a new target to be set, like World Health Assembly has given, endorsed the two targets, like effective refractive error coverage and effective cataract surgical coverage to targets should be met by 2030. And it is a kind of the tracer indicators for universal health coverage. And then also we need to be elevate the leverage the school and this educational setting, as we see that a lot of refractive error problems and is in school age children's. So the should be eye health should be in the school health systems. And then also is an important factor is to achieve one of the SDG goal is a decent workplace and then improve productivity with the good visions. So we should target the employers And then also the occupational health should be a kind of the issues. All the safety and safety measures in the hazardous worker should be considered. And then, yeah, SDG framework is one of the factors we should consider. So the IL to embed, IL should be embedded or include or integrate into the SDG frameworks. That's how the eye care service is planned to be elevated. Similarly, in the integrated, it should make a part and parcel of the universal health coverage. And then World Health Assembly endorsed integrated people-centered eye care should be included or the translated in a national eye health plan. And then we should able to build up the resilient workforce. And the WHO has given guidelines on the competent workforce. So that should be taken as a reference, and then every country should have a resilient workforce, and then embrace the technology solutions with the latest technology solution of the eye health, which will improve the quality and the accessibility of the eye care services. So another part is the activate. I already mentioned that it should be a kind of we have to have a campaign that everybody knows how where and how to seek, how and when to seek the eye care services, and shouldn't be taken as any social stigma for the blindness and any disabilities or vision impairment. And then it's an important factor is we have to consider is also the private sector. The private sector provides a lot of eye care services, so that should be a kind of the partnership should be built in the public-private as a public-private partnership. And then regulatory environment that the eye care service consumable, specifically the glasses and the IOL should be considered as a business commodity, should be considered as an essential commodity for the human being. So all this strategy has been built in the lot of evidences, as we see there a lot of evidences like a Lancet Global Health, World Report on Vision, UN General Assembly resolutions, and World Health Assembly resolutions. So for the elevate sector, there is already a lot of achievement has been made, like a political commitment. We already have a UN resolutions on eye health. There's SDG agenda. The UN has realized that there is a critical vision is critical to the SDG agenda, and there are the SDG indicators which includes the eye, and then UN institutional engagement in 2045 agenda. The eye health has already been inserted into the UN institution engagement 2045. So there is already process going on elevation of the eye care services. So all this has to be translated at the national level eye health policy and plan. Similarly, in the integrated sector, the policy and the system changes is required, where the World Health Assembly resolution and this integrated people-centered eye care is already been endorsed World Health Assembly. That means it is been endorsed by every country, member country. So it is endorsed in Nepal, endorsed in Sri Lanka, so it has to be translated in the National Eye Health Policy and Plan. There are several WHO guidelines which has come up and is coming up in the process of coming up. There are several packages and the tools WHO is developing. We have to use those tools and packages to make the eye care service more effective, and then to establish quality assurance and the monitoring framework. So by that, we have to make the eye care service more accountability. So another part is activate part is already going on, that also this World Sight Day is been celebrated globally everywhere. That brings us a lot of opportunity to activate the peoples and then to make the people aware on the eye care services. And then similarly, a lot of other campaigns need to be done in this under this strategy to make the to activate the policy makers and the health providers, and at the same time the health seekers. So with this strategy, there are several milestone annual strategic plan need to be developed, and then milestone need to be developed. Like in 2021, we can see that already some milestone has been set, like UN resolutions, global target on uncorrected refractive error and cataract surgical coverage. And then World Sight Day was in 2021 was another milestone. So in the similarly in the we have once we develop the strategic plan based on this strategy, like in 2025, so we can say that the SDGs target on eye health is being adopted. All countries have a national IPEC plan, Integrated People-Centered Eye Care Plan. World Sight Day is a major global event. If it goes that way in the 2030, so that we can set a kind of the milestone. It is a bit ambitious, and then we need to work harder to achieve all this. Like SDG is achieved, and then vision was considered as a critical part. And the eye health is included in the another agenda, 2045 agenda. And then there is no trachoma globally. And then the USC target like a 30% increase in cataract surgical coverage, effective cataract surgical coverage, and 40% increase in URE coverage is achieved. And then these 1 billion people who was left to access in Vision 2020 era will have access to the services. So there is every country adopted the IPCC and the plan. So this kind of milestone need to be set by every country in this new eye health strategy. So there are 10 major priority we have identified. I think I should read all, but this more importantly is a we all know that the leadership is an important part. We have developed new leadership, similarly better partnerships, and then we have to work on the evidences and prove our cases and prove accountability is very important. The priorities need these 10 priorities has been highlighted in this 2030 insight. So the most important part is the implementation of this strategy. So this strategy has to be implemented like a Vision 2020 implemented by every country. So we can complement the lot of things which has been achieved in the Vision 2020 era. And then we should make use of the best use of the global network, such as International Council of Ophthalmology, International World Optometry Union, Council of Optometry. So, and then other networks, global network, and then UN network has to be used for this implementation. IAPB and the IAPB member working at the grounds are also very important people to support these services. And then IAPB Secretariat also has a plan to support all this global network, and then people working in the ground, and also to the government to implement this strategy. So you need to develop a new approach, and then those approaches has to be, the global approach has to be locally modified, and the local context has to be adjusted according to the local context. And most importantly, to take government ownership. The government partners, government is a very important part of who is the responsible and accountable for the people's eye health. So, and then the government should convince to take this ownership of the new strategy, and then implement those SDG eye health services and embed in those SDG agenda. And then the complex system changes is there in the countries where the eye health services is a vertical, and then in the silos, the integration. So there are several roles are identified here, and then we can think of our organization role, which could be a kind of the policy dialogues, policy making, and the implementing, and then delivering the services also. So to detail program is a 2030 insight, how to translate at the national level. There is a global event has been organized, is coming up in the March 2 and 3 in Dubai. So it is a in-person meeting, also participated virtually. So we'll be discussing more detail on how to translate this on the national level eye health policy and plan in that global eye health event. So we invite you all to participate, if possible in person, of course, if not in the virtually. So because in the 2030 Dubai sessions, there is a lightning talks from the WHO, IAPB, and the UN body. And also that there is several thematic sessions in Elevate, Integrate, and Activate the eye care services, several workshops, national level workshop, and exemplary success stories our share in those in that meetings. So we invite you to participate at least virtually, if not in person, in that meeting. So finally, thank you so much for providing me this opportunity once again. And then if there are any things you would like to ask, you can access me in emails, and then you can also ask me in the panel discussion later today's sessions. Thank you so much.
between IKEA Institute and Lions Club of 306B2 to work together on public welfare. I now call upon the District Governor 306B, Lion Indra Kaushal Rajapaksha, and the Registrar, Ceylon IKEA Optometric Association Optometrist Udeni Gurusinghe to come forward. I would like to invite the chief guest, Dr. K. Selwyn, consultant eye surgeon, to come up to the stage. And also the guest of honor, Dr. Manil Pascal, the consultant eye surgeon. Could you kindly come to the stage, please? Yeah, I call upon the program director, the founder IKEA Institute, consultant optometry Naresh Pradhan also to join with.
Chairman ICA Groups, Mrs. Dhammika Desapriya, Program Director of ICA Institute, Mr. Naresh Pradhan, moderators, presenters and all participants, a very good morning to all of you. At the very outset, let me thank you for inviting me as the guest of honor for this important occasion. As it is the 15th anniversary of the ICA Institute, I wish to take this opportunity to congratulate the entire team of ICA Institute and also to wish you all the very best in the years to come. May your services to the community and country grow with each year. I am delighted I was requested to speak on a timely topic today. When we joined as trainees in ophthalmology in late 80s, there were only 2 functioning eye units in Colombo and Kandy hospitals with few eye surgeons. At that time, we used to go to eye camps to examine patients and assist cataract surgeries. Back then, eye care team performed intracapsular cataract surgeries, but no intraocular implants, as we as junior doctors enjoyed these trips and had a chance to travel island-wide. But today, after 3 decades later, we have consultant eye surgeons every corner of the country. So, one might think there is no need of eye camps. But unfortunately, right medical advice does not reach the general public at the right time even today. You might think this is the case only in rural areas. But to my surprise and shock, I have come across some patients living in areas like Borella, in the heart of Colombo, who did not visit the eye hospital at the right time. By the time they come to us, it is already too late. This is why I believe public health is a timely topic. I think it is important for us to find out why patients living in such close distance to main hospitals in Sri Lanka are not getting the medical care on time, especially in a country where health services are free. I have seen ignorance and negligence as main reasons. My observation in Sri Lanka is when elderly parents are no longer able to manage their daily activities due to loss of vision, children bring them to an ophthalmologist. Common reasons for visual loss in elderly are cataract, glaucoma, diabetic retinopathy, and macular degeneration. Of course, some patients luckily regain vision after treatment. But visual loss due to glaucoma and diabetic retinopathy cannot be reversed. These diseases cause irreversible blindness. If public health professionals can screen them in regular intervals, the patients can be directed to an ophthalmologist in early stages of an eye ailment and blindness can be prevented. At birth, babies are examined for congenital defects. At first year eye examination, congenital cataract and glaucoma can be detected. Thereafter, it is a good practice to go for eye screening every 2 years until the age of 18, so that we can prevent amblyopia due to uncorrected refractive errors. Again, eye examination every 2 years after the age of 40 years gives us an opportunity to perform refraction to correct presbyopia and check eye pressure to detect glaucoma. In addition, diabetic patients need dilated fundoscopy every year. We can stress every birthday eye examination for diabetic patients. Also, diabetic patients' children, brothers and sisters need fasting blood sugar checkup annually, maybe on their birthdays. In those regular examinations, one can pick up refractive errors, glaucoma, diabetic retinopathy, and cataract. This basic knowledge should be given to the community to save their vision lifelong. Awareness of the importance of regular eye checkup can reduce ignorance as well as negligence. Many diabetic and cataract patients do not visit the doctor until they are facing visual disabilities. In other words, patients come to us at the stage when they are blind. But by then, it is often too late to help them. We as eye surgeons want to see them early, when the first signs of visual loss appears, so that we can help them to regain vision. We want to see our patients recover well so that they can go back to their normal life. We very well understand the challenges and difficulties the patient as well as their family experience if they have to live without good vision. For patients with early diabetic retinopathy, we can treat by laser. But in later stages, patients need Avastin injections or surgery, which is costly and sometimes does not regain previous good vision. Cataract surgery these days can be considered a relatively simple routine surgery, but this is not the case in late stages. When very mature cataracts present, surgery is difficult and can cause complications such as corneal decompensation, posterior capsular rupture, etc. So it is extremely important to diagnose patients early and provide them their necessary medical care. This is where public health professionals come in. They have the capacity and ability to bridge the gap between doctors and patients, needing treatment by creating awareness. Awareness on how important it is to see a doctor at the right time. This does not only apply to eye, but to overall health. Public must understand how serious diabetes, hypertension, heart disease, obesity, etc. are. We must remember this will not only help the individual patient, their family, but also the entire country at large. Any driver or an owner of a vehicle is well aware that their vehicle needs servicing regularly at the right time. Similarly, it must be made common knowledge that one must attend regular medical checkups, including eye checkups, without fail. Imagine the time, money and energy that is wasted in our government hospitals to treat patients with diseases that are entirely preventable or manageable when diagnosed early. If a patient recovers well, they can continue working, lessening the financial burden of the family and also contribute to the economy of our country. So if we create awareness around the country, we are in reality helping ourselves and our own country. I know public health professionals are already engaged in their services with dedication and commitment. But as you can see, there is still much more to be done. So I appeal you to continue your services with enthusiasm as our country needs your help today and tomorrow. Together we can improve the quality of one more life. Wishing you, all of you, good health, strength to continue serving our country and helping our fellow Sri Lankans to live better lives. Thank you.
Thank you, ma'am, for your valuable speech. I would like to invite the chairman IKEA group, consultant optometrist, the Ambika Desha Priya, to give away the token of appreciation to Dr. Manel Pascal, the guest of honor. Thank you. We are highly privileged to have Dr. K. Selwyn as the chief guest today. Could you please have the honor of having Dr. K. Selwyn, consultant eye surgeon and who is also the president, College of Ophthalmologists, to address the audience.
Why you want me to go there? All right, fine. IKEA Group Chairman, Mrs. Desapriya, Program Director, Mr. Naresh, Guest of Honor, Dr. Pascal, ladies and gentlemen. I'm delighted to be in this audience as the President of College of Ophthalmologists of Sri Lanka, and this is my first outside gathering address in this year as the President. Well, now when I listen to Dr. Naresh, Mr. Naresh, the pathway of IKEA Institute in Sri Lanka, like in many other organizations, you have a very successful story. And it is encouraging, and it proves that if you are committed and if you want to serve the public, or if you want to do some good work, you have a pathway and it is possible all the time. I know the IKEA is providing a major service in the country, especially educating the youth and providing opportunities for them, the working opportunities. And in addition to that, the service component that you do, especially in the primary health care, prevention of blindness. Well, I think as a college, we all appreciate that, and I know that the public also appreciating equally, and they are benefited much from your institute. Well, optometry is an independent profession. We all know that. It's like another profession, like ophthalmology. But on the other hand, optometry and ophthalmology and other paramedical professionals, they all work for a common goal, common service. So we cannot be, though it's by definition it is an independent profession, I don't think any of these professions can be independent and work alone, because we are working for a common team, a common goal, and therefore it is a teamwork that the unity and working in coordination is very important aspect in our life. So therefore it is very important for all of us to keep in mind that we will have to work with the other organizations and respect their opinions and the policies have to be made together. I know that Naresh is doing a major service in molding youngsters for the profession, and very important at the end, the very, you can't see. I'm sorry that I'm not that old. It is very, it is very important that your molding of youngsters to behave in the society as professionals. We have ethics, we have to follow the professionalism, and this industry, this is actually is, if you listen to many talks, the people come saying that the service, even the international speakers, every conferences,
Every other word when it comes to health, especially ophthalmology, it is an industry. Every other word, if you see this industry, so that itself is indicating that a lot of money is circulating and lot of money involved, money driven forces are is involved. And it is very difficult for us to walk on the pathway, very difficult to walk on the pathway without getting deviated by the motivations, by the influences of those other factors. So it is our duty and the responsibility, and we'll have to be very smart in providing the services without getting caught for the those influences, and which is not an easy pathway. And I know Naresh and many professionals here, you all want to do a genuine service to the country and to the poor. And of course, with that, you are benefited, you are respected, recognized. But on the other hand, it is sometimes it is spoiled, your genuine, the intentions are spoiled sometimes or disturbed by the people who try to come from the sidelines due to those money involved deviations. So it is very important, Naresh, to be very careful and handling the things like we all have to be very careful, especially if because we have a long way to go, our objectives are different, and the people who are getting qualified, you also have to realize and understand those things. And when it comes to the preventable blindness in the country, of course, yes, a lot of cases, most of the time, are, as Dr. Pascal said, ignorance. But I would rather add on to that, more than the ignorance, the awareness, as she correctly mentioned, the awareness is very important. Now, still people, if you ask the people who are blind due to cataract, when they come, when you ask, they say, I would say it Mahatya operation karat hariyan nene. So still we have the impression that our all when the facilities were poor, the services, of course, the outcome of cataract surgery, glaucoma treatment, and those things were not that good. So still we have the misconception in the public that eye treatment is not that advanced or not rewarding, but actually it is not. I mean, we all know that. Therefore, it is very important for us to educate or to the public regarding these services and their outcomes. So, public awareness is a crucial event if you want to improve the services. Of course, the services are at a higher level, but the problem here is reaching those services to the people or getting the people coming to get the services the other. The other issue is that I want to address is right to know by the people. And we always like to, tendency is for us to give the statements, give the status of the country and things that we and sometimes we try to highlight the difficulties or weaknesses of the service and all that. Of course, people have the right to know the information, but it has to be very careful when we have come to a different level. The Eye Care Institute, College of Ophthalmologists, we are in the field in a higher level. And then when we make the statement to the public, we'll have to be very careful that we are giving the right information, because the media is waiting for us to get the information which will be next day appearing on the headlines. But when you see, sometimes it is not absolutely correct. It is misleading the people. So we'll have to be very careful when addressing the public the right informations, because people have the right to know the right. And further, I would like to say, actually, when you look at the progress, the way that you have organized this, and a lot of international organizations have come into work together, and I am sure that I can see a very successful year in this year as well. So I wish you, Eye Care Institute and everyone, a very successful new year, next year, and to serve the country together with other people in the eye care services. Thank you very much for inviting me again, once again.
හක්ෂ විශේෂඥයින්ගේ සංගමේ ගරු සභාපති තැන්පත් හක්ෂ විශේෂඥ කිසැල්වින් මෙතුමයි ඔබ ඇමතුවේ. ඉතාමත්ම සාරවත් හරවත් ඒ වගේම යථාර්ථවාදී කතාවක් එතුමා විසින් අපට ඔබ ඉදිරියේ දැනුවත් කරා. ඉතින් එතුමාට අපේ ගෞරවනීය ස්තුතිය. මේ අවස්ථාවේ මා සිලෝන් නායිකා දෘෂ්ටි විශේෂඥයින්ගේ සංගමය ඒ වගේම අයික්‍යා ජාලයේ සභාපතිනියට ඉතාමත්ම ගෞරවයෙන් ආරාධනා කර සිටිනවා එතුමාට සමරු තිළිණයක් ප්‍රදාන කිරීම සඳහා මේ ස්ථානයට පැමිණෙන ලෙස. ස්තුතියි සභාපතිතුමිනිය. උදෑසන සිට අප සියලු දෙනාම එක රැස් වී සිටින්නේ මහජන අක්ෂි සෞඛ්‍ය අන්ධ බව දුරලීම අයික්‍යා 2022 අයික්‍යා ආයතනයට 15 වසරක් පිරීමේ සාන්වත්සරික උත්සවය වෙනුවෙන් ඉතාමත්ම අවශ්‍ය දේවල් මේ තුලින් සමාජගත වෙනවා. ඒ වගේම අප මේ ශේෂ්ත්‍රයේ සිටින අය විදියට අපේ යුතුයකම අපේ වගකීම මේ තුලින් ඉෂ්ට වෙනවා. ඉතින් මෙතෙක් වෙලා අපි සමග ඔබ ගත කළා. දැන් මේ අවස්ථාව තමත්ම ප්‍රණීත තේපැන් සංග්‍රහයක් සූදානම් කර සිටිනවා. ඒ සඳහා සහභාගී වන්නට කියලා ඔබ සියලු දෙනාටම ගෞරවයෙන් ආරාධනා කර සිටිනවා. විනාඩි 15ක් තුල නැවතත් අපි මේ කටයුත්ත ආරම්භ කරනවා. මේ සඳහා පැමිණෙන්න
Good. We need our moderators onto the stage. To commence the session, we now have Dr. Amelie Alves, the consultant eye surgeon child eye, who will share his experience and useful suggestions on ethics on patient care, an area that has to remain in the forefront to the actions of all of us. It's over to you, sir.
Thank you very much. Also, thank you very much to the organizers, Naresh especially, for giving me the chance to speak today. And it's always an honor every year to contribute in some way to your conference in any way I can. Now, my talk was actually meant for the second session. I asked Naresh to advance it, so it doesn't really fit in with all other talks. But I thought it's a good talk to talk about before we get into clinical management and taking care of our patients. We've got to know exactly what to do and what not to do. So that's why I thought medical ethics is something really not focused too much upon in general in Sri Lanka, but I know Naresh and the curriculum here are quite strict and lay a quite important emphasis on it. I'll just not go into too much detail, just speak a few minutes about what I feel ethics is and why it's important, right? Okay. Good. So, like you see here, generally there are more pillars, but the 4 pillars of medical ethics includes autonomy, beneficence, non-maleficence, and justice. So these are the areas that we are going to talk about, and these are generally areas that relate to healthcare and medicine definitely. But if you really think of it, how we sort of get along in day-to-day life, no matter what profession, is based on these few areas as well, right? What we do, we need to do properly. So the areas are, number 1, non-maleficence. So now this is a very simple thing, do no harm, and always spoken about as the initial pillar of ethics, possibly due to it being what Hippocrates spoke about. He said, first of all, do no harm. That's the first step, and that's why it's always spoken about initially. And the important thing is, in our area of work, possibly not, even if patients request it, we've got to stick by this, that we do no harm, and we've got to remember that this is a constant. This is not something that will change from situation to situation, case to case. Do no harm stays the same, and also, most of the time, it's by an omission of a harmful action that we achieve this pillar of medical ethics. Now, more relevant to us would be beneficence. So that means you've got to cause a benefit to your patient, right? So now this is connected to a certain extent with non-maleficence, but at the same time, this is a more active thing. It's not a matter of omitting something, it's a matter of doing something positive. It's a active contribution to the patient's well-being. There are different thresholds which we'll speak to you about soon, but the important questions I like to ask is, will this treatment or will our option of management resolve the patient's medical problem? Is it appropriate? Is it proportionate to the medical problem, right? For example, nowadays when we talk about antibiotics, generally the trends become that we give the most powerful antibiotic to make sure everything gets better. But is it proportionate, right? At the same time, is it compatible to this individual's circumstance? That's important to see as well. And is it in line with what the patient expects from treatment? If you ask these few questions, generally you will be causing more benefit and less harm to the patient. Now, autonomy is the third pillar that we speak about. And here what we talk about is that the patient has the predominant decision-making responsibility for treatment, right? So you cannot impose, no matter how good or effective you think a treatment is, you can't impose this, or you can't force this treatment on the patient, right? And remember that the patient ideally should be actively involved in the investigations, the diagnosis, and the treatment of the condition. And now here what happens is the questions that we've got to ask are, we've got to explain fully the condition that's caused the problem and the treatment options available. And we've got to make sure whether the patient can retain this information and evaluate it. So if it's a child we are speaking with, we generally feel that we can't expect the child to do that. Our parents got to be close by. Or if it's an elderly patient, you've got to have a bystander who can understand and evaluate and remember the information close by. And what happens is, in certain procedures, we've got to make sure that the patient provides informed consent, right, to the management that we are going to be talking about. Now, justice is our fourth pillar, the last pillar here. And here, it's more to think about whether the treatment that we are offering, is it compatible with the law? Is it violating any of the patient's rights? And is it fair and balanced, right? So you've got to remember that this is where approvals come in. So certain medications available, certain treatment options available in other countries may not be still approved here. You've got to stick with the law that governs our treatment protocols in the country that you're practicing in. And also you've got the justice also applies, I suppose, widely even to the context here is that no one is unfairly disadvantaged when it comes to access of healthcare, right? So you've got to make sure that everyone has a chance to get at least very basic healthcare, and that's part of what justice talks about. Now, any questions, any contributions or comments on these four pillars? So I'm just going to, and I'm sure you've sort of spoken about this, you've heard of it, but it's always good. Remember that when we talk about it, right, it's that you need not be an expert in medical ethics, but you've got to understand the very basic concepts in managing your patients. That's number one. At the same time, you've got to realize that these medical ethics are a constant, irrespective of your personal philosophies, your political background, your religious views, and moral theories, or what your life stance is. These ethics would be the common ground for us to manage our patients with. So, in continuing, also we've got a few ethical ideologies that we can speak about. The first one, it means, the end justifies the means. So meaning that if you know that there's something at the end of it will be beneficial to the patient, it allows you to carry it on initially even if there's harm. For example, now we mentioned right at the beginning, cause no harm first. Now, if you are doing a surgery, you've got to make that initial cut in the skin. Now that's causing harm. But then if you just leave it at that, then that's just harm without much benefit. If you proceed with the surgery, and then that eventually gives the patient a better outcome functionally, and patient's life has benefited, then the end justifies the means. You can resort to that little bit of harm because the patient benefits. The next ideology is, again, very important in the context of optometry as well, is that you've got to consider the wider society. So that's what, ICARE, I know, does on a very regular basis. It's not about the individual, it's not about that one patient, but it's about looking at the bigger picture of with the resources, and nowadays in Sri Lanka, resources are limited in terms of finances, personnel, that expertise. So we've got to see what's the best way to use these limited resources for the benefit of the most number of people, right? And of course, there are other etiologies. You use the correct course of action that's dependent on your duty and your rights, and that's exactly what your code of ethics also speaks about. Now, taking all this information and maybe converting it into a more practical way, we are people who deal with patients, right? So we've got patients, and it's not only the final treatment that has to abide by these rules that we spoke about. I really would think it's an advantage if you can identify the whole patient's treatment process, and every one of those things have to fall in line as well. For example, the build up to the appointment, right? I mean, how easy is it for the patient to meet you? The information, the directions, that's something that's got to be easily accessible to the patient. The appointment itself, right, has got to abide by those principles that we spoke about. And once we have explained the condition to the patient and a bystander, and once they understand the benefits of all the different options, and once we've individualized the option according to this patient, they need to be able to give consent about how they are willing to undergo the treatment. And if something is beyond the expertise, those four the pillars would also encourage you to refer this patient to someone who's got slightly more expertise in the area. And it doesn't end there. I mean, a patient comes to you, follow-up is really important as well. I mean, it's not something done very regularly, but just a message or something routinely just to find out in a month or two, depending on the condition, what has happened to the patient and whether everything is okay, would be a nice way to end that one appointment in general, right? So you can apply those ethical pillars to every step of this patient, appointment pathway. Now, having said all this, I feel that we all got this inner conscience. Now, this inner conscience is what tells us whether what we are doing is right or wrong. I mean, if we are driving on the road, we suddenly cut lanes and cut the other person off. We do it. We can come up with reasons why we did it. We were in a hurry, whatever it may be, but we know inside that this is not the right thing we've done. So we've got this moral compass in us, inside, telling us what is right and wrong. I suppose if you can be aware and you can follow that, a lot of the ethics, the pillars are covered, right? And what happens is you've got to have a sufficient knowledge base in the area of expertise to make that sort of decision, right? So the inner conscience, remember, guides us in how we speak, in what we say, how we refer this patient. It's there, it's inside, but we've got to have enough knowledge. And I mean, a very simple rule that I would always employ with my patients is, do to the patient like you would done to yourself, right? We've all had a visit to a doctor for whatever reason, with our parents, ourselves, our children, and we know how annoying a 3-hour wait for a doctor can be when you're not feeling well, when you've got a sick child with you. So I think you can just easily put yourself in your patient's position, and then you will know the right decisions to make ethically, right? So again, if you like being explained and you like being told about a condition, do the same for your patients, right? So you've got to have the same bar of expectations that you have for yourself and your family for the patients that you are treating, right? And also, I'd like to end by saying it's very important to realize that most complaints, and even if it goes the further step further, and even legal action, which is not very, very prevalent at present in Sri Lanka, but is getting there. So most complaints and most legal action cases are when there is an alleged breach of one of these principles of medical ethics. So, I mean, hopefully not, but even if whatever happens goes to a legal court of law, basically the judge will be seeing whether you broke any one of those ethics, and if you haven't, generally okay. If you've broken one of those pillars, and then that's where the problems start. So I know that there's been a lot of emphasis given by, definitely by Naresh, by the curriculum, by a code of ethics, to how exactly you should, follow your moral principles should function when you're dealing with patients. And I mean, it's very important. Like I said, this is important for any profession, all the way down from the top of, where all our parliamentarians and how ethically moral they are, we know, all the way down to, whatever job you do. I think if you just follow certain ethical principles, your job becomes more relevant, it becomes more satisfying, and whoever you're serving ends up being happier. Thank you very much. I would like, if there's any questions or any comments, Naresh, anything you'd like to add to what I've already said? I mean, even if you've got questions and things aren't 100% clear, I mean, at least the introduction to these pillars and exactly learning more about it. I mean, this is a very, very small summary. This is possibly an entire course or a 6-month program if you want to do it in detail, but knowing that it's important and knowing that you need to just read up, look, even a video or two about this area would be a good idea. Any questions? That's right. Yeah, I mean, definitely, right? So I would always end my consultation with I mean, it's become a habit now. With every single patient, I'll always ask them, do you have any more questions? Then they can't actually go back and say that, I had a question, then the doctor didn't answer it. Generally, the answer is no, that we don't have any questions. And then there should be also, even if at that time, if they can't ask any questions, or maybe they go home and they start thinking about other things, they should have a channel of communication that they could communicate with you and say, okay, I didn't have any questions at that time, especially before a procedure or anything like that. I have these questions that they should be answered. But you should, like you said, I mean, sometimes these questions, when patients ask us these questions, it really feels irrelevant. I mean, doesn't not very associated or significant the questions are. But they're questions. I mean, and you've got to remember that these patients who we are dealing with are lay people. I mean, they don't have the same knowledge and expertise that we do. So we've got to give them time. And of course, you will have certain patients, when you ask this, they'll just keep asking question after question. You'll have the occasional patient, but I think if you allow the patient to ask whatever questions they want at the end, it will be a complete consultation.
Thank you, Doctor.
Okay. Thank you very much. Thank you for your attention.
Thank you very much, sir, for your interesting presentation as usual. I'd like to invite Chairman Ceylon IKEA Optometric Association, Optometrist Nissan Salah Fernando, to give away the token of appreciation. Next we have Optometrist Milan Fernando, Optometrist Darshika Devendra, and Optometrist who will enlighten us on the subject of discovery.
Good morning, ladies and gentlemen. Thank you very much for having me here today. It's a great honor to be here with you all. Thank you for your participation. It's been a long day. I would like to take a few minutes from that. Before starting off to the presentation, I would like to ask two questions from you all. I hope you will give 100% attention to me. So let's go into the first question. And my first question is, can you please raise your hand? How many of you are optometrists here? Thank you. Most of us participating here as an optometrist. So my second question is, from this crowd, how many of you are dream to become an optometrist from your childhood? Can you please raise your hand? So you all can see the results. This is what is the real fact in Sri Lanka. Most of us says, I want to become a doctor or an engineer or a nurse or a pharmacist. But nobody says that I want to become an optometrist. If you take me, I also don't to dream to become an optometrist. But today, I am really happy to be an optometrist. Nobody is choosing their profession as an optometrist. Why? Where went we wrong? For some reason, profession has chosen us. We are chosen the profession. What is the story? Rediscover today, and our topic is rediscovering Ceylon. Rediscovering. Sorry. Rediscovering Ceylon optometry education. Is there? Rediscovering Ceylon optometry education. Is there anybody knows how we are today here as an optometrist? Where we have started? If we take a look of our optometry history, as a Sri Lankan, we have to be proud. We are one of the first spectacle makers in the earth. From there, in 1952, we had a formal education system in optometry education by Honorable Albert Edri Singh. He got down two scholars from England and introduced licensed dispensing optician course in Sri Lanka. And after then, 10 years back, in 1962, one of the oldest optometric association in South Asia, which is called Sri Lanka Optometric Association, is formed. And then in 1982, School of Ophthalmic Technologies was formed in Eye Hospital by Dr. C. Parker under the Ministry of Health. In there, the optometry education is limited only for government staffs only. So, what about others? What about private sectors? There are no institutes for study who are willing to study optometry. For that reason, the new era begins in year 2007 with the establishment of IKEA Institute. IKEA Institute opens the door for everyone who are willing to study optometry. IKEA Institute is the first government recognized private institute. So, this is the pathway that we are going through in optometry education. But still, nobody is choosing their profession as an optometrist. Why? From here, I would like to invite my dear friend Milon de Lanka Fernando to further continue to the presentation. Thank you for the great opportunity. Thank you.
Thank you, dear Darshi, for handing over the presentation. Thank you, dear Darshi, for handing over the presentation just right me. I'm really happy to you have this opportunity to make a present about rediscovering of salon optometry in front of you with the 5 questions today. So, I'm Milon de Lanka Fernando. following optometry course at IKEA institution. So to identify the optometry education in Sri Lanka, we got 5 questions from the person who are working at the same field. What I mean that optical shops. So these are the questions that we have to follow from the person. First question, let me show you right now. When did you come to know about optometry? This is the question. This question I will ask from Galadari. What about you? That when is the day? So when did you come to profession? Yeah. Thank you very much for that. Thank you very much, Darshi. Let me show you the first question. So when did the company know about optometry? Actually, look at this one. Large part of this pie chart shows that 61 of them, when did they come to know about optometry profession after school? Actually, we don't talk about the optometry at the school, and we don't choose the optometry as a profession today at the school. So however, the 21% of them, when did they come to know about optometry profession at the school? Why? Because choose they know the person who are working at the optical shops. That is the reason they know the optometry profession at the school. So however, 13% of them while working and 5% of them other. So other mean, so following university courses and something other, that duration they know the profession at. So then please, second question. How did you come to know about optometry? Actually, how did they come to know about optometry? So look at this pie chart. The large part of this pie chart shows that most of them, how did they come to know about optometry? From family members or relatives. Unfortunate incident that we have come from by family. It has already business only in Sri Lanka. That is the reality that we have to understand. And 28% of them while working at optical shop, and 24% of them from person who is at the optical field, and 6% other. So let's move to the third question, please. What information have you heard about optometry? Oh, optometry is hired to cause enrollments. This question I'm asking from my dear Mokshala Bandara. What about you? How about medical profession? That is my answer also. I chose this the medical profession. Why? Because the optometry is a profession that involving examining eye and defects and something abnormalities. That is the choice I selected this as a medical profession. However, look at this one. The large part of this pie chart shows that 38% of them, they heard about optometry respective profession that we have to understand. So 28% of them eye care services and related job, and 20% of them medical profession. So that is the thing that right now. So what was the perception of the optometry among your family members or relatives? Take me an example. So most of them students are following the optometry courses, but their parents has no any clear idea about optometry. Maybe they have no idea also. However, look at this pie chart. 42% of them, their perception goes to respective profession. Again, we have to proud. This is a respective profession. And 21% of them IKEA services or related jobs, and 16% of them medical profession, and 9% of them other. So let me show you last question. Ladies and gentlemen, this is the last question that I want to say. After enrollment into the optometry course, what is your perception of the optometry and how it is different from what you already knew? I got many things about optometry. I got many things, maybe clinical side, maybe dispensing part, and many things I got. Part of this pie chart shows that 24% and 29%, they differ the how is know about depth of the knowledge in this course. Thank you very much. I'm inviting to Mokshla Bandar to continue this presentation. Thank you very much.
Seven hundred years of history and our first in optical industry. A huge step was taken by Honorable Mr. Albert Edrisinghe by establishing optometry education in Sri Lanka. But in 2022, where can you and me can stand as an optometrist in a scale of recognition? Good morning, ladies and gentlemen. I'm Mokshila Bandara, following optometry course at IKEA Institute. To begin with, considering myself, I went to an international school and I have never got my eyes checked, which most government school students are privileged of, at least once in 2 years. I have never heard of a profession called optometrist. I didn't know that such profession exists. Where did we went wrong? In my childhood, in our school days, we all raise our hands to say our future dream is to become a doctor, a nurse, a pharmacist, engineer, or a businesswoman, including myself. Let's go into the, we have compared optometry with few paramedical professions here. So as you all can all see, optometry and MBBS. Both are independent professions as well as prescribers, which pharmacists and nurses are not. MBBS gives you a salary of more than 100,000, which also can be earned by being a successful optometrist. Optometrist gives you flexible working hours and is specialized in the field, which other comparisons are not. MBBS and optometrists open the doors to do the doctorate, but still optometry is not a chosen profession. Leaving a question, why optometry is still not a choice of our generation? Why aren't our parents still dragging us to become an optometrist? They always want us to become a doctor, engineer, or other profession, but not an optometrist. I'm handing this question to the audience as well as the honorable panel, and I would like to wind up by calling upon optometrist Asha, optometrist Saki, and optometrist Rashmila to comment about public awareness on eye health. Thank you all for joining with us and contributing your support to IKEA 2022. Thank you.
Hello. Okay. Good morning, everybody. I am Lion Optum Rashmira Ratnayaka. First of all, I would like to warmly welcome you all here, this wonderful occasion. Before we get started our presentation, I would like to suppose some question for you. Please answer them. This is very important for our presentation. I think here we all of have 5 senses. Am I right? No? Okay. Out of these 5 senses, I want to know which sense is the most important for you. You can see that our screen, the senses. I need to know which sense is the most important one for you. Okay? We are moving now. Okay. Just tell me, how many of you think the vision, How many of you think the smell sense is the most important? Can't move. Can you raise your hand, please? Somebody thinking the smell sense is the most important sense? No one there, no? Okay, we are moving next one. The next one is the taste sense. Anybody think the taste sense is the most important sense for your life? I think no one there, no? Okay. The other one is touch sense. Anybody think the touch sense is the most important for our life? Okay, good. The other one is hearing sense. Ladies and gentlemen, are there anyone for hearing sense? Anybody? Anybody is there? Okay. The final one, the vision sense. How many of you think vision is the most important sense? Please raise your hand. Okay, wow, it's nice. Thank you. Thank you for cooperating. It's nice to see. Okay. Now we saw here, most of us think most important sense is the vision sense. But now we have another question here. Our Sri Lankan people really know about this valuable sense? Do you have any idea our Sri Lankan people awareness level about regarding the vision? As IKEA Institute student, we done wonderful research about this topic. The topic name is Why Wait to See? Why wait to see? Without taking too much of time, I invite my dearest Kali, Lion Optum, Ahmad Shaki for further details. Thank you for listening and cooperating.
Thank you, Lion Optum Rasmila Ratnayaka. Although each and everyone selected vision is the most important sense, do we as a Sri Lankan give the priority for our eyes? Good morning, good afternoon, good evening, all of you. I am Optum Lion Ahmad Zaki from Bandarwala, located to Uva province in Sri Lanka. First of all, I want to grab your attention. What is Sri Lanka? What is the current health situation in our country? Let me give you a quick review about my country. Sri Lanka is an island surrounded by the Indian Ocean, and we call it is the pearl of the Indian Ocean. It covers 65,610 square kilometers, 9 provinces, and 25 districts, with 14,022 Galadari divisions. 22 million population all over the country, and my country has ranked 84th in 2021. If you look at this Human Development Report, the HDI value of 0.782 as on 2019, which is the highest in Asia. Not only that, the infant mortality rate is 6.1 deaths per 1,000 live births. And if regarding the life expectancy, around 77 years as on 2019. When we compare with the SAARC countries, we are one of the best healthcare system in the world. Why I say this? My country has achieved commendable health status and measured in terms of traditional health indices gross domestic product. And again, we provide the free universal healthcare for the public. Only one of the few countries in the world with the free healthcare and free education, of which have been national priority for decades. We have provided free ambulance services using toll-free numbers and 24-hour emergency treatment unit available. And also we have a very regular vaccination system from the period of pregnancy until the age of 13. Not only that, we are #1 country which is perfectly breastfeeding for the infant. When we consider about the prevention of COVID-19, which is headed by Ministry of Defense, and we could manage it very successfully within a short period of time. Regarding the education and literacy, which is the higher for the both gender, as 93.2%, which is more than any other Asian countries. Although everything seems perfectly fine, but still we are unfortunate. Why? Because we are representing world's worst eye healthcare system. Let me show you how. We have 1.1 blind rate, which is the highest in Asia. And we have more than 350,000 cataract patients waiting in a queue for surgeries. According to this chart, which is prepared by Eye Care Institute on 2019, we don't have a sufficient eye care professional in Sri Lanka. And according to the B program, which is conducted by Eye Care Institute on 2016, we have 5 major barriers in eye examination. So there we were prepared some more questionnaires for the public. So we as Eye Care Institute decided to do a research on public awareness on common eye diseases in Sri Lanka 2021. So let me show you the questionnaires. So, and now my colleague Lion Optum Asatilini Rajakarna will explain you further regarding this research. Thank you for listening me.
Thank you so much, my dear Lion Optum Ahmed Saki, for opening my door for this valuable discussion. Good morning, everyone. I am Lion Optum Ashatilni Rajakaruna, representing the most historical city, Kandy, which is placed in Central Province. Today, I want to share what we have found from our research regarding the awareness on common eye diseases in Sri Lanka. So, as my colleague Ahmed Saki mentioned, we have prepared a questionnaire with very easy question and simple questionnaire from 3 languages, Sinhalese, Tamil and English, and also it covered all the provinces in the country, and also we did it with no barriers in age, ethnicity, occupation or gender. And also mostly we did this research through the social media, and also we collected some data from oral investigations too. Finally, we could collect 131 responses for our research. So without taking much time, let me show you what we have gathered as the result of our research. From these 3 slides, you can see we have asked, have you ever had your eyes examined once in your life? And how frequently an adult should go for an eye checkup? And also, when a child should have his first comprehensive eye checkup? From these first 3 slides, we got to know that nearly 80% of population in Sri Lanka has not done their first eye examination yet. And also, most people don't know that they should go for an annual eye checkup. And also, most people don't know that their kids should be accompanied to their first eye checkup at the 6 months of their age. If we move for the question we asked about regarding the cataract, what is cataract? We have got 118 correct answers, so it is 18.7 percentage. What is the treatment for cataract? We have got 164 correct answers, so it is 25.99 as percentage. If we consider the question we have asked regarding glaucoma, what is glaucoma? We have got 123 correct answers, so it is 19.49 as percentage. For the treatment for glaucoma, we have got 92 correct answers, so it is 14.588 percentage. If we consider about the question we have asked regarding amblyopia, we have got only 13 correct answers, so it is 2.06 in percentage. For the treatment for amblyopia, we have got only 19 correct answers among 631 participants, so it is 3.01 percentage. If we consider about the questions asked regarding the diabetic retinopathy, we have, what is diabetic retinopathy? We have got only 230 correct answers, so it is 36.45 in percentage. If we consider regarding the treatment for diabetic retinopathy, we have got 86 correct answers, so it is 13.6. If we consider about dry eye question, what is dry eye? We have got only 14 correct answers, so it is 2.21 percentage. If we consider about the treatment for dry eye, we got 56 correct answers, so it is 8.87 in percentage. So, I think you all can clearly understand what is the awareness level we have in our country. Actually, I think you all agree with me that it is a very pathetic condition. So, without taking much time, I would like to say, I think you all agree with me that when we are finding answers to this question, the best mantra we can provide is increasing awareness level. Actually, why I say like this, by increasing awareness level, actually we can reach our goal within very short time period, and also it is very cost effective, and also it is very convenient. And also we believe that prevention is better than cure. According to my colleague Ahmed Saki's speech, he mentioned that we have the very best healthcare system among the world, but so we know that we are spending more money, more effort on curing patients. I believe if we are allocate the money we are spending for curing the patients, at least if we can allocate only 1% from the money we are spending for curing to the increasing awareness level, it will be very fruitful in this pathetic situation. And also, without taking much time, I want to submit that we have few recommendations, few suggestions to this valuable distinguished panel. So let me submit our suggestions. Number one, please make an urgent government action plan Yes. Please make an urgent government action plan to increase the awareness level of each and every citizen in our country, and please uh, let them be aware regarding what we have, the resources we have, like National Eye Hospital and each and other every places. Actually, we know that they don't know that we have available these facilities in our country. And also, please utilize the government media. Please utilize to increase awareness level of our citizens using government media. Actually, we can see all around the world, lot of countries, they are using the government media for increase the awareness level regarding the eye health. But in Sri Lanka, we only can see that we have awareness programs such as breast cancers, regarding the childhood cancers, and smoking under the health ministry instructions, but there is no one for eye health care. But why? And also, I want to tell that we used to celebrate each and every festival and every valuable dates in our schools with the school's children. But why don't we suggest them to celebrate the World Sight Day too? And also, I know in each and every our government offices and the private offices, they used to celebrate each and every festivals and the important days. But why don't we push them to celebrate the World Sight Day too? Actually, it will be very useful to increase our awareness level. So finally, I think this is the most suitable time to hand over this timely topic to our distinguished panel here today. Actually, we have a lot of valuable personalities regarding eye health care all over the world here today with us. And also, not only that, we have the most valuable personalities from Sri Lanka, which representing the health ministry, the College of Ophthalmologists, and also the National Eye Hospital, and also the Ceylon Council of Optometry and Orthoptics. Those valuable personalities, every personalities are here today. And also, so I would like to request all of you, please please be together in this situation and do a valuable discussion on this timely topic, and please take actions. And also, I would like to say, in this purpose, as ICA Institute, we are here, we are ready to join hands with you all to serve our country. Thank you so much. And again, for our next presentation, I would like to invite my colleague, Stephanie and Sahan Pereira. Thank you so much.
Yeah, they will be talking school in Sri Lanka, surveillance on eye health in school in Sri Lanka, a vital and crucial aspect of eye.
Good afternoon, everyone. I'm Stephanie Fernando, and I have the pleasure in presenting to you an insight to the arena of optometry. I'm currently a third year diploma student in ICA institution, and I would base my presentation as my own story. I found myself as a color vision defect while I'd been following the diploma at the ICA Institute, Sri Lanka. Even though I was checked once through the SMI program during my school days, my defect was not highlighted. So when I entered to this optometric field as a student, a practical for color vision test was done on D15 test, where I was identified my defect as a color vision defect. And thank the Almighty for giving me a chance to follow the optometry diploma at the ICA Institute, where we get the opportunity and confidence to examine each and every defect in the eye and assist the patients to their fullest satisfaction. So, I dedicate this presentation to all the future generations to open their eyes on this regard. In retrospect, an eye examination was conducted when the black and white was used and other dimensions were used to detect vision deficiency and other visual tests. Our presentation today is all about school student eye examination. So I would happy to state that the SMI program, which was started in the year 1918, was proudly introduced in Sri Lanka. So most probably, most of the developed countries also must not thought even about the school eye examination program. They do test grades of 1, 4, 7, and 10. And I would like to request from the audience to raise the hands those who have undergone the SMI program in the grades 1, 4, 7, and 10. No one is there, right? Okay, thank you very much. The analysis for this program is done by the MO with trained PHIs for these visual acuity charts. We are looking forward to pursuing this presentation, elaborating on the outcomes of the tests. A PHI test and examination is done to examine the vision and if children are found to be having a vision deficiency, the child will be referred to a hospital or a nearby eye unit, after which they will be referred to an ophthalmologist or optometrist for specific treatment and be given a solution and cure for their problem. Unfortunately, since last government, they provide nearly 20,000 rupees from the program of Suraksha to buy a pair of spectacles. We sincerely hope that this project will be successfully implemented and projected. So this is how medical eye examination take place in our country. Now I warmly invite my colleague, optometrist Sahan Pereira, to explain it further. Thank you very much.
Good afternoon, everyone, and thank you, my colleague optometrist Stephanie. And now we all know about what is the SMA program is. Especially, I'm in Gampa area, and we get some relative details from Gampa Zonal Education Department. So you can see here, coverage of SMI in Gampa District Education Zones. We get this statistics from Family Health Bureau 2019 SMI program in Gampa Image Division. You can see here, first bar chart, found visual defects in blue color line. In Attanagala division, 545, and orange color line, corrected visual defects are 281. The Dombi division, found visual defects are 478, but corrected visual defects are 0. In Gampaha division, total found visual defects are 677, but corrected visual defects are 97. Also same in Dulapiti and Minwangoda and Midigam divisions, and same as Jayala, Katana, Nigambo and Sidua division. And you see Biagam and Mahara division. Mahara division total found visual defects are 302, but no one going correct their visual defects. Also same in Biagam division. Overview of SMI in Gampaha MH division. Total found visual defects are 6,129. Total corrected visual defects are 38%. Total uncorrected visual defects are 62%. You can see total uncorrected visual defects more than the total corrected visual defects. Why is it happening? I think trainee PHI did their duty. They found that visual defects in the school students, but current SMI program haven't any follow-up system. If they are follow whether the student going their treatment or not, we can get results more than that. And the students and parents not much aware about their eyesight and eye health. We have to improve them to aware about the eye health. Okay. Our objective is visual surveillance on school eye health in Sri Lanka. For this, we have made few questions. These are the questions that we have made, and let's now look at those questions one by one with their result. Our first question: has there been an eye examination program in your school? 60% say yes, and 30% say no. 10% they don't know whether they have an eye examination program in their school. Our next question: who did the program? 56.3% say PHI did the program. 12.5% say optician did the program, and 13.13% they don't know who did the program. Do you think it is important? 95% say yes, it is important. Did your school had SMI program? 35% say yes, 35% say no, and 30% say they don't know what is the SMI program. Do you think SMI program is well enough? 75% say yes, and 25% say no. Any other eye examination program conduct in your school? 30% say yes, and 70% say no. Do you think an eye examination is a vision checking? Using distant vision acuity chart, we know Snellen distant acuity chart. 35% say no, and 65% say yes. Most of people think eye examine is only vision checking. Has there been a dental clinic done in your school? 65% say yes, 25% say no, and 10% say don't know whether they have a dental clinic. You can see dental clinic percentage is 65, but eye examination percentage is 60. We have to improve the eye examination program. I never say dental is not important, but we have to improve eye examination results. And finally, what we want to conclude is, since 1918, this SMI program is continuously processing in Sri Lanka for grade 1, 4, 7 and 10 students. And which is you can see in this statistics and result that we have found is SMI program is not happening in qualitative way. And how to improve this quality? How to make sure that every child who has a problem got a proper management and has no visual impairment. And second thing, what we have to see here is how to improve the quality of SMI by adding binocular vision test, color vision test, contrast sensitivity test, and other tests that can identify various visual defects as well. And here, the main plan is to upgrade the quality of this SMI program more than that. If it has not reached to the school end, there we have to do some surveillance and see why it isn't happening. Whether this is on the correct hand, whether these people who are supposed to do, they are the correct people to do. So finally, with all these questions, I kindly request from the authority, well-wishers, and the professionals to assess the SMI program in an outstanding manner. To assist our poor Sri Lankan students to perform their education with fine colors, ensuring their good health, providing with the spectacles to the needed ones in the field of good vision. Let us hope and that the present SMI program will be ensured and designed to meet up with the quality enhance. Thank you very much. And now I pleasure to invite optometrist Geeta Vijay Sundara to deliver her presentation on sports and vision analysis in Sri Lanka. Thank you.
So good afternoon, everybody. And shortly, somebody who has got hurt with this ball, this is what you know to that. I have just demonstrated you that throw in a ball. Today, my topic is sports and vision analysis in Sri Lanka. Very first appreciations of gratitude goes to my sister. She is also former international player, and with her help and blessing, I have managed to do this presentation. Very first thanks goes to her. And people who has given all these data, I would like to pay gratitude. All these athletes, for all those people presentation, I would like to dedicate. So, first of all, first of all, what we have to understand, I'll go through this few questions. How many of you think that a poor vision can impact the performance of the sport? How many of you think? Next, how many of the thing can cause eye injury? Can all eye injuries can be prevented? Sorry. Sorry, can all eye injuries can be prevented? How many of you, how many meetings we have every year, which athletes they may have an eye examination? Warning, this vision can impact the performance of the sports. I think this is to understand one, need not to be a eye care professional. Do our athletes, our sportsmen have taken to step to avoid the injuries? Let's go on. If you take about worldwide sport injuries, more than 600,000 sports injuries happen this world, and out of 1/3 supposed to be a small children. 13,500 people completely lost eyesight. So today our main topics on the conference, eliminate avoidable blindness. If we want to eliminate avoidable blindness, definitely sports is one thing that we have to streamline. Definitely we have to avoid the eye injuries condition to the sports, to the country, as well as worldwide. If you take about even 1200 BC, people's Jesus Christ nearly about 3000 years back. Also, this is being taken, and you can see different timeline. I don't read one by one. Look at see here. So we all know that vision is one of the most critical. Vision is one of the most critical, very important part of the players in any kind of sports. Vision not only the sight, clear sight of myopia, hyperopia, astigmatism correction. Actually, vision sport is dynamic, like because of a ball. If he does a person. Further than that, we need to see a color vision, we need to see a visual perception. We have to see whether they have to track inability, how is reaction time, and all these things, like we can train other parts of the body. We can train eye too. As an optometrist, We have looked at all these screen factors: dynamic visual acuity, eye tracking, eye-hand body coordination, peripheral vision, depth perception, color vision, contrast sensitivity, ocular alignment, eye dominance. So, looking, uh, looking at this, I told you we have taken 14 questions. First question is, have you ever had an eye examination by ophthalmologist or optometrist? It's been 6 months of a time, 1 year, or more than 2 years. If you see green, they have never had an eye examination, says 71.2%. There is about more than 1 year, 12.1%. More than 2 year, 12.5%. Less than 6, a small segment of people that they say. Let's go for the next. Are you experiencing blurred vision? The face 86.7 says no blur vision, and yes 13.3%. Are you experiencing double vision? Yes, by very small segment, which is about 5%, and nobody by majority of the people. Next, go for, are you experiencing glare vision? 96 people says no. 4% people says yes. Have you ever have problems in color? Red eyes, sorry. So then is very minor population, better yes, majority says no. This, after that, each eye, which is the significant numbers that we have to understand why and then. Experience in eye pain, so there are 8 population that always says they have. Are you experiencing headache? For nearly 20.8% population, they say yes. Do you wear spectacle? About 11.4? 11.4 people said yes. Do you wear contact lenses? For sport is very hardly 99 point no. Do expose safety eyewear? See 96%. What do you think? 1,000 people, even though this mean understood. Then 81.4 never. 81.4 they were never had an vision program. As you know that we can have training program. We can train in a vision. We can train in hand-eye coordination, relationship, and that couldn't improve their performance. That final we have to voice an opinion. Do we think mean address important? Say 92% 8 people says yes, and 7.2 they understood basics, very important. When we look at this figure, what do you understand in this whole? As well as people who are listening to us through online, we all as an eye care professional is take for the people that we are available to hear on the international leaders as the national leaders in this platform. I would like to say people, they have sacrificed their life, sacrificed the all things, and then involved in this clip and bring us the prize rather than just clapping in front of television. It is our responsibility. If we don't, brought now how many people they may have cataract, because of the trauma, how many of people then they have diabetic retinopathy, how many them they have people's glaucoma, all these things. So we have considered, and let's think if we want to eliminate avoidable blindness. This one point, very, very important point, that we have to step and make these heroes. Who has brought prize this country? Maybe pay them the gratitude. For them, may the panel on discuss. So thank you very much. Next presentation, optometrist Prabha, optometrist Kausala, and optometrist Chatuni. Thank you.
පායනා දේශය ලොව ලොබ බැඳුණු දේශය මගේ මේ රටයි සුන්දර බලනු මැනසකි ඉරක් පායනා දේශය ලොව ලොබ බැඳුණු දේශය මගේ මේ රටයි සුන්දර බලනු මැනසකි
Michael is a 54-year-old retiree from the Canali Valley estate who at one time was blind in both eyes because of cataracts. With his total loss of sight, Michael became a burden on his family and could no longer work, resulting in a loss of income.
என் பேர் மைக்கேல் நான் புளியாத்தையில் இங்கே சுக்குது புளியாத்தையில் பணிய கணக்கில் இருக்கிறேன் எனக்கு 4 பிள்ளைகள் இருக்குது எனக்கு வயசு 54 வயசு எனக்கு தொழில் செய்யலாம முறையில் போயிட்டு கண் பார்வை ரெண்டுமே இழந்து விட்டேன் அதே பிறகு தோட்டத்து டாக்டர் மூலியமாக அவர்கிட்ட சொல்லி எனக்கு 1 வருஷமாக தொழில் தான் 2 பேரும் வேலை செஞ்சால் அவ்வளோ வருமானம் ஒன்றும் இல்லை அந்த நேரத்தில் பெரிய கஷ்டத்தில் தான் இருக்கும் மிக கஷ்டமான
Good afternoon, all of you. I am optometrist Prabha Pereira. I hope you all enjoy this video, isn't it? Okay, thank you. Now let's move to the topic. Our main topic is human resource and eye health of Sri Lanka. Before entering this topic, I would like to take you all a tour around our beautiful motherland. Our motherland is the pearl of Indian Ocean. This wonderful land is blessed with Tutrilikan, the footprint of Lord Buddha. And also, this land is full of natural resources. Many more creations done by ancient rulers are marvelous. I believe that Sri Lanka is an extremely fascinating island among tourists. Although we are lucky to have these resources, most of the Sri Lankans' mentality has brought up from their childhood as we are a small country, developing country, and many more negative ideas. Sri Lanka is a country with a unique and a proud historical record of great civilization, a culture of achievements spanning over a period of several centuries before and after the birth of Christ, which by comparison cannot be second to any contemporary civilization that existed in the world. Actually, there are a lot of countries smaller than ours. There are more developed countries which the literacy rate less than ours. And also there are so many countries healthcare system is poor than ours. We should be proud on these points, how strengthful we are. Apart from this, when we turn towards into eye care system in Sri Lanka, we have a proud history that when none of the Asian country had. We started our Sri Lankan Optometric Association in 1961. Although we have a developed healthcare system, but still our eye care system is much poor when considered with other countries which are developed or developing. I am sorry to say that we are still unable to have good eye care system in Sri Lanka. Sri Lankan's population is 21.9 million. Out of that, our blind rate is 1.1%. Sri Lanka is politically divided into 9 provinces and 25 districts. Now I will invite my colleague optometrist Kosara Jayasinghe to continue this presentation. Thank you and enjoy the rest of the presentation. Thanks.
Thank you, Optometrist Prabha. From my presentation, I would give a brief idea about the current eye care system in Sri Lanka. So according to the WHO, there are supposed to be one ophthalmologist per 100,000 patients and one optometrist per 10,000 patients. So going to that standard, let's go through the data that we have collected in 2020 of 9 provinces in Sri Lanka. Below, we have mentioned how many ophthalmologists and optometrists that we need to fulfill the WHO standard. If we go through Central Province, the population is 2.7 million and the blind rate is 1.87. The patients per ophthalmologist ratio is 154,000 to 1 and patients per optometrist ratio 63,000 to 1. Eastern Province, population is 1.7 million and blind rate is 2.67. Patients per ophthalmologist 249,000 to 1 and patients per optometrist 87,000 to 1. The North Central Province, the population is 1.3 million and the blind rate is 1.7. Patients per ophthalmologist 346,000 to 1 and patients per optometrist 36,000 to 1. North Province, the blind rate is 2.17. Patients per ophthalmologist 192,000 to 1, and patients per optometrist 41,000 to 1. Out of 9 provinces, Northwestern Province has the highest patients per ophthalmologist ratio, which is 427,000 to 1, and also it has the highest patients per optometrist ratio, which is 102,000 to 1. Sabaragamu Province, the blind rate is 1.37, and patients per ophthalmologist ratio 414,000 to 1, patients per optometrist 60,000 to 1. In Sri Lanka, Southern Province has the lowest blind rate, which is 0.29. Patients per ophthalmologist 296,000 to 1, and patients per optometrist 63,000 to 1. Ua Province, which has the highest blind rate, which is 2.87. Patients per ophthalmologist 346,000 to 1, and patients per optometrist 60,000 to 1. Western Province, blind rate is 1.21, and patients per ophthalmologist 150,000 to 1, and patients per optometrist 33,000 to 1. So here we have analyzed all the data into one chart. There we can see Northwestern Province has the highest patients per ophthalmologist ratio, which is 427,000 to 1, and also it has the highest patients per optometrist ratio, which is 102,000 to 1. Blind rate wise, Southern Province has the lowest, which is 0.29, and UA has the highest, 2.87. Here again, we have analyzed all the data in district-wise. There we can see, even though Western Province has 34 ophthalmologists, still there are some districts like Mana, we don't have even a single ophthalmologist. So there we have an issue in distribution. So that's a point to be noted. So I would invite optometrist Chatuni to continue this presentation. Thank you.
Thank you, Optum Kosala. As my friend Optum Prabha said before, although we have a better healthcare system, still our eye care system is not satisfactory. As we all know, optometric education was started in 1953 at Vidyodaya Pirivena. And also, when none of the Asian countries had, we also had the Ceylon Optometric Association in 1961. Though we have a proud history on optometry, still our blind rate is 1.1%. The major problem for this is lack of facilities and resources to outcome the situation. Most of the rural areas in Sri Lanka has no eye units at their hospitals. Even they have no opportunity to travel far for getting their eye tests done. As Optum Kosala said before, lack of ophthalmologists and optometrists are a major issue for the situation. The graph shown here illustrates the blind rate in South Asian countries. Just have a look at Nepal and Sri Lankan blind rate. Here I took Nepal and Sri Lanka comparing because the population is much similar when considering with the other countries. So even populations are much similar within these two countries, the blind rate, there's a huge gap in blind rate. Blind rate in Nepal is 0.32%, while Sri Lanka is 1.1%. Our topic is human resources. So let's move on to the topic. According to Community Eye Health Journal, which was published in 2018, they say that there are no any optometrists, while only ophthalmologists are in Sri Lanka, while the formal optometric education was started in 1961, as I mentioned before. Not only that, the Ministry of Health is conducting optometry since 1982. At present, there are 400 plus optometrists in Sri Lanka. My colleague, optometrist Kausalya, has already proved it on this stage before. So, how can it come to say that there are no any optometrists in Sri Lanka? While we are already having 400 plus optometrists at present. The above chart shows the ophthalmologist and optometrist needed to fulfill the WHO recommendations. The necessity of total ophthalmologists are 121, while the optometrists are 1,758. Here it shows the action plan for the WHO target in 2030. Sri Lankan government has to release 15 ophthalmologists in each and every year. The optometrist count must be increased from 450 to 2,200. The challenge is to develop the primary eye care system in Sri Lanka, which must be completed 3,750 within 9 years of time. Now let's go for the solutions to overcome the situation. Here you can see the LVPEI pyramid, which has been continued in India and also have been succeeded within few years. Mainly, this pyramid is based on volunteers which goes to the society and do screening by going to their doorsteps and referring to vision centers. Here the process continues through Eye Care Institute. We have already trained over 600 volunteers at present. We hope government will join hands with us to success the process. The next level is vision centers, which conduct by community to screen the eye. Here, Eye Care Institute has named the process as Community Eye Care Centers, which we have already established 3 units at Kandy, Moratuwa and Gampaha. This is the process to continue according to LVPEI pyramid. As Eye Care Institute, we already have started the base. Today, most of the eye care professionals are present here. As professionals, you, me, and we, all of us, are responsible for the eye health in Sri Lanka. So I invite you all to join hands with us to overcome the challenge we are facing to get a better health eye care system to Sri Lanka. Here are the references which we have used for our presentation. I would like to invite optometrist Nisansala Fernando to present her presentation on this stage. Thank you.
Thank you, optometrist Chatuni. Good afternoon, everyone. Today I am going to talk about glimpse on optometry practice in Sri Lanka. Optometry practice in Sri Lanka has been so variable. There are people who have no formal education. That goes as a family business, or they have worked in certain optical shops and certain period of time. They started on practice. Optometry practice in Sri Lanka again has formal education, different level as we know, a foundation level, certificate level, a diploma, high national diploma, masters, BSc holders, and doctor in optometry people also in Sri Lanka. Practice in Sri Lanka, it's go back to 400 years. We have started making spectacle as well. We had a formal education since 1952, and Ministry of Health started optometry education for the public sector since 1982. This has to be further stimulated to make optometry be better. I hope after this glimpse we will understand the current situation and hope there will be better guideline, a better way for improvement. With this intention, in 2017 we had a conference called Colombo Declaration 2017. In 5 years ago, we had a discussion on role of an optometrist. If we see who participated on this conference, we can see College of Ophthalmologists, different stakeholders, eye surgeon, optometrists, opticians, different other associations. So we together discussed on what kind of role should have in optometrists. So the role of optometrist, the idea is all about how to stimulate the optometrist practice and how to gradually take optometry to regulated. Additional to that, we have done major steps with the TVC developing national competency standard on optometrists and opticians. It is already in function. We should not forget that IKEA Institute, the first institution to introduce Code of Ethics for the optometrists in 2009. I am proudly seeing a gradual improvement and today I am going to present the current situation on the optometry practice in country. If you take an optometrist, his or her primary role as the primary eye care professional is refraction. Refraction can be divided into two parts, which are objective refraction and subjective refraction. Refraction, as you all aware, we have done a research in order to understand the glimpse of optometry in Sri Lanka, and below are given based on the research. Object refraction, we have taken autorefractor, retinoscopy, keratometer, corneal topography. Subjective refraction, we have taken Ducrum test, JCC. We received response of 497. Out of 497, 400 who were performing autorefractor, and less than 100 people out of 497 used retinoscopy, and limited number of people using corneal topography and JCC. Ducrum test was performed by less than people who were performing retinoscopy. Some of them are not performing JCs and Ducrum. Most of the people who were performing the retinoscopy, they had some formal education. So without autorefractor and retinoscopy refraction, the refraction is very little segment of people performing refraction. So people who cannot perform in retinoscope, the majority of they have autorefractor meter to the refraction. So this is Patrice of optometry in Sri Lanka is quite in a sense of equipment point of view, the business point of view, finance point of view. It is relatively better in South Asian region. If you take binocular vision assessment, only out of 497 people, only 58 people respond. They perform by visual assessment. Binocular assessment, we have taken RFA accommodation test, ARA, PRA, fusion test, Herzberg test, Kingsway test, and stereo accurate test, and worth for light. So majority about them, they were performing Herzberg test and the worth for light test. If you see, have number of few people performing fusion test, and so this is what is the condition out of 497, only 58 people responding on performing binocular test assessment. Even number of people who has gone through a formal education, also very limited number of people performing binocular assessment. So it's come to slit lamp. If you take out out of 497, only 52 people they have slit lamp. Out of 52 people, of majority about them, only very limited people using slit lamp. Most of all have slit lamps, but most of places, optometrists perform the slit lamp and the tonometry. So only for them, they have been having these equipments. But personally, these optometrists or those people who have practicing optometry has formal or no formal education, they are not using. The very, very limited people, they have been using tonometry and TB-UT test. Even graduates, BSc holders, master people, even doctor in optometry people will also practicing optometry, but tear breakup test not being practiced. So most of them are interested on refraction and making money from spectacles. If you take about fundus evolution, out of 497 people, only 126 people respond on this. So other no response on this. And it's you can see only 98 people, very limited people who are performing ophthalmos scope. Almost 76 people are performing out of 497 people. Fundus photography are performing by very limited people. OCT definitely very limited. You can see here the number of people who are performing ophthalmos scope and slit lamp, and still we can feel some places they have ophthalmos scope, but they are not performing by themselves, but they are keeping ophthalmos scope with them. If we take about color vision test, we can see here Ishihara chart, 15D test, 100 hue test. 100 hue test have not found anywhere other than National Eye Hospital, Colombo. And 15D test has been performed by very less number of people, and Ishihara chart is performing by 195 people out of 497. Now we are going to talk about visual acuity. We have taken logma, K-pictures, OK drum, construct sensitivity test. If you see here, 18 people out of 497 responded on this. A majority in these 18 people performing logma, but who were performing logma also not performing construct sensitivity test. Very limited people performing an OK drum test not visible. Again, if we say visual field test, we have taken confrontation, Amsler chart, AF. Confrontation test is performed by 111, 112 people. Amsler chart is used by very limited people and visual field performing 22 people out of 497 people. Next one, contact lenses batteries. RGP lenses are very limited people performing. Soft cosmetic lenses widely practicing in optometry field. But soft contact lens out of 497, 353 people have good response on that. But if come to toric soft contact lens, we can't see the very little number of people performing the toric contact lenses. So majority of people are practicing cosmetic lens or disposable contact lens. Next, low vision batteries. Out of 497, very limited number of people performing low vision. We can see 8 people out of 497. Now next, ancillary test. We can take an Amsler chart, OCT, pupillary reflex, smear test, AB scan, tonometry. You can see the response out of 497, 154, 155 people performing pupillary reflex, AB scan, smear test, tonometry are very limited. With this, what we understand is practicing optometry is in Sri Lanka is basically a reflection and very little limited, very little diagnostic practice done by very limited people. Unfortunately, formal education having people also limited only for refraction. Because refraction making better money, and as a result we can say number of batteries they are kind of dispensing rather than the clinical things we can see. We can see gradually newcomers and more formal education will bring these batteries into a more clinical setup and more researchers in future. With this hope, I will end my presentation. Maybe in next 5 years of time, if I do the same presentation, I hope these figures will alter. I wish we will have a better optometry practice in Sri Lanka. Thank you very much for listening to me patiently. I invite optometrist Lahiru and optometrist Deshamani to the next presentation.
Thank you, optometrist Nisansala. I am optometrist Deshamani Amrasinghe. So today my topic is occupational ocular health and safety standards in Sri Lanka. So when that comes to occupational ocular health and safety, we conducted this conference in 2019, and out of that we have been abstracted this one because of this presentation we want to manage in 10 minutes of time. So we extracted very little portion from there. So you all know that occupational ocular health and safety. we have to understand is now mainly the occupational other industry workers. Now they know where they have gone from home, where they have should return back home. This is the basic principle that we should have. But unfortunately, in Sri Lanka, there is no proper occupational health and safety guidelines according to National Institute of Occupational Health and Safety. Also at the moment, what we do some extent follow the ISO standards and those sort of things. So what we again thought of highlighting this is how important that ocular health and safety part when we are developing a standards. Especially every occupation has their visual standards. So there should be visual standards, whether it is a sport, whether it is a garment, whether it is a pilot, whether it is a police, or whether it is a teacher. Some extent, this topic, what we are going to discuss about is how these standards and how we can need to improvise or whether we can improve this. So if we take about in every 5 to 10 seconds of time, there were workers who are caught temporarily or permanently disabled. So then if you take according to statistics, 2.2 million people every year there is some kind of occupational health illness. In Sri Lanka alone, if you take about, there are but more than 4,000 accidents are reported every year because of occupational hazards. So why this is happening? One point we have to see in is when these people are taken for the job, whether we have specific standards for the vision is there or not. Whether their vision or other parts of the body can cooperate with their particular job. So they are physically fit or not. They are visually fit or not. So physical part I am not going to add here. Mainly visual part is discussing. Now I would like to invite my brother, optometrist Lahiru Malinga Rodrigo for further discussion. Thank you.
So thank you very much, my sister optometrist Deshamini Amarasinghe. So good afternoon, everybody. I'm optometrist Lairo Malinga Rodrigo. So first let's take teachers. Okay. In Sri Lanka, teachers' visual acuity should not be less than 6 by 12 in each eye. Right? So if one eye 6 by 6 and other eye can 6 by 18 vision. But very interesting thing is this. I don't know any other part of the world has or not. So if the prescription is stronger than plus or minus 6, their application rejected. I don't know with plus or minus 6 in somebody even have 6 by 6 vision whether they are suitable this to do professional or not. Is there any issue rather than that whether the teachers other part of visual standards we have to improve like color vision, binocular vision, those things are not tested still. So whether we have to improve that factors their teachers can perform the job more precisely. This is one thing we have to consider. So let's take driver. Okay. Okay. So every country has some kind of vision standard in driving, right? So even in Sri Lanka also, we do have visual standard of 6 by 6 for the heavy vehicle and 6 by 9, one eye and 6 by 12, other eye for light vehicle. So this standard actually College of Ophthalmology Sri Lanka has recommended. So they have even recommended there are should be what kind of visual field, whether the color vision has to be tested, diplopia has to be tested, and whether patient has nystagmus, blepharoplasm, this standard has been given. But still, motor traffic department, they have not followed this recommendation has been given by College of Ophthalmologists. So they have recommended there should be white kind of visual field, whether the color vision has to be tested, diplopia has to be tested, and patient has history, those of things. And but still, motor traffic department, they have not followed this recommendation has been given by College of Ophthalmologists. So still what we do is heavy vehicle 6 by 6 and light vehicle 6 by 9 and 6 by 12. No visual field tested and no other part also tested. So recently, every day in Sri Lanka, road 10 to 12 dead road accident. According to Motor Traffic Department itself, you can see this chart. Here, see the significant numbers of accident is taking place because of the eye problem. So I don't know why even the one of the highest level of eye professional given a recommendation, why they couldn't follow this. So this is still, this recommendation has been given for years. Still this recommendation as it is pending. So let's take other professional pilot. So everybody of we know from the childhood, we know to be a pilot, you have to have a very good vision. So see what kind of vision that people occupational demand for. So standard, according to Sri Lanka standard, pure vision should be with or without correction 6 by 6 or better, and binocular it should be 6 by 6 vision. So and refractor error should not accepted. Should not exceed more than +3 or -3, and also emmetrope maximum meridian should not be more than +or-2 astigmatism, and that if it is anisotropia is not, should not be more than 2 diopter. Visual field tested, very good, and color vision also tested. So here what consider is, so all these standards are very good. But what we have to consider is whether binocular vision should be tested for these pilots when they are landing, when they are take off. So binocular vision definitely important part of pilots. So what I feel we have to definitely consider for that. So at this moment in Sri Lanka, binocular vision not tested for pilots. So we have a very proud of army. So we have, with their dedication, we have completed 30 years for domestic violence in this country, and we are today free because of our army. So let's see what is the standard for the armies in this country. So visual acuity should be 6 by 6 and 6 by 9 on the other eye. Color vision also tested, and that should be without the spectacle. And so other than that, other contrast, those things not tested. So this is just I am highlighting here is because of one thing what I consider is this has to be re-energize this thing. So let's take now Navy. So what is the standard? Navy standard is 6 by 6 visual acuity and color vision should be perfect. So what about the other things? What about the eye tracking, those things? What about the dynamic mission? I think we have to reconsider this thing. So if it takes Air Force again, Air Force visual acuity and color vision. So visual field not mentioned, eye tracking is not mentioned, binocular vision being not mentioned. So we have considered these things. So finally, what is very important is if we want to make our workplace safe, there should be proper producer. So finally, what I would say is today conference is all about public eye health and how to eliminate the avoidable blindness, right? So to avoid avoidable blindness, the large portion that we can see in this occupational ocular hazard. So ocular hazard is one of the major part which can be avoided, right? So I hope the panel will take constructional this and we will look forward these things. So thank you very much.
Could you kindly give a big hand to all our presenters for their wonderful presentations? And optometrist Priyanta Mahanama and optometrist Anura, thank you for being here with us today as moderators. To wind up our first session, may I invite Dr. Amiladi Always, consultant eye surgeon, child eye, Dr. Prakash Podal, research and evaluation officer at Brand Holding Foundation and adjunct senior lecturer, UNSW Australia, and Ms. June Shrestha, policy and advocacy manager, IABP, to be part of the panel discussion, and that will be moderated by consultant optometrist Naresh Pradhan.
With this panel, with today, the money session will be completed. So this panel discussion, actually, whatever we have, the presentation, what we have done to now, on that base, we will be doing some, some discussion. And so especially what we want to see is, opinion on that and see what findings and what we can in future, how to improve from this point. And say next year when we discuss on the same sort of a topics, again, we may have a better result out of this. So that is the final purpose of this conference. So let's move on to this. So I think Dr. Prakash Paudel is with us. Is there? Yeah, and Junu Shrestha is there with us. Yeah, Junu, hi.
Hi, everyone.
And I've seen you on the screen. Thank you very much for being with us. Actually, as introduction was already given by Nisamani. So, right, so and then so I suppose we are going to this morning session you must have, and so we wanted to have a little cross discussion on this. and how what is your opinion on this? So, very first, what is our, this how to eliminate avoidable blindness. So, what do you think that totally comes from you itself? How do you think policy maker, as a advocacy person, how do you think how we can eliminate the avoidable blindness? What do you think? How can we do that? Can you hear me, Juno?
Yeah, hi, I can hear you now. The audio was a bit inaudible. Yeah, so talking about the avoidable blindness, as we all know that 90% of the total blindness or the vision loss in the world is avoidable. People are suffering from the blindness and vision impairment just because they don't have any access to the eye care services they need. So I think that we can eliminate the avoidable blindness by different ways. The first one can be prevention, just like early screening for diabetic retinopathy, vision screening in the schools, and then the awareness campaigns, injuries prevention. That is one of the way to eliminate it. But beyond that, the major important thing is the integration of eye care in the health systems and beyond the health system is the important way to eliminate the avoidable blindness. As when a patient he or she goes to receive the healthcare service, if he or she is referred to the eye care professionals in need, then his or her the eye condition can be managed properly. So what I think is integrating the eye health into other healthcare systems like the maternal health, elderly health, child health, like non-communicable diseases is one way, and similarly integrating the eye health with the major health system of the country, including this with the health financing, information systems. This all include awareing the people in the community to the making the services available, accessible to all, can eliminate the avoidable blindness.
Thank you very much. Actually, Tunu is actually, in a I have to follow this paper. Season of blindness, and she recently completed her master's on public health, right?
Yeah, public health and then health policy planning and financing.
That's right. So Juru, nice to see you here, and it will be, kind of for our students also, the newcomers also. That will be great, inspiration for them, you being here, because of, I talked about you a lot, right? And then, so same thing, if I ask from Prakash, Dr. Prakash, actually, he is a lecturer at University of New South Wales, and he also holds a position in Brian Holder Vision Institute. So what do you think, Dr. Prakash, how we can eliminate the avoidable blindness?
Yes. Thank you very much for this very important question. Definitely eliminating avoidable blindness is a main priority and also a challenging problem right now in the world. But what we need to be careful about this terminology is that we are just talking about the elimination of avoidable blindness, given that the population is growing and different diseases are emerging. There are different genetic disease as well. So given those circumstances, it sounds like elimination is unachievable. what we should think is about reducing the avoidable blindness, the burden of avoidable blindness. I think if we think from that aspect, then we can have a target. Like if the current prevalence of avoidable blindness in Sri Lanka is around 17% or 1.7%, that is what you said in some of your presentation. Say there should be a target of reducing that to by half in this many years. That is what the IATV has been doing once it has launched 2020 with certain goals, but they realized during the time phase that there are different factors associated with that. So now there is a new strategies as Vision 2030 inside, where they have been talking about effective spectacle coverage and effective cataract surgery coverage. So there is certain percentage of reduction for those avoidable blindness. So now, if you literally ask me whether we can eliminate avoidable blindness, I would say no. That's my personal opinion. But yes, our targets, our aim, our policies, our infrastructure, our human resources should be targeted in that directions to eliminating avoidable blindness.
This morning also we listened to ID Sapkota regarding 2030 Insight, and so we have come to know a lot about the 2030, and I suppose during the session we will have more discussion on that, and especially now as we have physically with me pediatric eye surgeon Dr. Amile Dialvis is here with me, right? And he is he's known for child vision, and he has his own practice of child eye, which is only specialized center for the child in Sri Lanka in private sector. So if you take about now what we have listened Dr. Miller this morning, we have a SMI, school medical investigation system, since 1918, right? So as we gone through the data, and we saw even from the educational department that we have got, right? So number of children that has been identified, that the most important thing is too difficult to identify them. And second thing is, once that is identified, and those children has not gone for the management. So they have not, now they have been sent to the hospital, right? Definitely the government hospital they will be sending. So they have not reached to the hospital. So in this scenario, now what happens now, there is no result out of it ultimately when we see. So what do you think, how can we improve this school eye examination, setup, right? So that we can have a better vision in our school children.
Yeah, so I think like a lot of the speakers said in the morning session, I mean, if we had unlimited financial and human resources in our hands, we can really set up a really beautiful, perfect system. But we don't. The problem is that I think, like you said, the school eye exam, the medical system, it's been in place for a long time, but it hasn't really evolved at all. So at the moment, the problem I feel is that we've got, of course, limited resources and we're not using them properly. So what I feel is that with this whole change towards even a digital thing, I don't think even a trained PHI just to check vision is not a very efficient way of doing it. I mean, you can even train the prefects or teachers in the school, and then maybe have the PHIs handling the more specialized, the more difficult part of getting these children into the healthcare system to identify their problem and treat it. So I feel that allocating, like some of the speakers said, I mean, allocating the funds, the limited funds we have to the certain areas, and then also, I mean, important thing in any healthcare system is that we don't have a trained, overtrained person performing a certain duty. You want the person who is trained at the right level to perform the duty, then you'll have the right allocation of human resources as well. But I think, I mean, we've got a very good school system going on to a certain extent compared to the region. We've also got to work on including, like some of the speakers said, not only the government schools, but because now we have a lot of children attending semi-government or private schools as well, international schools. And at the same time, we've got to work on bringing the age. I mean, it's all about school age. Now, we know that if we don't pick up certain conditions in children at even a younger age, we've got to work on, we can't be happy with this grade 1 onward sort of a screening thing. I think we need to work on awareness, on bringing this screening at a young age. And also, I think awareness. I mean, I think one of the speakers really spoke well about it. Awareness. I mean, you can identify these children, but if parents aren't aware about the problems that if you don't treat their children, this could be the result if parents are not aware about this. I mean, they've got enough financial and other economical problems to worry about. Taking a day off, take this child to school doesn't seem to be very worthwhile unless they're aware of what problems this could be in the future as well.
Thank you, Dr. Amira. It's very clear, actually, Sri Lanka, what we see is we have a policy. Now, a lot of countries, they doesn't have a policy. Say Sri Lanka has a policy since 1918, in a sense, when British were ruling here, right? So then what happens? Now, what we see is policies there, and things are happening, but not in a proper order. There is no sort of a surveillance system where whether the final output is in a correct manner that is happening or not. So it is, sort of a school examination program. Now, so there is any set of a standard that, we have, Juno, on this regard for a school examination sort of a thing?
Currently, we are developing the school eye health, which is one of the major agenda for 2030 Insight, which will be releasing soon this year. And yeah.
Dr. Prakash, you want to add anything on this? Because I see some articles on yours. Do you have anything to add on this school examination sort of a thing? Because of
yeah.
condition, now you can see due to Corona, the myopia is emerging, and you are talking a lot about the myopia and sort of a thing. So, do you want to add anything on this?
Yes, definitely yes. What I think about school eye health is usually, as we can see, I was quite happy and also surprised to see that the school vision initiative that was started in Sri Lanka very long ago in 1918, that was really a good start. But eventually what happens is, because there was a set of criteria or procedures that was set up during that time, which needs to be relooked at, that has to be modified based on the development that's happening in eye health system, the inclusion of new eye cadres such as ophthalmic technologies or optometrists, and they have greater roles in not only being in a clinical site, but also doing health promotion, vision screening, and that sort of thing. So definitely there should be some mechanism that involves every person that fits in that criteria, that school eye health environment. Then definitely there should be a process of bringing all those components into it, so that it would be easier for us to not only intervene, but also monitor and also evaluate and look at the impact of that sort of program. So that is something has to happen, which is definitely lacking. We have programs, we are running programs, but we don't know what impact it has caused and how it is running. That there are some other associated issues as well, benefits, cost benefits issues as well. So there are so many parameters linked with such provision. So that is something it needs to be looked into. Yes, you are correct. I have been in this field doing some sort of research in school eye health, not only just for refractive error prevalence, but also about the eye health literacy, how well they know about eye health and the disease, and whether they have good awareness about the benefits of wearing spectacles. These are the things that need to be discussed, and it should be built in the package so that it becomes a standard for every country. So basically, there is no difference in the developing countries. It could be 19 and 20, but yes, we are in the same page, so we should do a lot collectively.
What we think is, this presentation or this panel discussion is not all about Sri Lanka only. Actually, the people listening from Bangladesh at the moment and watching us from YouTube, or the going through the, this Zoom, or people, some of them, they are, watching us from Malaysia, from Nepal, so different countries, people are looking at this, and this will be, longer period of time, so this will be discussed. So, this is not all about Sri Lanka. Actually, Sri Lanka, when I look at, what I was a little bit puzzled about is, now a lot of people think, when the country, the people are not literate enough, or people are, financially not good enough, or people are, the transportation and those things, are not good enough, or a healthcare system is not good enough, so then people's, so then the awareness level goes down, and the blindness rate goes up, and all these things. But contrary to that, Sri Lanka has about almost 93% or plus illiteracy rate, right? Sri Lanka is having a very good transportation system. You can travel from Sri Lanka's north to south, very well established, good highways, good railway transportation. You can reach to the hospital or those things within a few just few hours of time you can reach. And education system is good, healthcare system is good, people are conscious, so even though I'm little puzzled, actually I was repeatedly thinking, why Sri Lanka has this 1.7% of blind rate, right? Which is, in compared to India or Nepal or these countries, this is much worse. And but in all aspect, if you take about education or a financial side, or a traffic, or a whatever, the road traffic or whatever segment, Sri Lanka is far beyond, right? So far front, as I told you, even policy and those things wise also, Sri Lanka has like this SMI policy and other policies also, the other these standards also quite far beyond, but still we are back. So I will come to these questions one by one. So shall we start from Dr. Amilo? What do you think about this?
Yeah, so I think in Sri Lanka, like you said, the policy, the practices have been there for a long time. But at the same time, you need organized leadership to implement these policies. You can have the policy, that's just the first step. But if you don't implement it, I mean, it's as good as not having it. Like you said, we've got all the infrastructure in place. And I think maybe there is a bit not very much awareness about maybe childhood visual issues where they need to be screened. That awareness may not be as good as it should be. I think the awareness about cataracts and the fact that, when you get older, your vision goes down, and most of it's because of a cataract, and a simple surgery could restore vision. That awareness is pretty good, I think. I mean, most families in a very rural area as well would know it. But then what happens is you've got to have the organization level to screen, pick the and as efficiently as possible do the surgery. So that's maybe where a bit of a bottleneck is. You've got the infrastructure, like you said, the healthcare, and things like sanitation, clean water. So we have all that in place. So as a result, I think from many years ago, infections as a result causing blindness is much less in Sri Lanka now. It's the majority of it would be maybe cataracts, childhood vision issues, glaucoma, and now things like diabetes on the rise. That's a problem as well. So I think it's we've got everything in place. Of course, funds and human resources always will be a limitation, but we need to just be a bit more organized in how we can screen, increase awareness, screen, and then bring these patients in for their management. If you can just tweak that just a little bit, I think we can bring those avoidable blindness rates down drastically.
Yeah. So I do, wish that same, because actually, I have, good experience, now people like some of my friends who came from Nepal, from India, when they, especially now say Yashwant Sauji, when he came last 2014 and 17 with us, so he was surprised. He was telling me, Naresh, if I have not, I have chosen this country first, I could have settled here. Because of, the way, the road traffic was managed, single side road, the traffic is there, other side the road, the none of the vehicle process, so that discipline that we have. Actually, so discipline wise also, we are far better. So as Dr. Oscilla says, like sanitation, low birth, so the infant mortality rates and all this wise, Sri Lanka is far better, but still, we have these figures, so which is amazing. And when we walk and ask from the public also, have you had your eye examination once in your life? So most of them, they says no. So this is what we are still puzzling on about that, and we are working out where it has gone wrong. So as Dr. Miller says, good leadership is one factor. So what do you think, Juno? The same question I have to ask to you.
Yeah, thank you, Naresh sir. I definitely agree with Dr. Emilio about the policies which are in place. But I think that there are policies, but the main thing is about the policy cycle is you plan the policy, you do it, you act it, but the last thing is you have to evaluate. So without any research, we cannot say like why is the blindness rate in Sri Lanka is very high. So we have to evaluate, are the policies being implemented? Are the people actually going for the receiving the eye health services? Because you said that there are eye health services, they are accessible, they are affordable, they are within the reach of the people, but we never know until we do a research that if the people are actually taking these services. So I think it is the responsibility now of the eye care professionals that why actually is this not happening? The research should be done, and it should be then referred to the policymakers with the evidence that, okay, these are the problems and you have to act on those in the coming modifications in the policy. And the next thing is, Dr. Norris, you said that the blindness rate is increasing so high despite all the very good facilities in Sri Lanka. I have to say that the demographic shift, the elderly population are increasing all over the world. Similarly, with the children, the lifestyle changes with the COVID pandemic, all of them are trapped inside, and the myopia, which is increasing. Similarly, the non-communicable diseases are increasing. All the demographic shift and the lifestyle changes have increased the blindness rate in the world, although we have not substantial evidence saying that these are the reasons which are causing the increase in blindness. But behind the curtain, we know that these may be the probable reasons. So we have to rule out that. As I said, that we have to reach to the population and get the feedback from them that is the policy actually working for them or not.
Thank you, Juno. And actually, Sri Lanka has a free education. Now, not only school education, actually even tertiary education is free here, right? Even campus education, even university education is free, right? So if you take healthcare system, healthcare is completely free here. Even the chronic disease medications are given free, right? Even diabetic and blood pressures and those, people if people who can afford, they can go to the private hospital, but people who cannot afford, they can go to the government hospital and get it done. So it's actually, the many ways actually Sri Lanka is a good example, right? So this is what I feel. Now, when I, very first, when I saw this public library here, and I remember I used to go British Council in Kathmandu, so right. So we didn't have a kind of a national library sort of a set concept that we don't have. So I don't know now, right? So Dr. Prakash, you want to add anything on this?
Thank you again, and I echo with Juno and Dr. as well with this regard, and yes, I completely agree that if you are launching a program, if you are having a good program or doing a good program in the community, the first priority should be, you should have a plan, a better plan, a clear objective, the objective that is measurable, okay? And once you set a certain goals or outcomes at the beginning, then you get the chance of knowing whether those outcomes were achieved or not during the time period of 5 years or 10 years. That is what it happens as a national eye health policy comes every 5 years kind of thing. So once you have a clear objectives, measurable objectives within the defined time frame, and you got to go to the community, you have to have something in the program itself called as evaluation. So that evaluation is a very important aspect. So if we are just not giving any priority to evaluation at the beginning stage, at the planning stage, then we lose that momentum. So when we come at the evaluation stage, then we don't have a good data sets. We don't have a basic baseline data, and then we are nowhere to compare data, where we were and where we are up to. So that is something it could have lacking. I'm not quite familiar in that context. I may have to look into the papers and the policy documents as well. That is something I would feel that we should have such program that should be measurable, could be evaluated in certain time periods, as well as what I felt just listening those presentations in the earlier session. I was quite surprised that the Ceylon Optometric Association was established in 1961. And since it's the very oldest association probably in Southeast Asia, or even, I don't know, it should not be for US and Australia, but yes, it should be, of course, for South Asia. Having that association, I can see something lacking in terms of developing the optometry and vision science skills, or developing programs that trains a suitable eye care cadres that meets the changing need of the country. We can't just stay in 1918. We have to move. We have to now in 2018, almost beyond 2018. So in a century time, the needs are different, the technologies are different, the problems are different, and there are so many people to look after the programs. So it is not just a single medical professional that can tackle everything. So we need all the helping hands, all the supporting hands. So that is where I was just kind of puzzle. I have a puzzle, or I have a confusion why it took such a long time for optometry program to be developed in Sri Lanka. So why I'm saying this is it could be one of the reasons, like not having a better trained eye care professionals, or not giving them a leadership to build up the leadership in taking care of those community care, basic prevention and promotion kind of work in the communities. That is where we are lacking. That could be one of the reasons. That is something I would like to add on that, on top of what Junu said and what I said about the importance of research and evaluation.
Manpower. Now we had a discussion on manpower, the eye care professionals resources, what we see, the number of eye surgeons, number of ophthalmologists, and number of optometrists, and a number of other eye care professionals. When we see the number wise, actually we are having a we are having an issue. What do you so what I see is now if you take in say optometry, which was introduced in national level of, sort of there was a, program since 1982. Actually, American Optometrists Association decided to go to 35 countries, and out of that 35 countries, Sri Lanka falls in 1979. They decides, and 1982, Dr. C. Parker, who is an American optometrist, he comes to Sri Lanka and established in 1982 a college in Sri Lanka, which is known as, right? So known as School of Ophthalmic Technology, right? So which is still exists in National Eye Hospital, Colombo. So with that, up to say nearly 35 years of time, we have produced almost 300 people from there, right? So 300 people. And so the private sector recently, now after 2007, we, so ICA Institute starts, and then, so after 2010 only, the National Computer Standards develops, there is some sort of a, government recognitions, and those things comes into the scene, and then we can start recognizing things. So because of that, number of optometrists, what we have is, at the moment, is less, approximately about 400 in number. And we have around 150 ophthalmologists in this country. So this whole total of nearly about 21 million population is looked after by this, 150 ophthalmologists and 400 plus optometrists, right? Which is looking after this whole eye care profession, other than nursing and other optician and all the labels are there, right? So this is what is the real scenario. What one thing what we see, and so I would like to, ask from Dr. Amila. Now, actually, this manpower. Now, if it is, say, what I was thinking was, last time also I was talking to this tertiary education, vocational education commission people. So why don't we have a PPP with the government, right? So that tomorrow, if you want to make a next level of, say, next tertiary level of hospital, like National Eye Hospital, Colombo. So we don't have manpower. Even we get a building, we may get instruments, but we don't have manpower to do so, right? So this is what one thing we are lacking. Out of 21 million population, we have only one super station in the country, right? So this is what I was thinking. So what do you think, Dr. Amil, about this?
Yeah, I think, Naresh, I mean, like I said in the previous discussion as well, is that, I personally feel that every level of qualification you've got. Now, for example, if you've got an ophthalmologist who's trained in surgery, and then at the same time, they are also doing screening. It's a waste of the time and effort put in to train that ophthalmologist. So I mean, ideally, if you look at, let's say, in most developed countries, you'll have the ophthalmologists doing their bare minimum of what they need to do. They're mainly focused on maybe surgery and helping medically manage the more complex cases, whereas the routine screening and even the follow-up of patients with diabetic retinopathy, with glaucoma, can be done by an optometrist. So what happens is, we've got, let's say, surgeons doing screening. That really is not the most efficient way a surgeon's time should be spent. If I personally feel that, I feel even optometrists should not be spent, because they are trained, they've got good years of training, and they should be also in maybe more focused in maybe following up these patients, having their clinics where even glaucoma, diabetic retinopathy, other refractive errors are being followed up. And the screening should be done even at a less qualified level. So now at the moment, what we have is, we have the optometrist screening, ophthalmologists practicing more medical ophthalmology, and then you have a backlog of surgeons. So I think allocating the limited resources in the right place, where is most efficient, is one thing. Then, of course, like you said, you can have the facilities, but then the human. So, and I don't think waiting for the government sector to sort of fill this void is going to work. We waited, and it's not going to work because of obvious limitations. So I think there has to be a collaboration where, just like in the private sector for anything else, in any other industry, the private sector is actually the engine that drives forward that industry. So I think you need to, like you said, have a better cooperation between the public and the government, the private sector and the public sector, and where you work together. Because I think at the moment we've got enough patients. It's not a matter of not having enough patients per healthcare profession. The patients are abundant, But I think if you work together, we will all benefit. And there's a lot we can learn, private sector from the public, public from the private. And then at the end of it, of course, the patient benefits.
Thank you, Dr. Amila. Now, actually, the problem in Sri Lanka, again, Dr. Prakash, now what we are facing again is, now I don't know, now other countries too have a similar kind of a condition, I suppose. Optometry is not taken as a chosen profession. So some reason they fall into, either they have work in optical shop and then they, okay, I should follow this course, or, or their parents are doing optical, right? Or their parents are, an optometrist, and then they wanted their children to be also same. Or, very hardly we get somebody, who, some from somewhere, something, they come. Otherwise, 99.99% people, they should be somewhere in relation with, eye care industry to come into the optometry profession. So how can we enhance this? How can we improve this? Actually, to tell you fact, last year, I sent 3,000 A-level leavers. And so we told them, first year we'll give them the, so scholarship of 15,000 rupees per month without paying any course fees and those things. Second year, 30,000, and third year we will pay them 45,000, and and the finishing a course we will pay them 75,000 is minimum. So even though we got out of 3,002 applications came back, they joined with us, right? So telling them how valuable this profession is, right, and what could be their future on the whole list. So what do you think? How can we, improve this condition?
Yeah. Yeah, that's really a good question. Very relevant questions for most of the developing countries as well, because optometry is an emerging profession. So basically, if we look at the history, we are quite familiar that in our context in Southeast Asia, the program started somewhere in 1970s or 80s. So from there, optometry profession has been emerging in our part of the world. And so is the case in some other continent as well, in Africa or South America. This is a universal problem. Everywhere, that's really a big challenge to get a very good, talented students in an optometry profession. But it won't remain for a long, because with time and with the scope of practice that you can observe in your cities, in towns, the perceptions towards optometrists definitely change. But at the beginning stage, it is definitely a big challenge. So is the case in Nepal as well, since Nepal started optometry program in 1997. And since then, in the initial years, there was challenge, definitely challenge to get a good number of students sitting in the entrance exams, because we do have entrance exams selected in the course, which was not very competitive. Say every one students get admitted out of 7 students sitting in exam. But whereas that ratio has changed in the recent years, now it is 1:50, 1:60, or it could be even higher, which I'm not familiar at this stage, the latest figure, but it has changed. And one additional is we know that most of our high school graduates, they are much more familiar with the terminology doctor. So when you talk about the terminology doctor, then they are more interested in the medicine field, and engineer, then they are more into the engineering field. So that doctor and engineer takes the majority of place in that when choosing that profession. So the first intention is to get into the medicine or engineering. But when there is more competitions, then there could be a leaking of those talented people in some other professions. And once you have a good and talented students in a profession, in an optometry profession, and they understand the scope of practice, because it's not only limited to doing a vision screening, doing a refraction and examining the eyes or diagnosing and referring kind of things. There is a whole set of things, so many subspeciality in optometry to practice. Which we know, but they don't know. And we also know that there is a scope of doing research, scope of doing into the health economics, policy planning, and also getting into the statistics and doing ophthalmic epidemiology research, get into the leadership role in WHO, IAPP, or NGOs, INGOs, and different institutions. That should be the way that pathways to go forward, which definitely those young generation, young minds, they don't know that pathways. So that pathways somehow has to be shared in a different platforms, given the scope of practice. Yes, we have to say optometrist is not equivalent as a medical profession, but yes, there is a pathways of doing a doctorate of optometry where you can be a doctor of some certain skill sets. That is somehow that message has to be passed, and same message has to be passed to the parents who are much more very much what you say, they are more keen to know that where they are leading, where their children are leading. So they should know that the scope of practice of optometry. Once this happens, then eventually the things will change. So in Sri Lanka, from diploma of optometry, it's been just recently, there is a Bachelor of Optometry program, and it will take a few years of time. But within those few years of time, whoever are produced as an optometrist, they should be trained very well in different subspeciality. They should not just speak about doing refraction and examination. They should be doing contact lenses, low vision, binocular vision, or sports vision, so many specialties. And I would like to give more address, more importance in research as well, because when I look into what is happening in Sri Lanka, when I search the papers or some documents, I hardly find 5 or 10 papers in the international journals or in good archives. So if those presentations that earlier some of the colleagues they presented their findings, research findings, which are very preliminary. They have been just reporting a frequency, just a descriptive statistics. They have to learn, slowly they have to learn the better statistics, the advanced statistics, and build up those skills to upskill themselves so that they can become policy makers, they can become changers, innovators. So that is how we should link this. So it's a holistic approach. So it won't change within a year. So you should learn from other countries as well, from your other countries in South Asia, from the very developed countries, what's happening there. You have to keep in eyes, and you have to just share those informations to the broader audience as well. So these are the ways to tackle that problem.
Yeah, thank you, Dr. Prakash. Actually, it was a nice insight. And number of, now relatively numbers are increasing, true. Now say we have much bigger number coming up now. That's, again, as I told you, now most of them are from the same industry. That is what is our pathetic situation is. So, Juno, you want to add anything on this?
I completely agree with Dr. Amilo and Dr. Prakash. They have much elaborated a lot of things they how to tackle with the issue. Just to add on like few lines in this, the first thing is the term optometrist. As Dr. Prakash said, that people either know doctor or they don't know any health professionals. So I think we have to resound or echo this term optometrist to the general public, that your eyes are being treated by optometrist, and so that they will be aware that okay, my health professional is an optometrist. So that way also some kind of awareness can be raised in the public about the optometrist career, and people can choose to be an optometrist and not a medical professional. I think so. And the next thing is the career options in the future. So as any country, they plan for producing optometrists or eye care professionals in their country, they must have the plan for the deployment and their upgradation in the future. Otherwise, the problem that Nepal is facing currently is the brain drain, that a lot of optometrists, they are traveling abroad seeking the higher education or for working abroad because of the problem in the planning of or the deployment or the employment in the future. So that should be in place, and that can also be an attractive point for the early comers who want to choose the optometry. And the last thing is in addition to the recognition by the government, this optometry profession should also be recognized by the fellow health professionals. So when they know about optometry, they will refer their patient to optometry. When they know that optometrists are there for neuro optometry, they are there for geriatric pediatric optometry, then they will refer their cases there. So one thing is the specialization. Optometrists, they do their own thing by themselves, do their specialization, but at the same time, it should also be recognized by the fellow health professionals. Yeah, I will add only these things.
Yeah,
Thank you.
thank you, Juno. And then we are already at 2 o'clock in Sri Lanka, right? So I think Prakash Paudel, Dr. Prakash, what is your time there now at the moment? What's the time now?
It's 7:30.
Half
7:30.
Yeah.
7 p.m.
So I think, it's time to, wind up because of we are already back from the it's nearly about 20 minutes. We have already, back from the program. So thank you very much, Dr. Prakash. Juno, thank you very much for being with us. And Dr. Amiladi Albis, thank you very much, sir, for being with us. And I think there are a few more questions left, but no time, because the time has been already 2 o'clock. So we will wind up here. So thank you very much for all of you. Thank you.
Thank you so
Thank you for this.
much.
ස්තුති
Thank
ඩොක්ටර්
you.
ප්‍රකාශ් පවුඩේල් ජූනු ශිෂ්ටා ජාත්‍යන්ත්‍රය සිට අප ඇමතු ඔබ දෙපළට ස්තුතිවන්ත වෙනවා. අද දවසේ මහජන අක්ෂි සෞඛ්‍ය අන්දපුරලීම උදෙසා පැවැතු මේ කාර්යභාරයේදී යෙදී තිබෙන්නේ දිවාහාරය සඳහා අවස්ථාව ලබා දීම. ඉතින් ඔබ සියලු දෙනාටම ඉතාමත්ම ආදරෙන් ආරාධනා කර සිටිනවා කියලා. ස්ටෝල් තිබෙනවා, ගිහිල්ලා බලන්න. බලලා තවත් විනාඩි 20කින් පමණ මේ ස්ථානයට පැමිණෙන්න කියලා ඉල්ලා සිටිනවා. ස්තුතියි.
Check, check, check. වසරේදී මට IKEA ආයතනය හමු වෙන්නේ. මෙතෙක් නොවද අධ්‍යයනයක ඔප්ටිෂියන් සංඥ වෛද්‍යවරුන්ගේ සම්මන්ත්‍රණයෙන් සහ නිරන්තර පුහුණුවෙන් ලැබෙන පිටුබලය ඉතාමත් වැදගත්. පරිගණක තාක්ෂණයෙන් ඇස් පරීක්ෂාව, රෙටිනස්කෝප්, ඔප්තල්මස්කෝප්, OCT, HPF වැනි අතිනවීන උපකරණ වලින් අක්සි දෝෂ සොයා ගැනීම සඳහා සුවිශාල කාර්යභාරයක් කරන ඇඹිලිපිටිය ප්‍රධානම ආයතනයක් ලෙස මහානාම ඇස් කණ්ණාඩි ආයතනය සඳහන් කරන්නේ IKEA සමාජිකයෙක් ලෙස ඉමහත් ආඩම්බරයෙන්. IKEA ගමන් මගේදී විහාර මහාදේවී උද්‍යානයෙන් ආරම්භි ඇසෝසියේෂන් එක ආයතනයේ ලොකුම ශක්තිය වුණා. දියවැඩියා දිනය, ලෝක දෘෂ්ටි දිනය, ග්ලූකෝමා දිනය යන පාගමන් තුළින් ජනතාව දැනුවත් වෙද්දී අලුත් අවුරුදු උළෙල, ක්‍රිකට් තරඟ, නත්තල් උත්සව ආදීන් අන්‍යෝන්‍ය බැඳීම් ශක්තිමත් වුණා. අක්සි සායන පැවැත්වීම, ඇස් කණ්ණාඩි නොබිල්ල ලබා දීම, දන්සැල් දීම, ගම් වතුර ආධාර ලබා දීම ආදී සමාජික කටයුතුවලදී IKEA ආයතනය පෙරමුණ ගත්තා. මේ සුවිශේෂී ගමන් මගේ නියමුවන් වන අපව මේ තැනට ගෙනා IKEA නිර්මාතෘ ප්‍රවීණ දෘෂ්ටි විශේෂඥ
Hi, I'm Prabha Mani, practicing as an optometrist at HMS Silverdam Opticians Giant. I was one of the first batch of students at IKEA Institute, which started in 2007 at Fatima Church, Malta. Gradually, number of students, activities such as IKEA Urdu annual trip, Christmas party, cricket match, and also activities like awareness programs, school programs increased. By 2009, National Competency for Optometrists developed. It expanded the curriculum and clinical programs to reflect the changing demands of the contemporary optometry practice. This is the first institute registered by the TVC and government accredited to award the NVQ qualifications. IKEA Optometric Association had been the voice of IKEA Institute graduates' political and legal stability. I had the privilege of being a past chairman of IKEA Optometric Association. I was awarded the fellowship for the dedication and commitment given for the success of the association. Also, currently, I am counsel representing IKEA Optometric Association at Ceylon Council of Optometrists and Orthodontists. I thank IKEA Institute for educating me to build up my professional career as an optometrist. I congratulate IKEA Institute as it has reached its 15 magnificent years of vision service by January 2022. All the blessings should go to the creator of IKEA Institute, Program Director, Consultant Optometrist, Narish Pradhan, and Group Chairman, Consultant Optometrist, Lanka Deshapriya, for the excellent and dedicated leadership.
Test. Check one. Test one. Check. Check one.
I wish IKEA Institute all the success in their future endeavors in order to achieve highest levels in optometry education and community IKEA services. Thank you.
Check this one.
ආයුබෝවන් මම ඔප්ටොමෙට්‍රිස් ප්‍රියන්ත මහනාම ශ්‍රී ජයවර්ධනපුර විශ්වවිද්‍යාලයෙන් ශාස්ත්‍රවේදී උපාධිය හදාරන මම පුහුණු ගුරුවරයෙක් ලෙස ජීවිතය ආරම්භ කරමින් දෘෂ්ටික් ශේෂ්ත්‍රයට පිවිසෙනවා. 2007 වසරේදී මට IKEA ආයතනය හමු වෙනවා. මෙතෙක් නොලද අත්දැකීම් සමග ඔප්ටිෂියන්, ඔප්ටොමෙට්‍රිස්ට්, ඩිප්ලෝමා යන පාඨමාලාවන් මම එහිදී හදාරනවා. එහිදී හමුවන මුළු ලංකාව පුරාම විසිරී සිටින දෘෂ්ටිවේදීන් සමග අපගේ අත්දැකීම් බෙදාගෙන වර්ධනය වන සුහදතාවය අතිවිශාලයි. විශේෂඥ වෛද්‍යවරුන්ගේ සම්මන්ත්‍රණයෙන් සහ නිරන්තර පුහුණුවෙන් ලැබෙන පිටුබලය ඉතාමත් වැදගත්. පරිගණක තාක්ෂණයෙන් ඇස් පරීක්ෂාව, රෙටිනස්කෝප්, ඔප්තල්මස්කෝප්, OCT, HPF වැනි අතිනවීන උපකරණ වලින් අක්සි දෝෂ සොයා ගැනීම සඳහා සුවිශාල කාර්යභාරයක් කරන ඇඹිලිපිටිය ප්‍රධානම ආයතනයක් ලෙස මහානාම ඇස් කණ්ණාඩි ආයතනය සඳහන් කරන්නේ IKEA සමාජිකයෙක් ලෙස ඉමහත් ආඩම්බරයෙන්. IKEA ගමන් මගේදී විහාර මහාදේවී උද්‍යානයෙන් ආරම්භි ඇසෝසියේෂන් එක ආයතනයේ ලොකුම ශක්තිය වුණා. දියවැඩියා දිනය, ලෝක දෘෂ්ටි දිනය, ග්ලූකෝමා දිනය යන පාගමන් තුළින් ජනතාව දැනුවත් වෙද්දී අලුත් අවුරුදු උළෙල, ක්‍රිකට් තරඟ, නත්තල් උත්සව ආදීන් අන්‍යෝන්‍ය බැඳීම් ශක්තිමත් වුණා. අක්සි සායන පැවැත්වීම, ඇස් කණ්ණාඩි නොබින්න ලබා දීම, දන්සැල් දීම, ගම් වතුර ආධාර ලබා දීම ආදී සමාජික කටයුතුවලදී IKEA ආයතනය පෙරමුණ ගත්තා. මේ සුවිශේෂී ගමන් මගේ නියමුවන් වන අපව මේ තැනට ගෙනා IKEA නිර්මාතෘ ප්‍රවීණ දෘෂ්ටි විශේෂඥ නරේෂ් ප්‍රධානන් ගුරු පියාණන්ටත් IKEA අධ්‍යක්ෂක ධම්මිකා දේශප්‍රිය ගුරු මෑණියන්ටත් මම හදවතින්ම ස්තුතිය පුද කරනවා. IKEA ආයතනයට ඇතුල් වීමට සිටින සුවහසක් සිසුන්ට මතක් කරන්නේ ඔබගේ අනාගතයත් ඉතාමත්ම ශක්තිමත්ව ගොඩනැගීමේ කාර්ය IKEA ආයතනය බාර ගන්නා බවයි. ඔබටත් මටත් ජීවිතය දෙන IKEA ආයතනය තව බොහෝ කාලයක් දෙස් විදෙස් සිසුන්ට සෙවන සදමින් වැඳෙන්නට හැකි වේවායි 15 වන සංවත්සරයේ සමරන මේ මොහොතේ මම සුබ පැතුම් එක් කරනවා. ස්තුතියි.
Hi, I am optometrist Nisansala Fernando, chairman of Ceylon IKEA Optometric Association. I am practicing at Tidex Optical in Kandahar. As we are marching towards celebrating 15th anniversary of IKEA Institute, let me express my gratitude in below manner. I started my career in 1999. It was my family business. Although I entered into the optometry world, I knew nothing about the optometry until I joined IKEA Institute in 2007. At that time, there is no proper place to study optometry. This is the first legal institution in Sri Lanka where I learn ins and outs of optometry. The respect should go to our mentor, our guru, optometrist Naresh Pradhan and optometrist Dhammika Deshapriya Madam for founding this STEAM institution. IKEA Institute, you made me stronger, educate me, you made me fearless, you taught me leadership and to take any challenges in optometry field as well as in my personal life. After school education, you are the best institution I found in my life. I am very proud to be a IKEA student. For me, IKEA Institute is a God gift. Thank you IKEA Institute, what you have given me. I love IKEA Institute and I wish you all the very best for your 15th anniversary. I always with you. God bless. Thank you.
Check. Test one. Check one. Test one. Check. Test one.
Hello everyone. I'm optometrist Udeni Guru Singha, the registrar of the IKEA Optometric Association, practicing in Net Optometrist in Colombo. It's my great pleasure to congratulate the IKEA Institute on its 15th anniversary. IKEA Institute is the first private optometry college recognized by the government of Sri Lanka under the vision to be the leader in professional IKEA organization by improving the quality, quantity of service providers in all IKEA segments in the region. As a novice to the profession, I gained the theoretical as well as the practical application knowledge through the IKEA Institute. The strength, the courage, and
Check
the
this one.
experiences I had from the ICA Institute was a big milestone in my path of success. So, I'm delighted to thank my dear sir, the founder of ICA Institute, Mr. Naresh Pradhan, and Madam Damika Deshapriya, the group chairman, for creating the best optometry and visual science institution. And as a proud student of the ICA Institute, my heartfelt congratulations on the 15th anniversary celebrated under the noble theme of Public Eye Health Eliminate Avoidable Blindness. Thank you.
Hello everyone, this is Rajiv Prasad, Secretary, Indian Optometric Association, Vice President, Asia Pacific Council of Optometry, and Governing Board Member of World Council of Optometry. Friends, we all are aware how important vision is for one life, including physical health, social engagement, education, employment, and socio-economic position. Whereas reduced vision, a person's ability to perform daily activities and increase person risk of other health problems and also may lead to premature death. Feeling of being dependent in all respect economically or related to loss, mobility or productivity is definitely a big challenge. Unfortunately, vision health is rarely included in public health programs designed to prevent and manage chronic diseases because of limited resources and competing procedure. Vision impairment and blindness are public health problems because they not only affect the lives of large number of people but also cause a large amount of disease, disability, economical burden and reduced quality of life. I'm so glad to learn that Eye Care Institute along with Ceylon Eye Care Optometric Association is hosting Eye Care 2020 on 30th of January 2022 in Colombo. And the theme is so relevant in current scenario, public eye health. I also came across alongside that the Institute is celebrating 15 years of its completion, which doubles the celebration. Friends, I wanted to meet you all in person, but due to pandemic, I could not do so. I'm sure that this conference would inculcate knowledge on public health and would emphasize on the importance of preserving vision and eye health and take you all to a tour where you would get to learn more on reduced modifiable risk factors, how to improve timely detection of diseases leading to visual impairment and management of such cases of eye disorders. This conference will also give you a fair idea in recognizing the fact of 2.2 billion people who are living with visual impairment or blindness, out of which at least 1 billion have visual impairment that could have been prevented and is yet to addressed. Let me congratulate Team Eye Care Institute under leadership of Dr. Naresh Pradhan and the organizing team. My connection to Sri Lankan optometry is way back from 2007 when I had first met two wonderful optoms and great human beings who work passionately for optometry and holding the baton of profession in Sri Lanka, Dr. Dasanta Fonseca and Kumari Fonseca. This is while I was working with Special Olympics International as a Asia Pacific Health Manager and also had an opportunity to work with them for quite a while. It is so heartening that management of institute envisioning the transforming happening globally in eye care and geared up on the upgradation of optometric students and professionals and giving them opportunity to play a key role. Friends, I'm sure that Eye Care 2020 will prove to be a great conference for all professionals of Sri Lanka and neighboring countries who is excited to witness deliberations of all stakeholders on single goal of eliminating avoidable blindness at this platform. I wish all the best to the organizers of Eye Care 2020, Eye Care Institute, and I'm delighted to be a part of it virtually and hope that this conference would be a milestone and would hook up with Global Health Targets 2030 as shared by WHO on 74th World Health Assembly, which is integrated people-centered eye care including preventable vision impairment and blindness. I hope that the day would prove to be the best platform for all the delegates and rejoice the knowledge fest on recent updates on research, clinical, public health at iCare 2022. Once again, I wish all the success of the great conference and looking forward to see you all sometime soon in near future. Till then, have a great conference. Take care, stay safe. Thank you.
Hi everyone, I'm consultant optometrist Lanka, practicing at Colombo. I started my career in 1994. In 1998, I joined large optical chain in Gulf, Yatim Optician in UAE, up to 2004. On that time, I realized how important optometrist's role in optical practice. I joined ICAP in 2009. I completed all the level up to diploma in 2016. My optometry college first accredited institute in TBC, which followed guidelines, curriculum, and syllabus under recommendation of WHO. ICAS took a major part in the optometry industry to achieve the NV2 qualification, with support to all the level of eye care industry have a government recognition. After study, we need our welfare, legal protection and update study for the pass out students. We started ICA Optometric Association as associate member, director, honorable treasurer, ICA Optometric Association register. I contribute my level best to association in my period. I initiated ICA Optometric Association logo, ICA Institute and ICA Optometric Association common flag. I gave leadership to many ICA events to complete successfully. This all contribution for ICA Optometric Association granted me ICA fellowship. This is what I reach highest position in association. We approach to make a one platform among the profession. Sri Lankan Optometric Association, Ophthalmic Technologies, Vision Care, Eye Care. We all contribute equal power in one organization. It's called CCOO, Ceylon Council of Optometry and Orthopedics. As a member, director, now I'm honorable treasurer in CCO. This all achievement, what I reach, wish, guide, and push my ICAP program director, Naresh Pradhan sir. I'm delighted to congratulate ICAP. You're wishing my best wishes on celebrating 15th anniversary on 2022 January. It's my great pleasure greeting as a pass-out student, a member of college. It's effort to uplift optometry education in this profession. I'm highly appreciated and honor proud past 15 years. It has expanded with the changing and demand of optometry practice. It's reflected all the level of ICAP, profession and other organization. Blessing of Triple J, ICAP.
I am optometrist Ranjit Premratna of Nethil Optometrist, which is located in the middle of the ancient city Anuradhapura in Sri Lanka. I was the past president of the Ceylon Eye Care Optometric Association. The Eye Care Institute was formed in 2007 to train optometrists. Eye Care Institute is also awarded with QMS 9001-2008. This is the first and foremost private optometrist training institution in Sri Lanka. I have been learning in this institution since 2007. The efforts of the Eye Care institution are to teach human eye anatomy, physiology, human eye disease, pharmacology, eye protective precautions, the art of the how to handle equipments and first aid. These complex and vast subject matters are taught theoretically and practically with much simple methods. The optometrists who were nourished from this institution saw their professional performance in the locally and internationally. I am proud to be a member of the first batch of Eye Care. I think this is my second school where I improved the professional knowledge of the eye and its protection. I could have reached the following benefits to myself and society. I was able to have awareness programs and eye clinics, hospitals in rural areas, in the universities, in the government offices, and the non-government institution. Those are some example. I think this is my golden age of 35 years profession. Now I have experienced the community relationships at a large scale and a good status in the society. So being a member of the IKEA, I can do better service to the nation. According to my point of view, the IKEA is not only an academic institute, but also it's a home sweet home. We all live as a family. We share our joy and woe. It is a platform to achieve all kind of talent and humanity. Now I bring my warmest wishes to the 15th anniversary of the IKEA. Thank you very much.
Hi, I'm Yuresha. I'm very happy for giving me this opportunity to address you on this occasion of 15 years completion after opening the IKEA Institute and the valuable service done to the general public during this period. I have completed 25 years in this field as an optometrist since 1997. After joining the Albert Edison Opticians laid the basic foundation for me. I have further improved my knowledge and experience after joining the IKEA Institute in the year 2007 with 5 other students. I followed the dispensing opticians course. It was a very happy day in my life, as we have never followed a similar course as no any other place available for same. I vastly improved my knowledge and practical experience working under our Guru, Senior Optometrist Naresh Pradhan, who is the master in charge of the IKEA Institute. I am happy to say that how we improve our knowledge daily. The other students who join vastly also getting the same benefits. In addition, now there is an opportunity to follow diploma in optometrist course. In addition to the optometric knowledge, we did social work, having eye camps to serve general public also. We arranged picnic, New Year Day, Christmas parties and cricket matches. We got the opportunity to meet all the optometrists and build our friendship and distribute among them our knowledge and experience, and also to help each other whenever it is necessary. The knowledge and experience I got from the IKEA Institute helped me to build up my future career with better prospects. It was a big help for me to join the eye and ENT hospital and to work with job satisfaction. From there, I improved my knowledge and experience by using eye investigation instruments like OCT, visual field topography, fundus camera, and biometry, etc. Since year 2007 till today, with great dedication and facing lot of challenges, our Guru Senior Optometrist Naresh Pradhan and Chairman of Senior Optometrist Damika Deshapriya brought this IKEA Institute to this successful position. I wish IKEA Institute celebrating its 15th anniversary the strength and ability to reach success in that journey by managing its affairs with professional expertise as a team. Good luck. Thank you.
I am optometrist Geeta Rupini Vijay and the director of the Ceylon IKEA Optometric Association. After completing my A-levels, I joined the Albert Edison Opticians in 2000, where a new chapter of my life began. Later in 2006, I started my own business in Kuruita under the name Vijay Sundara Optometrics. However, my quest for knowledge paved me way to join the IKEA Institute in 2009, which I still believe is the turning point in my life. There, I studied the basic course, certificate level course, and the diploma course. In addition to my studies, I was lucky enough to meet 6 friends who are always with me in the ups and downs of my life. They are really a strength to me. I also got the opportunity to attend several lectures with the Malaysian Segi University while doing the diploma in optometry. I was a founding member of the IKEA Optometric Association and a member of the Ceylon Council Optometry and Orthoptics. I also got the chance to join the Vision 2020 program held in school all over the island. Further, I had the privilege of conducting lectures at certain times. Apart from that, I got the opportunity to participate in programs like IKEA New Year, cricket tournament, and Christmas party. So I am glad to mention that all my success and where I am today is due to the guidance from my IKEA founder and my mentor Naresh Pradhan and Dhammika Deshapriya. Let me take this opportunity to extend my heartiest wishes to the IKEA Institute on its 15th anniversary and courage and strength to move forward. Thank you.
Hello everyone, I am optometrist K. Dayalan. I hope you all are being safe during this pandemic situation. I am practicing at my own eye clinic, well known as Sunoptic Eye Clinic, situated in Vatala, Sri Lanka. I am very proud to say that I am a product of IKEA Institute, where I was graduated to become the professional optometrist. IKEA Institute is the first government-registered optometry visual science institute in Sri Lanka. First of all, I would like to show my appreciation to our legend lecturer, program director, Sir Naresh Pradhan, as well as Madam Dhammika Deshapriya for their enlightenment. So I am very delighted to say that I am one of director, Ceylon IKEA Optometry Association, and also a member of Sri Lanka Optometry Association. As an optometrist, I was able to provide huge humanitarian service during my career, and I have received many awards and appreciation. During our 15 years debut, we have conducted many awareness programs in Sri Lanka. As the awareness walk, we did from Kandy to Colombo. We have done many researches about the awareness of vision by our public nation. Our institute's lecturers always encourage us and insist to practice according to their code of ethics. In our practice, we were not confined only refraction, but also we were advised to diagnose the different systematic diseases for the betterment of our patient. I have gained a lot of experience as a student of IKEA Institute. IKEA has also started the paramedical courses such as nursing, pharmaceutical science, and audiology, which we have already started. I hope that IKEA Institute grows to an international level. We have accomplished many achievements. Also, we were able to become members for a lot of organizations throughout the world, as well as the Lions Club International District 306B2, as we are the one and only professional Lions Club of IKEA in Sri Lanka. All the Lions members are professional optometrists. As Lion members, we were able to provide the tremendous service to our public nation in the area of vision. Our only hope is to eradicate the blindness in Sri Lanka. I am very happy to say that we are going to celebrate our 15th anniversary soon. I hope it's going to be a memorable and a great ceremony. I wish all the best from the bottom of my heart for their future endurance. Thank you.
Hello, I'm Sanjeeva Ratnayaka, optometrist at Vision Infinity Eye Care. It's an immense pleasure to talk about IKEA Institute on their 15th anniversary. Eye Care Institute is one of the best places where that I got my optometry education as an optometrist. Eye Care Institute has produced many quality optometrists during last 15 years. So they got an opportunity to work in Sri Lanka as well as overseas as quality optometrists. I would like to convey this special message to all the youngsters who is willing to learn optometry. Eye Care doors are open for you all to learn optometry. In this special occasion, I would like to thank specially Eye Care Institute Director and the founder, Senior Consultant Optometrist Naresh Pradhan and Madam Dhammika Deshapriya for their dedication for upliftment of optometry in Sri Lanka with international standard. Finally, I would like to thank all the past directors and the members and the present directors for their dedication for Eye Care Institute. And thank you so much and congratulations.
Eye Care Institute Optometrist Lagi Mahageda. I wish you all the very best for your 15th anniversary. And my mind goes back to year 2007, where we met our great guru, Senior Consultant Optometrist Naresh Pradhan, and also his wife, Senior Consultant Optometrist Madam Dhammika Deshapriya. So we started our eye care journey there at Valikada Plaza Rajagiri. That was in year 2007. And today, when I think back, I'm so happy to say we have achieved many things together with Eye Care Institute in the field of optometry in Sri Lanka. And at that time, there was nothing called optician, optometrist, and there were no curriculum, no syllabus for the students. We were just having some professional discussions day to day. It was so interesting. And now to see, for the new students who love to learn optometry, your pathway is very clear. You have the clear steps to come forward in Eye Care Institute, and you know what you're going to achieve at last. So this is the best place for you all to study optometry and also practice optometry. And best example is in our family, because we have 3 optometrists in our family, me, my husband, and also my elder daughter. She's now studying in Eye Care Institute at the diploma batch 3rd semester, and she's a student optometrist from Eye Care Institute. So I don't have to tell much about Eye Care Institute, what is now. And let Medha explain what Eye Care Institute is now, because their pathway is very clear. So they have taken many steps to develop in their career. So I'm so happy and proud for Eye Care Institute. Wish you all the very best, Eye Care Institute. Thank you very much.
Hi, I'm Medha Ratnayaka. I'm a student of Eye Care who is studying in diploma level, and I'm already in my 3rd semester. I'm really happy that we are celebrating our 15th anniversary this time. I'm wishing all the very best to my dear teacher Naresh Pradhan and also my teacher Dhammika Deshapriya for supporting throughout my passion with a lot of opportunities in Eye Care. I started my Eye Care journey after O-levels, and I did my 1st year and came as the batch top, and I started my 2nd year. So I'm really proud to be an Eye Care student. Thank you so much.
Hi, I'm optometrist Nishamani Durgi, practicing at Nishamani Durgi Optometrist. I started my career in 1989 and qualified in Germany in 1993. By 2007, I joined Eye Care Institute with the idea of studying the subject further to broaden my knowledge of it. I am also founding member of Eye Care Optometric Association. My experience with Eye Care Optometric Association and Eye Care Institute is that when it has come to education, it has been crystal clear. The decisions are made in a fair, impartial manner with absolute focus on merit. This is highly recognized and regarded as a place where one's talent is appreciated and opportunities provided for them to act, taking their own initiative. It does give me pleasure to see that The first cricket match I had organized with my husband, optometrist Gamini Durge, at the Maharagama grounds has now developed to a tournament level. I have also enjoyed carrying out the comparing at various scientific sessions, various programs, Christmas get-togethers, and cricket matches, so on. I do take this opportunity to thank the founder IKEA Institute, the consultant optometrist Naresh Pradhan, my guru, for his tireless efforts to transform the field of optometry in Sri Lanka with his dedicated professionalism that has resulted in fundamental changes in our field of work that has enriched all of us. Let's wish all the very best to the 15th anniversary of IKEA Institute, which will be celebrated soon. Thank you.
Hi everyone, I am optometrist Tushan Chaturanga. Currently I am working at J. Vimalasuri Opticians and Panora Eye Hospital, Gampa. I started my career since 2012. First of all, I would like to thank my guru, Naresh Pradhan sir and Namika Deshapri madam. I just want to say, for me, this is everything because of IKEA. IKEA is the best institute for optometry and visual science in Sri Lanka. Really, I am very proud of to be an IKEA member. I wish you all the very best for 50th anniversary of IKEA. Congratulations, IKEA. Thank you very much.
I am Prasad Gomis and I am a past student at the IKEA Institute. I am privileged to have myself introduced as a member of the IKEA. The reason behind this is that throughout my career as an optometrist, I have not only acquired the skill of optometry, but many life lessons through the institute. At the time in Sri Lanka, where we were not able to learn optometry, even at a cost, my teacher Mr. Naresh Pradhan lent his hand in offering us the invaluable opportunity to learn optometry. I personally believe this was the defining moment of optometry in Sri Lanka. After all this time, even now, I am delighted that I was a member of the first batch of IKEA Institute's Diploma in Optometry. As a past chairman of the Ceylon IKEA Optometric Association, I would like to share something with you all. The association helped to protect the optometrist legally as a professional in optometry, even after graduating from the IKEA Institute. The specialty of the Ceylon IKEA Optometric Association is that only the members of the IKEA Institute and the past students are given the opportunity to join the association. Ceylon Council of Optometry and Orthoptics is an association built on behalf of primary IKEA providers to regulate ethical optometric and orthoptic professionals in Sri Lanka. I am honored to represent Ceylon IKEA Optometric Association as a counselor to Ceylon Council of Optometry and Orthoptics. As a fellowship holder of Ceylon IKEA Optometric Association, as a counselor of CCOO, I would like to extend my heartiest congratulations for our 15th anniversary, which will be in 2022. I am ending my speech by reiterating that I am a proud member of IKEA. Thank you.
everyone. Hope you all well and safe. I'm optometrist Nadi Kamarasinghe Hettiarachchi. Currently, I'm calling you from Nairobi, Kenya, East Africa. I've been practicing in Kenya for nearly 12 years. Currently, I'm with Cambridge Opticians, one of the leading optical in Kenya.
We are highly demanded in Africa as professional optometrists, and I'm sure not only in Africa, even in the other part of the world too. All these achievements, opportunities I got today because of ICAR Institute. I joined ICAR Institute in 2007 by the guidance of my former boss, Mrs. Deepika Kumuduni De Silva. Thank you, ma'am, for your faithful guidance. The time I joined ICAR, I didn't have any knowledge of optometry, so I did my first letter reading of optometry in ICAR Institute, Sri Lanka. I, on behalf of all the ICAR students from 2007 until today, I extend my most sincere gratitude to our dearest teachers of optometry, Senior Consultant Optometrist and founder of ICAR Institute, Sir Naresh Pradhan, and Senior Optometrist, Madam Dhammika Deshapriya. Thank you, my dear sir. Thank you, my dear madam, for all the dedication and the great effort you have done for all these years to build our knowledge, passion, confidence, and future. Because of you today, I'm very impressed and proud to review my journey as an optometrist.
Since we are proudly celebrating our 15th anniversary of ICAR Institute, I thought of adding my tribute and heartfelt wishes on this special moment. Dear Mother ICAR, congratulations and happy anniversary. Keep shining. Cheers. Thank you.
Hi everyone, my name is Dr. Amila Dialvis, a consultant ophthalmologist practicing in Colombo, Sri Lanka. I'd like to take this opportunity to wish ICAR and Naresh, they are very energetic and organized leader, the very best for this conference to mark their 15 years in service in Sri Lanka. And I worked with a few of their trainees and the optometrists trained by ICAR, and I found them to be very meticulous and do their job very, very well. And I feel with the goal of expanding ophthalmology and ICAR in Sri Lanka, ICAR will play a very important role in the future too, to enable this growth to take place. So I wish them a very fruitful conference and many, many years of great service and required service in Sri Lanka to come. Thank you very much.
Hello everyone, I'm Stephanie Fernando. I'm an active student of ICAR Institute, Sri Lanka. I take this opportunity of sharing my experience as an optometrist with all of you. I still remember the day when I initiated my ICAR journey after my O-levels by the guidance of my loving mother in 2018. Just after the enrollment, I was able to complete my first year foundation course and I continued my second year diploma in optometry. In the meantime, with the blessings of ICAR institution, I got a chance to work at Gloria Vision Center as a trainee optometrist since 2018.
I'm really proud to state that the knowledge and the trainings that I received from ICAR are excellent for me to excel my inspiration in my dream field of optometry. Moreover, while studying at the ICAR Institute, I was able to gain much experiences required for our professional lives through attending welfare eye camps which were conducted by the Institute. I could enhance my presentation skills by receiving opportunities to present several themes in my academic life with the continuous assistance of ICAR Institute. Other than that, the Institute gave us the chance to educate ourselves with social activities too. ICAR Institute probably has a very passionate environment where they intrinsically motivate the professionals for the work we do. Throughout many practical sessions, I could be able to promote worthy approaches to learn in many ways. It also helped me to develop my problem-solving skills. Now, as a proud optometrist, I have the urge to pinch myself for this moment for where I am today, which seems unbelievable. With profound love and reverence, I would like to thank and appreciate my dearest mentor, ICAR Institute Director and the founder, Senior Consultant Optometrist Naresh Pradhan, and also my respected teacher, Group Chairman, senior consultant optometrist Madam Dhammika Deshapriya for always molding me and guiding me to lead a successful path. Now we are on our way to celebrate the 15th anniversary of our IKEA Institute. It's a matter of great pride to see the institute growing, embracing good value system and achieving more. Finally, I wish the institute to continue the journey with many more anniversaries, many more success stories and many more achievements. Keep experimenting, keep growing and keep celebrating. Thank you.
Vanakkam. Non-optometrist.
Kindly draw your attention. Could you kindly come and take your seats, please? Could you kindly take your seats, please? I hope you enjoyed the lunch. We are running short of time, so kindly come and take your seats.
මේ විශේෂ නිවේදනය ඔබටයි කරුණාකර නැවතත් දේශන ශාලාව පැමිණීම අපේ කරනවා කල් වේලා ගිහින් තිබෙන නිසා හැකිතාක් ඉක්මනින් මේ ස්ථානයට පැමිණෙන ලෙස අපි ඔබගෙන් නැවතත් ආයාචනා කර සිටිනවා.
Before we start the session of the day, this will be the last session of the day. May I call upon the stage fellow optometrist Prabhamali Sirivardhana and fellow optometrist Suranga De Silva, who will be our moderators for the second session. Thank you.
මහජන අක්ෂි සෞඛ්‍ය අන්ධ බව දුරලීම IKEA 2022 දෘෂ්ටි විද්‍යා සැසියේ අවසාන භාගය ගිවන්නයි දැන් අපි සූදානම් වෙලා සිටින්නේ. තවත් ඊ타ත්ම විශේෂ දේශන කීපයක් මේ ස්ථානයේදී සිදු වෙනවා. ඔබට මේ කාර්මික ආයාචනය ඒ සඳහා පැමිණ මේ ස්ථානයට සහභාගී වෙන ලෙසයි.
Ladies and gentlemen, please come and take your seats. Fellow optometrist Prabhamani Sirivardhana and fellow optometrist Suranga de Silva will moderate the session. We kick off the afternoon with the presentation by Dr. Prakash Paudel, who will be speaking on the subject of role of an optometrist in public health in Sri Lanka and South Asia, a topic that gets to the core of the wider society, who is joining us virtually.
Hey, hello everyone. Thank you very much for your warm introduction. And today I have witnessed the previous session and a good presentations about optometry in Sri Lanka. And it was a very productive panel discussion at the end of earlier session as well. And I'm very happy to be here to present about the role of optometry in Sri Lanka and South Asia. And I have to say it is not only limited to Sri Lanka and South Asia. It should be beyond that as well. Yes, there are few of these presentations are specifically focused in Sri Lankan and South Asian context, but the main sense of gut of these presentations also applies to the broader optometry community worldwide. Today, I will be just covering a few of the informations about public health optometry. So the sessions will cover about the public health optometry, dimensions of public health optometry, the public health optometry and the Brian Holden Foundation in Sri Lanka, public eye health situation in Sri Lanka and South Asia, public health optometry in Sri Lanka and South Asia. And I will also be explaining a little bit about public health optometrists, how we become an public health optometrist and what are the scope of the public health optometrist. So, as we are quite familiar with the role of optometry as a clinician, mostly doing vision screening, refractions, and comprehensive eye examinations. The definitions has been broadened as the time has passed, as the technology has developed. So we can't fit in a single definitions, it has been broadened. But given those all definitions that also differs country to country, but yes, we do have a better definitions given by World Council of Optometry, which adequately defines optometry and optometrist. But here my presentation is mainly focused on public health optometry. So here I define public health optometry as a hybrid discipline with the principle of public health and optometry. to reach out to the communities, to provide clinical care, to promote eye health, to conduct research, to train eye care professionals and community level eye care workers, and to advocate for eye health policies and system improvement. So these are the main areas or scope of this public health optometry. But if you look into the broader scope of public health within the optometry practice, I believe in 5 pillars that define the scope of public health optometry. That is 5 P's: prevent, protect, promote, provide, and publish. So as a public health optometrist, we can find ourselves, our scope of practice can be found within these 5 pillars. And most of us believe optometrists are for vision screening, refraction, comprehensive eye examination, and treatment or management of ocular disorders. And in the earlier sessions also, many of you identified the roles of optometrists in different areas as well, which has already covered in the previous session as well. But if you look into these 5 pillars very closely, and we as a public health optometrists fit with this scope of practices. Optometrists can play a greater role in the prevention of ocular diseases such as glaucoma, red eye, diabetes and diabetic retinopathy, myopia progression, etc., etc. And optometrists can also help protect eyes, suggesting a proper eyewear or treatment strategies to prevent eye injuries, UV radiation, smoke exposure, and also environmental and climate change effects. Similarly, eye health literacy is also very important for uptake of eye care services. Community screening and school vision screening and other eye health promotions are also important. And lastly, conducting research and publishing the evidence for the policy development and tackling the issues in the community is very important. And beyond this, we as in public health optometrists, we can be heavily involved in the statistical analysis, paper writing, or conference presentation, which are also very important to have a professional growth. And given this, we have a very broad dimensions in a public health optometry. We can engage in different areas as we already covered in the previous slide. And there are a few other dimensions such as involving in monitoring some programs, monitoring the treatment of patients, the effect of certain interventions, and also monitoring the program, collecting data of a long 5-year or 10 years program that we run in a community, such as the School Health Initiative in Sri Lanka, which started in 1918. If we have been monitoring the program itself, there we could have a large database to show up how many students has been screened or refracted and prescribed, where are the barriers where we lack in terms of reaching those outcomes that we set during the planning stage. Those are some monitoring stages. And also we evaluate at the end of the time course after the program. That is something it involves in the program as well. So as a public health optometrist, we have that greater role in monitoring and evaluation. Okay. And I already said epidemics is very important, as well as identifying the risk factors associated with different diseases. That is also very important. And another important aspect of public health optometry is also communications. That communication can be as a practitioners to the patients, or to the policymakers, or to the public, in terms of sharing the information, sharing the awareing them with the disease and conditions or the treatment availabilities. So we have plenty of room to act, to practice within the optometry as well. So we, as an optometrist, when someone just mention about optometrist, you think about refraction. That is the common sense, common thing that that beliefs is there in the community. But once you understand the broader scope of optometrists, there is different. It is entirely different. As we already explained in the earlier session, we discussed about the how to attract the high school graduates in the optometry. We definitely need to explain the scope of optometrists and optometric practices. And it is very important for us to achieve a national or global recognitions for our contribution in eye care, research, health plan, and policies. That is very, very important, and which we can feel in last 2 decades. There is greater involvement, greater participations of optometrist leader in WHO, INGOs, NGOs, and different institutions, which leadership was very limited until 1990s. So we have seen plenty of development in this area as well. When public health optometry comes, there is a name that is associated with public health optometry, that is Brian Holden, who is very well-known optometrist, public health advocate, and he is known for very different areas of expertise as well. And Brian Holden Foundation, which was formerly known as International Center for Eye Care Education, that was founded in 1998 in Australia. Until early 90s, uncorrected refractive error was not prioritized as a cause of vision impairment and blindness. And IAPB and WHO did not talk seriously about vision impairment due to uncorrected refractive error or myopia. And uncorrected refractive error was not counted in vision impairment statistics, and optometrists were not widely accepted to be part of eye health workforce. But with the advocacy led by Brian Holden and optometric colleagues around the globe, including Kovin Naidu, who is here today, vision impairment and blindness caused by uncorrected refractive error was highlighted in Vision 2020, the right to sight as one of the major priority. And this is now the main focus of work for prevention and treatment. And this has been adopted by different organizations, including WHO, IAPB, and different NGOs worldwide, as the epidemics of myopia has been prevalent, and it has been the prevalence is increasing, and it is estimated that 50% of the population will be myopes by 2050. So there are a lot of things to be done in the field of refractive era itself. So as an optometrist, there is plenty of opportunities to work and to lead in this area. And Brian Olden Foundation was also quite well known due to the support provided to many countries in establishing optometry schools and also providing refraction training programs in the low resource countries. So now optometrists are basically a core part of the eye health team, and they are well respected, well recognized, and are also in a leading positions, the leadership position in different organizations. And because of uncorrected refractive error and myopia as an emerging problem, this has been recognized as a major global risk. There are many worthy attentions towards optometrists because they play a core part, main part in dealing with the problem with refractive error. So if we look into Brian Olden Foundation's association in Sri Lanka, Brian Olden Foundation provided emergency eye care in Sri Lanka after 2004 tsunami. And then the Sri Lanka country office was established and registered in 2008. Following that, in 2009, it established 4 vision centers in the Kegel and Gampa district. And later in 2009 to 2014, there was a program called Colombo Urban Comprehensive Eye Care Project, which was launched in the urban slum areas of Colombo. This has been a successful program. And similarly, Brian Olden Foundations also established an optical workshop and later handed to the National Eye Hospital in Sri Lanka. Also provided scholarships to individuals to train in India, conducted workforce development activities such as volunteer training on primary eye screening, supporting to the staff in following the optometry courses, facilitating the eye care related institutions to provide the training for eye care professionals. And basically, if we sum up the achievements of Brian Olden Foundations in Sri Lanka during those 12 years, the Brian Olden Foundations was successful to have provide eye health services to over 130,000 people, was successful to dispense over 69,000 pairs of spectacles, referred more than 27,000 individuals for secondary or tertiary eye care services, conducted awareness programs that have reached over 2 million community members, and also over 800 personnel were trained in primary eye care and vision screenings and low vision management. These were the activities that were related to Brian Olden Foundations as a leading optometry global organizations that was supporting optometry in different countries, and Sri Lanka was one of that. As we were heavily involved in Sri Lanka, we also did a few studies to understand the refractive error situations in Sri Lanka. One of the study that involved in 2004, right after the tsunami, and we were able to report the first time we were able to report the prevalence of uncorrected refractive error in Sri Lanka. That is how the Brian Holden Foundations was established in Sri Lanka and eventually has worked was associated in different activities. We also conducted a study in 2011 that was related to barriers to refractive error services. And that involved 130 eye care providers, including optometrists and ophthalmologists. And what we found from that was basically unaware. Most of the patients, most of the public were unaware to have a problem. That was the most identified barriers by the eye care providers. And some of the other barriers were work priorities or very busy with work, preference given for treatment of other health problems, lack of awareness about refractive error services, never felt important due to old age. So these were the few barriers that were identified by the eye care providers. And later we had a survey with 106 patients in 3 different vision centers. And what we found and what they said is as a barriers, what we identified were lack of felt need, work priorities or busy with work, long waiting time at clinics, and family influence and cost was some of the major barriers to refractive error services. So the key message is that we should have school-based and community-based vision screening and eye health literacy through health education interventions and health promotion. That is health awareness. Eye health awareness is definitely needed in Sri Lanka. So that was the most important message abstracted at that stage, which is still relevant based on the previous presentations that most of you have presented in the earlier session. And now, if we look South Asia in a one picture, we can see that South Asia consists of 8 countries: Afghanistan, Bangladesh, Bhutan, India, Maldives, Nepal, Pakistan, and Sri Lanka. And why I'm mentioning South Asia is because South Asia share the closest similar culture, tradition, beliefs, and which is very related to compare between the countries as well. So to have a comparison with Sri Lanka and the countries near Sri Lanka, the main focus of these presentations is also that also includes South Asia. And this South Asia has a population of 1.75 billion, which is 1/4 of world's population. In 2017, the prevalence of blindness in South Asia was 0.7%, which is home of 11.7 million blind people. That accounts 32.5% of the people who are blind worldwide. Due to national eye health programs, after the first epidemiological surveys in the region, the age standardized prevalence rate of blindness is estimated to have reduced from 0.8% to 0.5% in all ages population, and from 3.2 to 5.2% to 3.5% among people aged 50 years and older. So let us see what is uncorrected refractive errors contribution in blindness in South Asia. In year 2015, uncorrected refractive error contributed about 36% of total blindness compared to world's average of 20%. If you compare this figure, with the year 1990, there is increase in the blindness caused by uncorrected refractive error by about 1%. We know cataract is the main cause of blindness. However, as you can see from this graph, that uncorrected refractive error contribution is almost equal to cataract blindness in South Asia, because this figure represents the South Asia. So if you look at the cataract and uncorrected refractive error contribution, it looks similar. The graph shows similar. And let us see what is uncorrected refractive error. Yeah, this was about the blindness, and where we saw about 1% of increase in contribution of uncorrected refractive error in blindness is 1% increase, whereas you can see in a vision impairment with uncorrected refractive error, this has also remained almost same, but you can see in year 1990 the old contribution was 50%, whereas in year 2015 it was 52%, whereas in South Asia 64.59% in 1990, and 2015 it was 66.39%. So there is overall 2% of 1 to 2% of increase in contributions of the vision impairment due to refractive error. And if you look at the myopia prevalence in children in South Asia, Rudnick et al. Reviewed 20 articles from 1990 to 2014 from 4 countries, Bangladesh, India, Pakistan, and Nepal, including some 46,102 children participants, and revealed the increasing trend of myopia prevalence with increasing age. And this study also showed that the prevalence of myopia in 2005 was 5.3% among 5 years old children, 9.2% among 10 years, 13% among 15 years, and 13.9% among older children, 18 years and old children. And in India, the overall prevalence in the last 4 decades, overall crude prevalence of myopia over last 4 decades is about 7.5% in 5 years age group, and the prevalence of myopia is 8.5% in urban and 6.1% in rural children. And similarly, Priscilla et al. Recently in early 2021 reported that the prevalence of myopia 5 to 15 years old urban children has increased from 4.44% to 21.15% in 2019. So in 1999 it was 4%, and now it is 21%. So overall, you can see there is an increasing trend of myopia prevalence. And if you look at in some other countries, like in Bhutan, the refractive study in children conducted in 2019 reported that prevalence of refractive error is 15.4% and myopia prevalence as 6.6%. In past 20 years, several studies that had been conducted in school children in Nepal showed that in overall about 7.9% of refractive error among school children, where myopia prevalence constitutes about 5.9%. And similarly, few small school-based studies conducted in different states of Pakistan have reported myopia prevalence of about 1.9%, and in Bangladesh, population-based studies reported refractive error prevalence of 3.24%, whereas there are no refractive error in school children studies being reported from Afghanistan, Maldives, and Sri Lanka. Yes, there have been some studies being conducted in Sri Lanka, but in the international journals, the information about the prevalences of refractive error in children has not been documented yet. And if you look at the refractive error in adults in South Asia, Afghanistan, they have a vision impairment due to uncorrected refractive error as 26.9%. And in Bangladesh, in age 30 years plus, the myopia prevalence is 22%, whereas in Nepal, the recent RAP surveys reported that refractive error prevalence of 20% and uncorrected refractive error of 9% among 50 years plus population, whereas in Pakistan, among 30 years plus populations, the National Blindness and Vision Impairment Survey reported myopia prevalence of 36.5%. Whereas in India, in the population of 40 plus, the myopia prevalence has been reported from 16.8% to 42.4%. So there is a big variation in the prevalences of refractive errors in adults in India. So looking at these figures, we are still not able to report the refractive error prevalences from Sri Lanka. Yes, there was a national blindness survey that was conducted in 2014-15 in Sri Lanka. They do have some figures about the refractive error, where they mentioned that the National Blindness and Vision Impairment Survey conducted among 40 plus years, they reported prevalence of blindness of 1.7% and 17% having vision impairment. And with regard to refractive errors prevalence, they reported 53.9% having plus minus 0.5 diopter, greater than plus minus 0.5 diopter of refractive error. And if you consider within the limit of less than greater than 0.5 diopter myopes and greater than plus 2 diopter hyperopes, the prevalence is 28.7%. With this, they have estimated 1.66 million of 40 plus populations having vision impairment due to uncorrected refractive error, and also reported the prevalence of spectacle coverage of 17.7%. Given this information, and as we also know from the same survey that 8 million presbyopic adults and need prescription and 1.2 million cataract surgery backlog is there in Sri Lanka, and those who have cataract, particularly nuclear cataract, they might get benefited with spectacles. The role of optometrists is enormous. They can just focus on refractive error itself. There is huge of work to do. So as an optometrist, we can just primarily focus on refractive error in a public health level. And then we do have other roles that I have already mentioned earlier as well. And the other important aspect is that there is increasing prevalence of diabetes in Sri Lanka, which is estimated 10.3% in recent years, and it is projected to be 13.9% by 2030. So the populations with diabetes mellitus are increasing, and there is a possibility of these people having diabetic retinopathy in some stage of their life. We as an optometrist have a greater role in screening diabetic retinopathy early at the earlier stages so that we can prevent them from being blind. And some other roles, as in earlier session, some of the colleagues presented about occupational eye health. There definitely, as a public health optometrist, you can play a major role, such as for verifying the eligibility to get a driving license, and similarly supporting people who play sports, providing different different kind of devices. Similarly, pilots, police, army, navy, and other labor workforce, such as the labor workforce in tea industry, garments industry, they can get benefited with simple pair of spectacles. So as a public health optometrist, these are the broad areas where we can play a major role. And for that, yes, as we also discussed in the previous session, optometrists has to be trained and they have to be regulated, which definitely Sri Lanka seems little behind than other South Asian countries. And I think having a Bachelor of Optometry program being introduced in Sri Lanka, this will eventually change. There will be more defined, regulated optometrist practice in Sri Lanka. And I was just giving a reference of a few optometry institutions in Bangladesh, India, Nepal, and Pakistan, which I think in coming years we can see this growing, these numbers growing in Sri Lanka as well. And we will have a big family from Sri Lanka in our optometry institutions and optometry associations. And I was a little bit interested in knowing the public health optometry associations, or say optometrist involvement in community vision screening in different associations and conferences. It was really good to see Ceylon Optometric Association as one of the oldest optometric association in that region, particular South Asia or Southeast Asia region. And it was good to see they have been working, introducing foundation level course, diploma of optometry courses, and eventually, yes, Bachelor of Optometry program is also being introduced in Sri Lanka. I think that will grow in a bigger number so that we can address the need of optometrists for Sri Lanka according to the WHO definitions. And it was amazing to see the presence of Asia Sri Lankan Optometric Association in Asia Pacific Council of Optometrists, World Council of Optometrists since 1985 and 86. And I have witnessed a few of the optometric colleagues in different conferences as well. And as an association, as an optometrist, we have a key role, an important role as an advocate for policy change, to make a policy. So it is good to see that Sri Lankan Optometric Association is as a steering committee member of Vision 2020 program, and it should be much more involved in this year as well. And with the Bachelor of Optometry program, there definitely that will open more avenues for optometrists, and the public health optometry definitely will grow, and they will play a major roles in leading different institution associations and also playing a major role in policy making, advocating for policy for different dimensions of eye health care, so that we can develop those leaders as an not only as an optometrist, as a leaders, health leaders, innovators, or changers. They can heavily get involved in different dimensions of activities, including research, optometry practice, and as a vision scientist or epidemiologist. There are plenty of opportunities. And you might have been a little bit curious of getting involved in public health optometry as you graduate from your Bachelor of Optometry degree. There are many institutions in the world where you can pursue your further educations in community eye health or public eye health. I have listed few of those that are available, such as it is available in India in L.V. Prasad Eye Institute as a Master in Community Eye Health program. There is diploma and certificate courses as well. Similarly, it is also available in Pakistan Institute of Community Ophthalmology, also in Dhaka, Bangladesh as a Masters in Community Eye Health. And one very popular course is run by London School of Hygiene and Tropical Medicine in UK as a MSc in Public Health for Eye Care. And we also are familiar with the MPH in Postgraduate Diploma in Community Eye Health in South Africa as well. So these are the few courses where you can pursue your further career in public health doing masters or PhDs. And in addition to this, you can approach to any overseas universities or within your universities as well to complete your masters in public health, where if you do masters in public health, that helps your career in public health optometry as well. And also that also leads to, or you can directly get enrolled into the PhD in optometry, taking a health service research or community eye health. And there are a few other courses that are available from different websites. You can get these slides at the later stage from Naresh as well, if you are interested. And before I finish, I would also like to give a little bit emphasis on some other aspects of public health as well, where optometrists can play a major role, such as screening diabetes or screening hypertension, because diabetes and hypertension is an increasing problem in the world. So there we have a major role in identifying diabetes and hypertensive patients and referring them to the physicians. And also we can play a major role in smoking cessation, also supporting in healthy pregnancies, as well as supporting in the obesity management and cholesterol management, which are also linked with some eye health conditions where you can see some changes because of the high cholesterol levels or because of the obesity. You definitely will have some problems in eyes as well. So these are also some areas where you can keep on eyes when you are examining your patients. You can just measure the blood pressure. You can also look at the diabetes. You can ask for them to check have a diabetes test, blood test. Also, you can counsel about the cholesterol things. And also some of the conditions are also associated with alcohol consumptions, where you can see some pursuit movements, nystagmus kind of things. That is also linked with eye conditions as well. So you can have some counseling related to addiction with alcohol and smoking. That is somewhere as a public health optometrist, you can also play a major role, a better role in suggesting your patients, the public, about some of these conditions. So some of these are the examples. There are many other areas where, as a public health optometrist, we can definitely play a big role. Yes, I can understand when we have an impression that once we are an optometrist, our main scope of practice is being as a clinical optometrist, a consultant optometrist, but at the same time, you don't just think about the business, having a good business, running optical outlets. There is also a bigger responsibility to address the problem in the community. So not only as a clinical optometrist, you must work as a public health optometrist at the same time. So there is a good future. Bachelor of Optometry program has been introduced in Sri Lanka, and this will definitely open the door of leading into the better opportunities in future. Good luck for that, and if any wherever needed, whenever needed, I will be here to just be in connection and talk further about the professions and also developing optometry and public health optometry in Sri Lanka. There will be association, my association as well. Feel free to contact me at any time through LinkedIn or ResearchGate or any other connections. Thank you. Thank you for listening for today. And I will be here and I will be listening. If any questions comes at the end of the program, I will be happy to answer those questions. Thank you.
Hello. Am I going to be introduced, or this is very quiet? Can I? I can't even put my video on. I don't know why. Yeah, it's on now. Ladies and gentlemen, my name is Azrin Arfin. Do I need to be introduced, or what's the procedure? Everyone's quiet. Okay, that's good. Yeah, all right.
You have introduced me.
Will I be? Okay. Are we having some communication problems? I can't.
Yeah, Professor.
Okay. Am I able to be heard? I am. Yeah.
Yes, doctor, we can hear you well.
Thank you. Thank you very much. I don't know how much time I have. It's really gone off the schedule now. I'm supposed to be spending 15 minutes. So that was a keynote address that we just listened to. So I'm going to have to be very quick because I've got something on to do. I'm sorry. I'd like to say thank you to the Eye Care Institute and Ceylon Eye Care Optometric Association, Mr. Naresh, especially, whom I know personally. And I'll try to keep to 15 minutes, of course, yeah, because there are a few more speakers after me and I have to respect the time. Okay, I'm just going to talk about a few things about the professional aspects of the profession. Having been to Sri Lanka before, and I think I don't know if my topic fits well into your theme, but it is public health in a way. It's about optometry and optometrists. I heard the talks this morning about optometrists in Sri Lanka, and I understand very well the situation. And I think one of the things that we need to move into is, rather than aspiring towards a model, it's about rethinking the model of care. Because I'm going to talk about the Malaysian experience here. I am in Malaysia. My name is Azrin Arifin, by the way. I'm an optometrist, and we had serious issues since the pandemic started. And I hope to share this with colleagues in Southeast Asia. It is public health in a way. It is somewhat related to the profession. I hope I can get your interest for about 15 or 20 minutes. This is where I work, by the way. For those of you who have been to my institution, it is still the same. It's a bit quiet now because of the pandemic. We've not got students on campus apart from those who are on campus for their practical work. And optometry, dentistry, medicine, medical students are on campus. But you know, it's difficult to teach optometry with all the SOPs. But anyway, I'll try to make my presentation in a very kind of sit back, relaxed manner so that you can actually go through the many slides that I've got. And I've got my storyboard as just 4 points, ladies and gentlemen, just 4 points, okay? The frustrations of the profession, the painful truth about us, the plea that I'm making, and also the suggested mechanisms. Now, I know that our situation might be different. I've been to Sri Lanka a couple of times. The last visit was probably 2015, if I remember correctly. And I think we had something going then, but we didn't actually continue on because of things that happened after that. But now with the pandemic, I think things are getting a bit clearer so that we can have joint programs and stuff like that. But before that, let me just tell you that over the last 2 years, the profession in Malaysia, the profession of optometry in Malaysia, I'm not trying to discourage people from coming into optometry. Naresh said this morning very elegantly that, you know, out of the thousands of A-level leavers, many didn't have the interest to do optometry, and they don't see optometry as a healthcare profession because of certain things. And I'll tell you why. In Malaysia, I'm not trying to discourage people as well, but the frustrations during the pandemic. Now, this came out in the Malaysian news. You know, we were asked to stop operating, prohibited. Not just that, the frustration was that we were grouped together like barbers, hardware shops. So, you know, the fact that the retail environment made us not healthcare in the eyes of the government, in the eyes of medicine, unfortunately, very unfortunate. And here we are talking about eye healthcare, trying to prevent blindness, avoidable blindness, uncorrected refractive error. I mean, the gentleman just now was saying, you know, so much work to do. And here we are, we were stopped from operating apart from essential services. And what are essential services? I mean, I don't think the government actually regarded refraction as essential, because up to a certain point, when the Association of Optometrists Malaysia made the strong plea that, look, people can't work without proper glasses, then, you know, things started to open up. But here we are in a public health seminar talking about causes of blindness. And I apologize for not having uncorrected refractive error on the diagram here, because I pulled this out from WHO. I suppose they were just talking about the uncorrect. I mean, they weren't talking about refractive error on this slide. I apologize. But then again, cataracts, glaucoma, the same story everywhere. I mean, in Southeast Asia, it's cataract. The fact that optometrists are very, very essential in eye examination and picking up people with cataracts and some of the blinding conditions, you can't just sweep that under the carpet. We play a very major role. But the painful truth is our healthcare function has been marred by the spectacle shop image. Very unfortunate. I can't show this picture for too long because, you know, the owner might not be very happy with that. And in the optical law that we have in Malaysia, funnily enough, the English is very funny. It's called the Optical Act. In most countries, the act would be called Optometrists Act or Opticians Act, you know, in the UK. But here it's called the Optical Act, very strange. And optometry is defined as employment of methods of blah, 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 without actually talking about eye health examination and care. I don't know about Sri Lanka. I don't know about India. But, you know, in Malaysia, Indonesia, same story. Singapore is slightly better, but Singapore are not allowed to have bachelor's degree programs for some reason. I don't know why, but here we are in Malaysia and in many parts of Asia. Optometry is a refraction profession. Well, that's fine, but you know, this is what the public views us as. The role of doing refraction on the high street, eyewear, spectacles, contacts, refraction for the purpose of ophthalmology management in hospital services and technical procedures in eye departments, including A-scan, OCT, visual fields, but not making primary eye care decisions. That's the thing. So are we eye healthcare professionals? We face a big problem of being recognized as an equal, on par colleagues, not at least as independent primary eye care providers, unfortunately, despite the fact that we've been around for many years. And if I heard it correctly this morning, in Sri Lanka, the profession started 40 years ago, was it? Yeah, or at least association started 40 years ago. And that was one of the very first associations in Southeast Asia, I think, yeah? So within the public health service in Malaysia as well, we're not fully recognized as primary eye care practitioners, let alone in the private sector. I don't know about Sri Lanka, whether you have optometrists in the government service, but in Malaysia, we do. There are optometrists in eye departments, but what do? They do all those things, the technical work and not the primary eye care work, unfortunately. And here we are talking about blinding conditions which need to be detected. So how do people get detected? GPs, nurses, and they clog up the hospital service because there's so many false positives. So I would like to refer you to this thesis by a colleague. She submitted it to Queensland University of Technology sometime in 2016. And she was, she did a very interesting work, and she found that the role Malaysian optometrists at the time in government service were just limited to refraction and very limited for ocular health examination. And she interviewed some ophthalmologists, interestingly enough, in a very, very powerful chapter 11. Some of them don't even know what optometrists do. Very unfortunate, but some do. Yeah, some did. And in the National Eye Survey in 2014, the same problems, untreated cataracts, diabetic retinopathy, glaucoma, these are the conditions that are prevalent in the community, and they need practitioners to examine people. People come in for the refractive error and they get examined for ocular health condition. That's what optometrists do. And so the plea here is, I don't know whether I'm making my voice heard, but the plea is, hopefully, I'm a Muslim, I would say, inshallah, God willing, that we could have a united eye healthcare profession instead of a technical profession working for the purpose of getting technical data. I think primary eye care is making decisions about a patient that comes to see you and making a decision on whether they need to be referred now, next week, later, no need to be referred or monitored or whatever. It's not doing something and then referring them. You're clogging up the hospitalized service. So we need to be very, very friendly with our medical colleagues. And I'm sure there are medical colleagues in this conference, and the lawmakers need to understand. And it's very difficult to make the law people understand if medicine does not actually push forward. We need to work very hard with our ophthalmology colleagues that we're not allied or para level, but we are professionals in our own right. It's probably a bit difficult for medicine to accept it. But then if you look at some of the countries, and in my topic, I called these countries developing countries. I don't know which ones are developing now, but certainly developed countries. Not all developed countries have optometry as a profession. France doesn't have optometry as a proper profession. United States, Canada, Australia, New Zealand, South Africa, and a few more. In South Africa, it's not in Northern Hemisphere. But anyway, yet not all developed countries have proper optometry as a profession. But what we need to do in developing countries, and Malaysia certainly is to be very friendly with medicine, with ophthalmology, is to tell them we're not antagonizing medicine. And good optometric eye care will mean efficient ophthalmology because people get picked up. There's blinding conditions, those uncorrected refractive errors, those cataracts, those diabetic retinopathy. But medicine needs to see optometrists as really trained people and not just simply somebody who does, is it clear, 1, 2, 1, 2. It's more than just that. And we can look at our Western colleagues, Western here referring to the UK and North America, as a model of how they train optometrists. So this is a very ideal diagram on what the three professions are. I'm sure it's not being agreed by everyone in the world, but something that I adhere to, I subscribe to. So the commonest causes of blindness, the Malaysian data showed us cataract, diabetic retinopathy, and glaucoma. And uncorrected refractive error was grouped under visual impairment rather than blindness. So what we can have is optometrists who are well trained in the pre and post-operative care of cataracts, people who are able to pick up diabetic retinopathy timely and appropriately, not just simply seeing something abnormal and referring them, and also people with glaucoma, ocular hypertensive, glaucoma suspects, they need to be monitored. And if you look at the UK situation, if you don't, I'm telling you that initially when optometrists were just referring patients with glaucoma, with suspect glaucoma to the hospital eye service, the consultants at Moorfield were not very happy because they said that you're wasting our time. So they changed to enhanced referral service, but they had another layer where expert optometrists actually made sure that the referral was actually granted and warranted. And with artificial intelligence coming into optometry and ophthalmology, I think this is just beautiful. And in the UK, the College of Optometrists and the College of Ophthalmologists are such two beautiful bodies that work together and they respect each other. And of course, ophthalmologists are surgeons and the optometrists are GPs in eye care. And they develop guidelines. You can go through their website, develop guidelines. Even during the pandemic, they had beautiful guidelines on how things can be managed. So medicine and the lawmakers need to ensure that optometrists are up to the mark with regards to their competency. And the onus is on us. We need to be recognized and we need to make sure that we're able to deliver the job. So it's time to up the ante. And the last point in my storyboard and my presentation is that the suggested mechanisms. Now, these mechanisms might be a bit personal to me, to Malaysia, but allow me to share it with you if you don't mind. This is very late in the day. It's 6:30 in the evening in Malaysia. The suggested mechanisms. We need to be reskilled and upskilled in a structured program, and not just simply by going through videos and listening to webinars. It's got to be credentialed, and the best is to be credentialed by the ophthalmologist. That could take the form of a higher professional diploma using the membership or the fellowship mode. And they've got to be, courses or upskilling that involves further investigation techniques and also monitoring and managing eye conditions in a way that when you refer a patient, it's got to be referred timely and appropriately. So I was looking at the models that our medical colleagues and our dental colleagues have. They've got the membership and the fellowship diplomas, and these are not free of charge. People have got to sit for exams to be a member of the Royal College of Surgeons. Ophthalmologists in Malaysia many years ago had to have the FRCS, whether it be an Edinburgh one or, whatever, yeah? And now we have ophthalmology surgical programs in our local universities in Malaysia. That's fine, it's 4 years, so it's not easy. So if you're a fellow of a professional body, if you're a member of a professional body, it means that you're well trained beyond the first degree. Now, it's a bit premature to talk about this to Sri Lanka, but anyway, you're moving forward towards a bachelor's degree. And beyond the bachelor's degree, there's got to be postgraduate. This is my personal opinion. You've got to be a member of a professional body or a fellow in order to become better. So I was looking at the British College of Optometrists website, and they've got higher qualifications beyond the BSc. Now, in England, you got to do a BSc and you got to do 1 year in practice to get the membership. And beyond that, you can become a fellow. Now, many years ago, when I was a student in the UK, I was doing my PhD in the UK. Sorry, I've got to mention this. Fellowship of the College of Optometrists then was by exam. Now you can do it by portfolio. But anyway, whatever it is, according to the College of Optometrists in the UK, the College of Optometrists is a professional body, by the way, yeah? You need further qualifications. And this is taken from their website. And they've got certain areas of expertise that they need now. And mainly glaucoma, low vision, medical retina includes diabetic retinopathy, pediatric eye care, glaucoma, and also the rest of the traditional optometric areas of contact lens practice, low vision, and pediatrics. I think For the Malaysian scenario, this is because I don't sit on the Malaysian Optical Council anymore, but I keep making suggestions to them. Some of my suggestions are being heard of, are being heard by them. Some are not. But I think beyond the Bachelor of Optometry, people need to be trained in certain areas in order to become better practitioners for the purpose of working with ophthalmology. Now, in the UK, you realize that optometry has moved, by leaps and bounds. They're not like our American colleagues. Our American colleagues are giving injections now. The UK optometrists are a bit more sensible. I mean, I'm sorry about that. They're not so aggressive. They do urgent care, and they're talking about minor eye conditions, optometrists having the ability to prescribe, and optometrists in Scotland certainly have the prescription pad now, which is something that's paid by NHS. But anyway, we are in Asia, so it's a bit far from there. So I think if we have a membership, a fellowship diploma, we can actually move towards that direction in order to be good practitioners for the purpose of public eye healthcare. Now, a more controversial but yet academic suggestion is, I think if you realize that, I did optometry in Australia many years ago. I've got a B.Optom from University of New South Wales. At the time, programs such as Doctor of Optometry were not heard of. Nobody was talking about it. I graduated in 1984. There was almost 40 years ago. And now we've got the University of Melbourne and recently University of Western Australia offering the Doctor of Optometry degree. Now, at one point, the Australian optometrists were talking about calling themselves doctors without the doctoral degree. But, that concept was not taken up very well by the Australian optometrists, as you can see here. Some were using the title, some are not. Adrian Bell was using it, and Graham Lakis was using it. They've got good reasons for using and not using it. So it causes a bit of confusion. But when you ask the optometrist board in Australia whether the title of doctor should be used, they say nothing prohibits them from using it. So that's a very, very easy answer. Nothing prohibits. But anyway, I think, that's my picture, 1984 when I graduated. So, optometrists were not called doctors then, and were not aspiring to become doctors of optometry then. If you want to be called doctor, you have to have the PhD, which I did eventually, but went to UK for that. But let's come back to the fellowship and the membership qualification. I think they can be linked to higher degrees. I think it's possible. It is hereby proposed that the membership and the fellowship are actually incorporated into higher degrees. And this is the plan that we have. I'm sorry, this is a bit of an advertisement, but anyway, sorry. We want to go beyond the B.Optom into the M.Optom and into the Optom D. So that finishing the first year, I think people should sit for the membership exams, and finishing the 2.5 years, they should sit for the fellowship exams. These are just my thoughts. And why 2.5 years? Because you can actually go to the US and do an OD program for 2 years. So, I mean, it's not a doctoral degree, it's not a PhD, it's a professional doctorate. So I think the M.Optom should be the subject matter expert and the Optom D should be the specialist. Now, it's a very, very controversial idea because medicine, ophthalmology will not be very happy, but no, this is not to antagonize medicine. This is to make sure that the care is good and it's done by people who are actually well-trained. So in my institution at Sega University, we teach students, to do routine examination. And if there is anything further to do, we follow the British curriculum, which is do further investigation of ocular health. So it's routine and further, and they overlap to a certain extent. So my idea is for optometrists with routine examination ability, they perform general optometric care. And when they are able to use diagnostic drugs, which we have in our law, but people are not using it because they don't have the extra confidence, I think they should be called optometric experts or optometrist experts. So when a patient comes to us, we refer to ophthalmology after routine examination or after further investigation to make the referral better, as what they do in the UK, enhanced referral service. And people in the community or the community optometrists should use standardized referral pathways, which are suggested by ophthalmologists and agreed by them. And you can have many of these in the UK. And I found a very nice one from Bristol Eye Hospital as well, which I will not want to show you. Now, let me share you a couple of weeks ago, I did a webinar for a colleague from India. And, you know, I was talking about drugs in optometry and why do we need them? Diagnostic, I'm not talking about therapeutic. And I asked a couple of questions to the participants. Strangely enough, many people don't agree about the title, and many people would want to do a dilated examination, and many people said we should go into therapeutics. I shall say no more. And in the UK, you know that there is the acute ophthalmic services where optometrists are allowed to actually treat certain eye conditions. So there we go. In the UK, they've got the acute service, routine, and also further care. And if we tie this one up, we will find that eventually we'll have specialist optometrists. Ladies and gentlemen, this is really, really something that's ahead of us. But I'm thinking ahead of time, and I hope, you know, with this, optometrists should be able to provide better care and contribute to eye healthcare. And here we are talking about eliminating avoidable blindness. For my Chinese colleagues, it's Chinese New Year tomorrow, Kong Ki Fa Shai, and I think I've just taken about 20 minutes. Thank you very much for listening, and I wish you well. There you go, I'm off.
some strategies to prevent the problem. So, and if you improve the early detection methodologies, you can prevent this 80% of preventable childhood blindness. Sorry for these technical difficulties. I used to teach while having the computer here. Now I have to turn back. It's not my criteria because I'm a teacher teaching to the audience. Sorry for that. Well, you can see it's a part and parcel of the poverty. You can see it very clearly. Along with the poverty, the blindness also increases. So it's a serious concern because since we are living in a underdeveloped or developing label, so it's our concern. This is seriously our problem. Well, when we think about the blindness, as I said you earlier, 135 billion people in the world are having moderate to severe visual impairment. Out of that, nearly 90% living in middle and lower income countries like Sri Lanka. And unfortunately, we don't have any stats in childhood blindness in our country because we need a larger sample for a quantifiable data. Therefore, we need population-based studies for this. But you can see by having childhood blindness, it affects almost all the development. It affects physical development, mental development, and social development in your life. Then, if you think about the prevalence of the blindness in the world, it is 0.3 per thousand children in developed countries. In contrast, 1.2% per thousand in developing countries. So I use this particular criteria. So therefore, I assume that in our country there are estimated 6,471 children are blind, since we don't have any stats in our country. And each year, 50,000 childhood blindness added into this particular pool. So this is a matter of concern. As I said to you earlier, the childhood blindness affects almost all the departments. It affects your cognitive development, physical development, psychological development, and it affects your self-esteem, and it affects your self-actualization and all the departments in your life. So it's overall your child becomes so handicapped if you are having visual impairment. It's not only a problem with our countries, or it's don't think that fine. Don't think it's a problem with countries like us. So it's a problem even in England, like developed countries. You can see it's on the verge of. So you can see the severe visual impairment keep on increasing. So it's a problem for even UK, not only Sri Lanka. Well, then you might wonder why we are talking about the childhood blindness. So think about this way. If your child is raped, yes, how do you feel it? In the similar manner, think about it. If your child is blind, so then this empathetic approach you should inculcate, or you should improve, you should get within yourself to look at a blind child. Or look when you are making policies, when you are talking about these national concepts. So you have to think about it in this manner. If my child is blind, so this is the similar approach I used here. You can see the causes of blindness in the world. ARMD is very high, and you can see childhood blindness plays a very less significant play here. It's about 4%. Well, we don't think that we don't have any policies. We do have policies. We do have Vision 2020, and we have reserved a day, that's Saturdays, we have reserved for children in government hospitals. So these are the things, the productive things that we have implemented in this country to eradicate the preventable childhood blindness. And then we have set up the 4 pediatric eye units, Late Vijay Hospital, Sirimau Bandaranaga Hospital, Peradeniya, and Jaffna Teaching Hospital, and Karapitiya Teaching Hospital. Then the Ministry of Health has taken initiative, or steps rather, to improve the cadre of orthoptists, pediatric ophthalmologists, and the others. But we don't have any converged policy. These are broader policies actually. We don't have any converged policies to eradicate the preventable childhood blindness. Then we have to ask from ourselves, are these policies enough to eradicate the preventable childhood blindness? So therefore we have to think about this, and that's, so in this particular, the paper, so my goal is to eliminate the preventable childhood blindness by 2025. And objectives are to establish sustainable screening and referral system, to establish integrated eye care team, to promote programs to eliminate each and every the blinding disorders, or mitigate the blinding disorders, to improvise services to treat children with cataract, glaucoma, retinopathy of prematurity, and corneal ulcers, and to provide optical services for children with refractive errors, to provide services for children with low vision, to provide affordable services to eliminate preventable childhood blindness in equitable manner. So it is when you consider this, this is what the sustainable development. So you are giving your services on an equity principle. So I designed the paper based on the Eugene Badash principle. So as usually, you had to detect, or you had to design at least 3 alternatives to address your problem. Your problem is eradication of preventable childhood blindness. So I identified 3 alternatives. First alternative is Let Me See program. Second alternative is V for Vision, that is Community Voluntary Force. And third alternative is EC program, that's digitalizing of health programs. So let's see one by one. Let Me See program is, this is something very interesting. I think you might have seen the CHDR card in Sri Lanka. That's usually called Baba card or Triposha card, Children Health Development Record. This is very familiar in our setup. In our context, every mother, every public health care worker, midwives or nurses are very familiar, because we do have a very strong community primary health system in this country. Therefore, this is very, and our indices are very high when you compare with the other countries. Children, the maternal mortality rate is very low, and the child mortality rate is very low. So therefore, this is because of our preventive measures. So this card is very useful, and it's very prominent and easily in the practice. So this is a very common thing, very known thing. So this is not a new thing. So what I'm doing here is, I'm adding another small question here into this existing Baba card or CHDR. So it is cost effective. It's virtually, because you don't need to spend much money on this. It's very economically very viable. And so we can use the existing public healthcare workers, because as I said we do have a very strong the public health care team, like midwives, public health care nurses, MOH officers based, very good expanded system. So we can give a little bit of awareness on the eye health as well. We can train them and give a one-day awareness sessions, and we can introduce this card and how to get familiar with the questionnaire and how to tick and how to identify the simple eye disorders and how to get the feedback and refer. So this is a very practical, the practical method, I believe. So, but the problem is there are some negative or weaknesses in this particular method, because it can create interprofessional calamities within our professions. Because if you are given this, if the midwives are given this vision screening, the duty, definitely ophthalmic technologists or the optometrists will go against this, or the nurses will go against this. So these are the weaknesses in this particular thing. So we have to identify this, and we have to mitigate this the problems when you launch this the program or the solution. Well, then the second alternative is V for Vision program. This is well practiced, well established in Thailand-like countries. So they do have community workforce. So they are not paid. They are completely 100% voluntary. They are given a T-shirt, I think. So they are wearing the orange color T-shirts, but they are in the community. They are the people who go to the community and identify, and they get all the informations. So they refer. So they are getting only the recognition by referring this. So they are, that's how. So we can create community voluntary force. You call it CVF. It's like our Maradar Samiti or something like that. So it's again cost free, economically very viable, and it's very practical as well. And there are some weaknesses in this particular method, because you might ask, what will happen to them after serving this voluntary force? If they are not paid, how they survive? What are the benefits for them? These are the problems remain with this CVF or community workforce. Then the third alternative is EC program, or digitalization of health system. So here this is also very practical in our country, because we do have high computer literacy rate in Sri Lanka, and it's a trend in our country, because people use mobiles or the computer devices very easily, and therefore it's easy to use. Usability is very easy, I think. Right. Then the weaknesses of this particular method is, it is initially you had to invest a lot of money on computer devices or the mobile devices. Therefore, it's a highly economically not very practical. And the other thing is, existing health community may object, because they don't like to change. They do like to go to the work and eat first in the breakfast and work something and go home, and like that. Very same schedule, same scenario. They don't like to change actually. So this is the problem with our public service. So therefore, we have to think about the paradigm shift, how they are changing from the present stagnant scenario to working scenario. So even if you are giving a computer knowledge, whether they will like it or not. So these are the problems we are remaining with the coming with this EC program. Then anyway, by considering all these the positives and negatives of all these three alternatives, so you can do a multi-goal analysis. This is a very good analytic method what we are using for policy planning. There we think about a lot of aspects. whether it's goal-oriented, the efficiency, economic efficiency, and the distributional equity, political criteria or legality, socio-cultural acceptability, and sustainability, ecological aspects, impacts, and like lot of things we are considering here. So, and we are giving some points for each, like Likert scale, or you can give some scoring, the 1 to 3 like. So, at the end of it, you can see our first alternative comes as the best one. So, that is so when you come to the first, the alternative one, it has so many positive features of sustainable development because it's economically viable, socially and environmentally acceptable. So I don't think, I believe 100% I believe nobody will object this, because this is we are creating a small addition to the existing CHDR card. It's nothing, no difference, and it won't make any job, no one will lose their jobs, and therefore this is a very practical and economically viable method for a country like us. And it's bridging the gap, and it's based on the equity principle, and cost is minimal, and improve the services and improve the health industry image as well. So it's giving a lot of competitive advantage over the other projects. So when you compare the this particular first alternative, when you compare with the other two, it has a lot of competitive advantage. So, and this is a very transparent, and accountability is there. So nothing hanky-panky or nothing hidden, no hidden agendas here. So imagine if you implement the EC program, you had to invest a lot of money on buying the computer devices. Then at the level of procurements, or at the level of purchasing or whatever it is, so you can, a lot of the financial frauds can happen. But here in this, there's nothing like that, because it's very simple. It's only the printing cost. You are printing little additional paper into that, that's all. So therefore, this is economically very viable, and it's transparent, and accountability is there. So I believe this will address the eliminate childhood blindness in our country. So actors to implement this plan, so it should come from the top. So you have to submit a policy paper. So you have to, from the national level, it's a national policy. So then these stakeholders should come, from the Director General of Health Service, then the bureaucratic control under the Deputy Director General of Medical Services, and the legislative bodies, MOHs. Then these are the stakeholders: Blind Council of Sri Lanka, College of Ophthalmologists, orthoptists, low vision practitioners, blind schools, and Department of Social Services, and etc. So this is a very smooth, trouble-free, and transparent policy. And once it's approved, or once a policy is approved, so you can make a budgetary approval and allocation and implement. And not only that, so you have to at least review once in 3 years this policy, how it is, whether it's effective and efficient. If not, you have to review and readjust. So this is the thing behind this, the particular alternative. So these are my annexures, my summary. Childhood blindness, again I'm stressing this point. Childhood blindness is a group of diseases and conditions occurring in childhood, early adolescence, which if left untreated result in blindness or severe visual impairment, that are likely to be untreatable later in life. So if you neglect it, it's too late to treat later in the life. So 80% of these cases could have been avoided or prevented if treated. So this is the part of it, because 80% of the blindness can prevent if you treat them, or if you identify, if you have strategies. So our goal is to eliminate avoidable childhood blindness in Sri Lanka by 2025. Alternative 1, let me see, V for vision and AC. I made 3 alternatives. A1 is the economically viable and socially acceptable. Then my plea is never make them blind, please. Thank you. If any questions, I would like to answer.
ප්‍රශ්න තියෙනවා. මොනෑම ගැටලුවක් තිබෙනම් ඉවසන්න පුළුවන්. මහජන අක්ෂි සෞඛ්‍ය පිළිබඳව කතා කරන විට ලදරු සහ ළමා අක්ෂි සෞඛ්‍ය අතිශයින්ම වැදගත් කාරණයක්. ඒ කාරණාව පිළිබඳව ඔබ දැනුවත් ජ්‍යෙෂ්ඨ ඍජු නේත්‍රඥ ජේ.යු. සීකුබදු මහත්මයා එතුමාට සමරු තිළිණයක් පිළිනැමීම සඳහා මම මෙය කැඳවන 306 බි ऐक्या सिंह समाजे सभापति दृष्टि लाहिरु मालिंग
The next speaker will be Professor Kovin Naidu, Senior Vice President, Social Impact. He will talk on the public health response to the refractive error change.
Hello everyone, can you hear me clearly? Can you hear me clearly?
Yes.
Okay, great. Thank you. And thank you very much to Naresh and the team for inviting me to this important event. I have very fond memories of my time when I was CEO of Brian Alden of visiting Sri Lanka and some of the fantastic work that was happening there, especially in collaboration with organizations like Sightsavers, etc. So I'm just going to start sharing my screen. And if somebody can just tell me whether you can see my all right, can you hear me? Can you see my screen? Could somebody just tell me if you can see my screen, please?
Yes, we can.
Okay. All right. So my topic is public health response to the refractive error challenge. Now, I've been listening to some of the other presentations, and I know increasingly optometry says that the way forward, which is correct, would be ideally for us to be able to have this approach to optometry, which we know is good for our communities, where we are the base for comprehensive eye care, and that through that we will grow optometry. Now, after doing this for more than 20 years and hearing that for many, many years, I have to say with the greatest respect, we have achieved very limited progress in that. There are specific countries that have achieved limited progress, but a lot of countries have failed to. The reason being that optometrists are often not at the public health table. They are not contributing with governments to help them to build access to eye care. And when we go there to talk about benefit what optometry needs, there is a cynicism that emerges about what public response to refractive error as the issue that opens the door to get us to the that give us the opportunity so that actually society. And I've been trained through the of optometry in the US, studied in South Africa. I live in South Africa now and have my PhD from University of New South Wales. So I've seen the different models, and I must say that there is a very different way that we can think of public health, not in terms of just contributing to the society, but being the leading edge to build the relevant. By Estolo Luxottica, I'm in the social impact division. So don't ask me about any of the lenses and the sales, etc. I'm very much just in the social impact division, where we look at creating access to eye care in the world. So, and I think Prakash referred to this. In our very first meeting with the WHO, Brian Olden and I and Nagrao had arguments with the World Health Organization. They did not consider refractive error as necessary for blindness and vision impairment, and in fact left it out of this graph. And we then did a study in Africa, which was a population-based study that showed that only 20% of the population who need access to glasses actually, or spectacles, actually get them. And other such studies were conducted in India, Nepal, China, etc. And that data we used to convince the WHO that refractive error contributes to blindness, because that data showed that people are going blind, are living blind because of refractive error. It's not permanent blindness, it's avoidable blindness mainly, and very significantly in vision impairment. And when that data was reorganized, and we see that the 2015 data was looked at by the Global Burden of Disease Study, and when we sat as part of that group and looked at the data, what we found that was refractive error was the second leading cause of blindness and the leading cause of vision impairment, which immediately said that given that the primary function of optometrists across the world is one of providing services around refractive error, that this profession of optometry is at the cutting edge of addressing vision impairment and blindness in our world. But I want to go back here and say that there was good news. There was good news because there was news that showed that there was a decrease in the prevention of blindness as well with the 2015 data. However, we concurrently, as many of you know, published a paper on myopia, which showed that close to 50% of the world's population, which is 500 million people, will be myopic by the year 2050. And this is mainly due to the lifestyle changes that are occurring in the world right now, with children spending more time indoors, more time on digital devices, but most importantly, less time outdoors. And suddenly we're seeing that while other conditions, even refractive error blindness, has been decreasing, there's a spoiler alert essentially, and there's a real threat that myopia would become the leading cause of blindness. The chief showed me that I myself found it true. And even it would increase by 4 times to 28 overall trend, in excess of 50% by the year 2050. And in South 2050 at 53, this number was only 14.4%. So yes, all have myopia, that's fine, we can increase access, etc. But the problem when it comes to blindness and vision impairment is that it increases the risk of ocular pathology that will cause permanent vision loss. And as a result of that, we could have blindness and vision impairment gains that we are showing with the current data all being reversed. So we know that myopia is a growing visual problem, and it brings early onset cataract, particularly PSC, glaucoma, retinal detachment, and myopic macular degeneration, which has increased, or myopic maculopathy as it more commonly being referred to now. And we know myopic maculopathy is going to be the disease of the future in our profession. We have to be on the lookout for it. We should ensure that optometrists are capable of diagnosing and being able to respond to this. We know there'll be atrophic retinal changes in the macula. There's atrophic retinal changes in the macula, but most importantly, subfoveal choroidal neovascularization. And we know that this is a major problem because in age-related macular degeneration, billions of dollars have been put behind it because it's the leading cause of blindness in the US. And yet we still don't have the most appropriate tools to prevent it or manage it as effectively as we want. So this would happen in the presence of high myopia. Glaucoma prevalence will increase. And we know right now ophthalmology and optometry have failed dismally in being able to address glaucoma, mainly because we don't have a cost-effective screening tool or a simple screening tool. So staphyloma will increase, as you know, because stretching of the sclera as a result of the axial length increase. And that could lead, obviously, to retinal holes or retinal tears, retinal detachment that could occur. And we know that in many countries, especially the developing world, we are battling to meet the cataract and diabetic retinopathy challenge. Can you imagine now having these increased ocular pathologies which in many ways are much more complex? The risk is staggering: 40.6 times risk of myopic macular degeneration, 21.5 times risk of retinal detachment if your prescription is -6 to -9, 5.5 times risk of cataract PSC, and 2.46 times risk of glaucoma. So the numbers speak for themselves. And beside the clinical effects, we know that poor vision has a real social and economic impact. Uncorrected poor vision is now one of the largest unaddressed disability in our world. Okay? And I'll talk a bit about the productivity loss from myopia, but we know that there's a 2.72 billion loss in productivity every year as a result of uncorrected refractive error. And many of you would have seen the paper we published in that respect. 1 in 3 people live in the developing world, and I told you about the myopia. So we know what the 272 billion was, a bit older figure that we published very early. But let's look at what productivity loss is going to happen because of this new scourge that we're having called myopia. For persons with myopia, there would be a $244 billion per annum in lost productivity as a result of myopia. Okay? Now, go back to the slide where I spoke about the increase in prevalence and you're understanding what the cost to society is going to be. And for caregivers alone, for blind people, for people who can't work, etc., is $27 billion, right? Myopic maculopathy will cost $6 billion per annum, okay? Now, there are studies that we did and others have done which are showing that between 37 to 40 to $50 billion, we can solve the problem. But the world doesn't work like that. Governments won't invest in solving the problem, creating the infrastructure, expanding the number of optometrists to ensure that we can respond because they could save this money, because many of them think about the economics in the period that they are in power only. But there's been a lot of positive developments. Let me not sound gloomy. We had the Global Action Plan. And in 1999, I was part of the committee that sat at the WHO and developed the Global Action Plan. And there was resistance to the inclusion of the word optometry. But for the first time, optometry was separated from allied health professions, and we were able to get clear targets for optometry development. Have we used that? Have we benefited as optometrists? Absolutely not. Because as a profession, we are notorious for social media activities. We are notorious for conference activities and amazing speeches, but we are very weak as a profession globally of engaging governments, using these WHO documents and turning those into advocacy and policy change gains. We are extremely weak at it, and we convince ourselves repeatedly that we are making great progress as a profession. And I would say that we have made limited progress is the word. The Eye Alliance report was published by the World Economic Forum, again, elevated us in the private sector to another level. Have we been able to leverage of that? Limitedly. And that spoke about the importance for eyeglasses to be provided to people. The World Report on Vision was a great advancement. Again, I was on the editorial committee, and when we were putting the report together, reviewing the putting the report together, it became very clear that we needed a much more broader approach, not because of optometry, but because of the limited progress that we made. We set out to say that by 2020, we'll eliminate vision impairment due to avoidable blindness. We didn't even come close, right? And this report is significant because it talks about the Sustainable Development Goals. It talks about an integrated approach. It talks about ophthalmology, optometry, allied health professions, etc., working together and carrying out this campaign. It doesn't talk narrowly about professions and how you help professions. We looked at the problem, we looked at the people first and worked backwards from there. And it showed similar results. 1 billion people affected, almost 900 million is uncorrected refractive error distance from near. The Global Commission, Health Commission, entrenched those same results, but created an academic platform to make an argument. They spoke about sustainable development goals, urgent action, improvement quality, outcomes, and cost-effective care. I don't have time to go through all this, but the UN passed a resolution as well recently, which is a great victory, that talks about, that asks the Director General to prepare in consultation with member states recommendation on feasible global targets for 2030 on integrated people-centered eye care, focusing on effective coverage of refractive error and effective coverage of cataract surgery for consideration by the 74th World Health Assembly in 2021. And the World Health Assembly has already set a 40% coverage of refractive error by 2030. Again, our core business is in the forefront of UN resolutions, World Health Assembly, etc. We must be careful not to make the mistakes of focusing on the excitement, but roll up our sleeves and start delivering at a country level. The SLO report, Eliminating Poor Vision in a Generation, and we have put forward a plan to eliminate uncorrected refractive errors by 2050. We used the 612 cutoff, not the WHO 618 cutoff, and we showed that 2.7 billion people need eye care and cannot get access to eye exams and refractive correction, which is staggering numbers. It tells you we are busy tripping over each other to serve limited markets when there's massive needs in our society. Spoke about all this. And we also showed that we need $14 billion to create a world free from refractive errors. $14 billion, that's not a lot of money, okay? Which can support training. So 2.4 billion to create sustainable access points, 0.7 billion to innovate for affordable products, 2.4 billion to create sustainable access points, private practices, public health clinics, vision centers, etc. But look at the figure in green, 4.5 billion to raise awareness. And the question you should ask yourself today, how many optometrists in their practice on a daily basis invest in creating awareness? We are too busy with price cutting or advertising prices, which anyway is necessary because we need to keep affordable products, but we don't think holistically. We don't see refractive error as something that can grow the traffic to optometry, that can allow us to be able to provide services. Are we telling our patients that time outdoors is important, that you need at least 2 hours a day for your patients to be able, for your children to be able to delay the onset or prevent the onset of myopia? If we are prescribing and we're not telling them, we are falling far short. Because tomorrow somebody else, another colleague will do that and they will be the myopia expert. Yet myopia is something every optom should be doing, okay? And we need $6.2 billion for philanthropy and charitable efforts, okay? So that's a huge number that we need. The most is going to be for that because the poorest of the poor in the world cannot afford optometry services, and we have to face that. And governments are not allocating funds towards that. I remember in Sri Lanka, you had an eye care fund and people would complain that within 2 months, the government's fund was depleted, right? It was a great policy. I'm not sure how it is now, but it doesn't last. We need affordable. I've spoken about all this. So we have had more some vision in existence for 10 years. Always funds from diabetes, work with the mental health professionals. We need to work with nurses, with people in road safety, in school IELTS, work with people that are interested in poverty education. We have to take the UI space at K development perspective. And there's a whole lot of things like advocacy and awareness, integration and government engagement, sustainable. Do not stand up and say that I have the solution. Whether you're in the private sector, whether you're in the NGO, or whether you are in government or in education. We need a multifaceted approach because people in society are varied. The public sector should provide for the poorest of the poor. Those who don't have 2 cents to rub together cannot buy food. They're not going to buy glasses. The NGO sector and inclusive businesses or social enterprises need to focus on the working poor, those who can at least buy product at a low cost. And here optometrists are failing dismally. We stay in our practices in big cities. Our numbers are low and we keep talking about how we're the most important and will reach everyone. When we know it will take 100 years for the trend. So we need to start thinking about how we can reach that. And then the private sector of the observation delivery, telemedicine opportunity. We in 5 years, so by the numbers don't stack. The number of people of that. What we need, can we use telemedicine? We have a technician trained at the under control of an optometrist, be an outlet, and be in that loop and ensure I can. Important debates and discussions have to retrain. Yes, optometrists 4 years. Yes, optometrists with diagnostics. Yes, optometrists with therapeutics. I'm not opposed to that. I'm trained in therapeutics in the US. So I know the value of all of that. All I'm saying is we may have to bring other people into the equation and we need to have that discussion and debate, as difficult as it may be for some of us. And we need to look at refraction too. Just to give you an example, we've developed as SLO the click check, which costs $50 compared to an auto refractor cost. And it gives you the same results. In underserved clinics where sometimes the numbers may not be the great, or even if the numbers are great, you can have a technician going from person to person using this tool, measuring the refraction, getting you the outcome of an auto refractor. Let's start thinking differently. And let's look at affordable products. Can't keep the margins that we have in the big cities and in the malls and hope that those margins are going to sustain the expansion of spectacles. I've spoken about tele-refraction. So we need access to affordable correction, education, practitioners, and partners, the eye patient alliance, all of those, advancement in research, and we must help each other. For example, from my university in Durban, give PhD master's scholarships to students and free. They stay in their home country and study. I've got students in India, Pakistan, I've had in the US as well that have registered and are able to get the master's PhD and become faculty in their country. But we need to focus on effective. I'd ask you to read about the Global Myopia Coalition. My time has run out. Where we are creating, myself and Matt Overding from Treehouse Eyes, we came together and we came up with this concept of the Global Myopia Awareness Coalition, pulled industry together and WCO and other partners. We raised $1 million now, about $1 million a year we're raising, and we're using this to create awareness around myopia. So industry will support efforts such as that, but you need to be able to come up with plans. This is the only way we can reverse the trend of myopia and the trend in refractive. We have to think and act differently, or history is going to judge very harshly as a profession. The UN, the WHO, all are saying we are important. All are saying that this issue that is our baby is important. And if we don't stand up and be counted, history and future generations of optometrists are going to judge us very harshly. Do this together, we can eliminate poor vision by 2050. Here's my details. If you want to reach out to me, I'm happy to have further discussion with you. Thank you.
It was so interesting. Thank you very much, Professor Naidu, for your presentation. And thank you, fellow optometrist Suranga De Silva and optometrist Prabhamali Siruvadana, being here with us as the moderators. I'm sure we have approached an end of a thoroughly informative day of knowledge gathering. I would like to now call upon for 5 panelists, namely Professor Madhuvanti Disanaika, Consultant Eye Surgeon, and Professor Kovin Naidu and Professor Asrin E.B. Arfin, Mr. Deepak Shah and Professor Kovin Naidu and Dr. Rajiv Prasad, and to be moderated by Senior Orthoptist J.U.C. Kubadu. All the others are virtual.
Good evening to everybody. I'm very pleased and privileged to be among great professors all over the world from 5 different countries. First, I will introduce the panelist. Professor Madhuvanti Disanaika. She's a consultant eye surgeon, former chairman of College of Ophthalmologists, president of College of Ophthalmologists, and professor at Faculty of Medicine, University of Colombo, Sri Lanka. Then we have got Professor Dr. Aswin Arfin. He's from CG University. He's the Deputy Vice Chancellor, CG University, Malaysia. Then Professor Kovin Naidu is Senior Vice President, KwaZulu-Natal, South Africa, now presently based in Singapore. Then Dr. Deepak Kumar Shah, National Coordinator at Vision Screening, Nepal. Then we have got Dr. Rajiv Prasad, is the Vice Chairman of Asia Pacific Council of Optometry, India, from India. First, while welcoming you all, I would like to start with a small story for you to begin with. It's easy for you all. So it's a story about Sri Lanka. So in 1952, in Sri Lanka, Vidyodaya University started the certificate course in optometry. That is a small, that's a great, big university called Vidyodaya. Then in 1961, Sri Lanka Optometric Association formed. In 1983, under the guidance of Dr. C. Clifford Parker from United States, School of Ophthalmic Technology started at National Eye Hospital, Colombo. And they have produced more than 200 ophthalmic technologies so far to the country. And in 2007, ICAR Institute, under the guidance of Tertiary and Vocational Education Commission, started. Then 2009, Ceylon Council of Optometry and Orthoptics started. They have started in 2009. It's a regulatory body, but still not registered under the Parliament Act. In 2009, Vision Care Institute, still again under the Tertiary and Vocational Education Commission, started. In 2010, Sri Lanka Optometric Association also started Diploma in Optometry under the guidance of Tertiary and Vocational Education Commission. In 2021, ICAR Institute, along with the CG University, started their bachelor's course of optometry. In 2022, Sri Jayawardenepura University in Sri Lanka starting bachelor's degree in optometry. This is the small scenario. I think I can remember when we start the School of Optometry, Ophthalmic Technology in 1983, Sri Lanka got students from Maldives, Pakistan, then Nepal, like South Asian countries. But still, Sri Lanka still producing certificate and diploma courses, but all the other South Asian countries have achieved their target. They have acquired bachelor's degrees in optometry, and not only bachelor's degree, master's and PhD as well. So I would like to ask few questions from the panelists. First, I would like to ask first question from Professor Azrin. I like your talk. I like your play. Inshallah, we should work together to achieve the common goal. Can you please elaborate on this? How your strategy, inshallah, how can we achieve this in our country?
Thank you, Mr. Sigavadu. The last time we met was a few years ago, and I was really enchanted by Professor Naidu's talk. Actually, we're so busy tripping over each other's feet that we have forgotten about the real issue of people not having the right pair of glasses. But I think I was probably talking to a more advanced audience. I apologize for it, but anyway. I make no apologies for telling people what my thoughts are. I think to answer your question, there's going to be a need to train basic optometrists to the level of the bachelor's degree. Many years ago, we all went to Australia to study optometry. And there was only the Bachelor of Optometry program at University of New South Wales, and there was a Bachelor of Applied Science. QIT then, it wasn't even a university. And there was this prestigious Bachelor of Science Optometry at the University of Melbourne. And things have changed now, obviously. I've not been back to Australia for many years now, but I've got friends and we still maintain our communication. But with the pandemic, things have actually changed the game. It used to be that people had to travel such a big distance to get a bachelor's degree. And I'm sure, gentlemen, I'm speaking from the point of view that things can be done online now. We can have fantastic lectures, for example, the one by Professor Naidu just now. I'm going to have to get your slides, sir, because I think they're very relevant and they're coming. They are slides from a practitioner, clinician, educator. That's very good. And if we can have common visiting professors who actually don't have to travel the distance to provide the latest info and also what's going on and what's really needed in the field of eye care and optometry. We could have a joint program in a way that some of the programs can be done in the home country, and the clinical part would have to be done in the university that offers or awards the degree. I mean, that you can't avoid that. The regulations are such that you need to finish off the degree programs in the country, in the university, in the country that offers and awards it. You can't have it online all the way. So to answer your question, regulations have been made easier now to ensure that some of the programs can be done online with proper monitoring and overseeing, provided the staff, the faculty, if you want to use the American word, are people of repute. Is that the right word? Of repute, yeah. So that is possible. And if you can't have it as a bachelor's degree in your country, it can be done in such a way that you have an advanced diploma, which transfers into a bachelor's degree at least. I was talking about the doctorate degree as well, but that's actually beyond. And I was pretty much influenced by the Australian way of thinking, and also what's going on in the UK. So that's my comment at the moment. It is possible with the kind of technology we have and with the kind of people that we have across the world. Thank you.
Thank you, sir. Is Professor Madhuvanti here? I think she's not here. Then the next question goes to Dr. Deepak Kumar Shah from Mayport, because he's well experienced and in the service. In your opinion, how can we eradicate the avoidable blindness as far as there's this present situation is concerned, with the existing the human resources and the infrastructure? It's over to you, Dr. Deepak Kumar Shah.
Thank you for the question, sir. Thank you. I don't think we can eradicate, but some way we can eliminate this avoidable blindness. I think that we need to start now only. We can't wait for it. We need to find the people, treat it. We can't wait for policies to come and address a child who is suffering from uncorrected refractive error at this present time and suffering, and who is not able to learn in a good way what he or she would have at school. So my first thing will be, what is the problem at the present? It should be sought out now, and then it should be started with prevention, promotion, and policies, integrating eye health into basic health services or general health services, or if we want to really eliminate avoidable blindness, then definitely our human resources should be community focused. So the curriculum of the optometry program, either it's a bachelor of optometry program, masters of optometry, or doctor of optometry program, it should be community focused. So there should be extensive portion of a community component inside, so that they can be more responsible towards their country community. So I think that these things are very much important, where if these things are being addressed, then definitely we can achieve for elimination of avoidable blindness faster, comparatively faster. Thank you, sir.
Right. With great respect, I'm asking the other experts, if you need to add, please raise your hand and add your valuable comments. It's not only one particular person, so even the others, if you need to add comments, you're welcome. The next question from Senior Vice President, Professor Koid Naudu. Out of 4 major obstacles mentioned here, first one is socio-economic standard, second one is education standard, third one is standard of primary eye care service, fourth one is policy gap. Out of these 4, what do you think, what is the major obstacle in the process of eradicating the preventable childhood blindness or the preventable blindness?
I do think that the most, thank you for that question. And just a correction, I'm based in South Africa. I think I lost you. Can you hear me?
Hello. Yeah. Can you hear me?
I think you're back now. Yeah, we're back now. We're back now. Can you
Yes.
hear me? I'll put my video off because I think that's affecting the.
No, you're fine.
So the so for me, the most important thing is policy change. What is optometrists faced as the huge barrier is laws in countries. And therefore, I make the argument that we have to drive the public health aspects, be at the forefront of delivering services so that we can influence the policy that allows for the training of optometrists to a degree level, that allows for social programs that caters for the poorest of the poor, that allows for the education subsidies, etc. And in many ways, all of us are guilty of this. That's the least of what we do. So for me, policy change is the most important issue. Okay, I'm done.
Hello. Yes. Thank you. And to Dr. Rajiv Prasad, it's over to you, sir. So when you considering this, the policies and the bureaucratic problems and policy implementations and the identifying the policy gaps and all these things, so what are the best the lessons that you have learned when you considering the other developed countries, or what is the role model that you can follow?
Right. Yeah, thank you so much. Thank you so much. I mean, what I personally feel is, when we really want to sensitize.
Sir, I can't hear you clearly.
Is it audible now?
No, your volume needs to go up, Rajiv.
Okay, it's fine now.
Is it better?
Fine.
Am I audible? Am I audible now? Not sure if I'm audible clearly.
We can hear you, Rajiv.
Great, thank you so much.
Yes, I can hear you.
Wonderful. So, see, I think the first and foremost, thing which I recently, I was talking to some international NGO, and the most important part is to sensitize the optometry community right from the school of optometry, where they are getting into bachelor's or diploma or master's, to sensitize them about community eye health. The major challenge which I see is, when optometrist passes out, I mean, they talk about diseases, they talk about, getting different rights, but the basic thing, from where actually optometry came from was refractive error and still being a challenge. And nobody ever, there is less people who's thinking about it. So if we really want next generation to work more on community eye health, more about, uncorrected catering, the unmet need of uncorrected refractive error, it is really important to include community eye health into the course in the optometry colleges, into the optometry course. So that will really help, to grow. And then definitely, second thing is, importantly, that to ensure that, to ensure that most of the optometrists who may not be willing to get into community eye care, probably the one reason I fully agree, endorse what Cohen said, that we are getting more notorious in getting the certain getting into certain areas, but we really never thought about community eye health. So it is all about that, to create awareness. And it is very simple. If we not, who will else talk about optometry? If we not, who is going to sensitize the public about uncorrected refractive error? If we not, then who would actually sensitize the government? Where are we lacking? How the economical and other losses which is happening because of uncorrected refractive error, and the important need of community eye health. And very well phrased by Cohen and other couple of speakers about myopia epidemic. I mean, this lockdown has actually, emphasized, that most of the globally we all are on Zoom and other lectures like now, and definitely the screen time has increased and myopia is definitely increasing. So awareness is needed, and the same thing, we have to do it. We'll have to include, we have to create awareness. Thank you so much.
Any panelists want to add something?
Yeah, let me add, this is Coven. I think, the South African example is maybe helpful. We had two strategies. And I think earlier on, Professor Azrin spoke about how you build the advanced optometry in the country. So we had that strategy that the institutions were driving. But we also had a concurrent strategy that we were driving through the Health Professionals Council around creating policies and rules to enable access to services, so that the Health Professionals Council becomes more than the protection of optometrists, but rather challenges around with us having diagnostics and therapeutics. The Health Professionals Council eventually passed a law supporting optometrists getting therapeutics, right? Which is going to happen as a postgraduate. So you do your undergraduate 4 years, and then you get additional qualifications, and you get up to therapeutics. It was opposed by ophthalmology. It was opposed, but not all ophthalmology. A lot of ophthalmologists who understand the need did not oppose it. But all the doctors on the Health Professionals Council from the other disciplines fully supported it, because our argument was that it was in the best interest of creating access. So I think that when we talk about community IR, like Rajiv is mentioning, it has to be inculcated earlier, and I fully agree with him, so that optometrists understand this dual role. Okay, we always have seen ourselves as mainly at the level of just trying to get a bigger scope of service. Now, you need the bigger scope, because I can tell you therapeutics is more needed in Africa than it is needed in the US. They have much more ophthalmologists. We don't have the ophthalmologists, we need it. It's more needed in Asia than in the US, okay, or UK. So we need this dual strategy to be developed, but that's not going to happen. And I just want to say that absolutely every generation of optometrists needs to be trained to understand this dual strategy, not just becoming good politicians, which is often what our optometry associations are. They're not public health focused organizations as well. I'm not saying you mustn't do what you're doing, but you have to have a public health focus. Thank you.
Thank you.
If I may add,
yes,
I think, is it okay for me to say something? It is?
Yes, you're welcome.
If I may add, the South African Optometry Association is a very powerful body too. I've got friends as well, and I think they've made great strides. In the early part of the fight to get diagnostics, and I think it's probably because of the numbers. There are more South African optometrists who are willing to go the extra mile, and the help that South African optometrists were getting from the US was tremendous as well in pushing the policy forward. But unfortunately, in Asia, it's not happening that way, and we've got, and I say this with apologies, that we've got dispensing opticians who are actually, with all due respect, of course, who are actually blurring the situation. No disrespect for dispensing opticians, but the fact that optometrists are also known as opticians in the UK, although it's actually ophthalmic opticians, and it's a very mouthful word. So, when you visit an optometrist in the UK, I mean, the average Tom, Dick, and Harry would not say, I'm going to the optometrist, they say, I'm going to the optician. So the word optician gets carried back to Asia, and the public just views optometrists, properly trained ones, as opticians who are able to sell glasses and do nothing more than that. I think in South Africa, that's probably not the issue. I might be wrong. You had the profession of optometry solid and when it started, I think.
Can I add something?
May I add, in terms of policy, just to Professor's response, sorry. We did have the problem as well. We had dispensing opticians. And when I was head of optometry, optometrists were not happy when I went to them and said to them, let's upgrade these guys and bring them within our fold. The first response, and this is the problem in optometry, we don't think more laterally about this. The first response is, you're going to destroy our profession, you're bringing these other people in. I said to them, you'd rather have, and excuse the language, I'd rather have somebody inside pushing out than outside pushing in, because once they're inside, they won't go and be to government and lobby against us. They will be lobbying with us. And we upgraded all those dispensing opticians to optometrists. And most of them, their livelihood was ceasing because ophthalmologists were not dispensing anymore. We were doing most of the dispensing. So also they, you needed to look at their livelihood issues, etc. Today, some of them are heads of departments in our countries, got PhD, etc. So I think we have to start thinking about how we address, and I think you're absolutely right. The dispensing opticians are there. Can we bring them in? Can we find a way to make them future optometrists? Can we do upgrading so that society sees this unified force that is driving the agenda? And that played a big role in what we did. Thank you.
I love this policy. Yeah, excellent. We're doing the same thing. Yeah.
Yes, sir, you can.
Yeah. I think that a small example can be taken from Nepal as well. This optometry program in Institute of Medicine is comparatively a community-based optometry program. So they gave ample of opportunity to the students to go in a community and know the problem of a community through community diagnosis. And community diagnosis is all again turned to a community eye health diagnosis by collecting the people, knowing their eye health problem and treating in the community itself. So it is a community-based learning somehow optometry program. The course which is designed at Institute of Medicine in Nepal. One thing, community component is also there. And we are privileged that we do optical dispensing as well as therapeutic dispensing. Our code of ethics, the code of ethics which has been passed by Nepal Health Professional Council in Nepal, has given us opportunities to dispense almost all of the major medical all of the major medicine in eye health. So we have got that opportunities, but parallel to that, but we have not been able to do more on the policy sector, like integration of optometry into government health services. We have some of the problem, but I think in South Asia, Nepal can be a small example of community optometry program, as well as providing therapeutics by optometrists. Thank you, sir.
Well,
thank you.
Yeah, can I add something?
Then I have another question from you, sir. What should be the role of international agencies or local bodies in curbing this avoidable blindness? Because we know that not only the local bodies, because we don't have a very strong local bodies in our country. So therefore, sometimes we urge, sometimes the pressure from the pressure parties make huge impact at the level of establishment or so therefore what is the role of international agencies in this particular matter, preventable blindness?
Are you directing it in particular?
No.
Okay, if others don't, I'm happy to answer that. I do think that the international agencies give much more political pressure than anything else, especially IAPB. We need to use WHO resolutions, UN resolutions, etc., as an opening to engage our government. They make a big difference. So for example, the Sri Lankan government, the Minister of Health, will have to go to the World Health Assembly on an annual basis and report on how much coverage of refractive error has been achieved and how much progress has been made to achieve the 40% coverage. Now, I can guarantee Sri Lanka, like South Africa or many Asian countries, US and all, don't have surveillance systems to respond to that. Most people don't. So I think the opportunity here is to rather use their what they're saying for optometrists to go to government and say, we'd like to work on with you to create the surveillance system, to create the access. How can we be of help? And how can we support? So, and use the political clout of these international agencies. Sri Lanka has also been fortunate that NGOs have been there, Sight Savers, Brian Alden, others have been there for many, many years. And I'm quite familiar with CBM and Chip Parker, the work that they did in the early days, etc. So I think it's important to also look at how you can get support and funding to rather create an example of what you can achieve as optometry. So for example, we got money from Standard Chartered Bank. There was hardly any optometrists in the public sector. In our province in South Africa, we implemented a model to integrate optometry into the public sector, paid for it for the first 3 years. And then after that, government took over, and now there is not enough positions available for the optometrists wanting to go into the public sector, whereas in the past they didn't want to go. So I think those kind of things, you need to influence the international agencies as to what model should be implemented. Because there is a problem. People go to Aravind, or they go to Alvi Prasad, or they come to South Africa and they see what we're doing, and they try to export models into your countries. Non-profits, we have done that in the past. I was part of it as well. And so it's not a criticism about others, because that's the funding we have. You have to shape that and say, this is what our country needs, and start engaging them and say, in order to create access to refractive errors, this is how you can work through optometry, and this is how what you can achieve. If we didn't do the Standard Chartered Bank project, most international organizations would not have supported optometry in South Africa and in parts of Africa. It's when we showed them the success, they then invested in Malawi school. When I had the idea about setting up the School of Optometry, it was the NGOs that paid for the setting up. Same in Mozambique, same everywhere. So once we show them what optometry can do, they start investing. But you cannot be saying, yes, boss, what do you want me to do? How can I help you? That is how we talk to people as optometrists. Maybe not in the crude way that I'm putting it today and abridging it, but our demeanor is that way. We have to show that we have ideas and we know what we do, because we do. Taking so long.
Okay, thank you, sir. Anybody want to add any comment? Add comments onto this? Then to Prof. Arfin, Asrin Arfin. So could you please make a comment on the role of stakeholders? Since you are very prominent dignitaries in this particular arena, and based on the very significant associations and bodies, government bodies and the NGOs, that's why I'm asking this particular question. What is the role of stakeholders?
That's a very difficult question for me, actually. I wouldn't be able to comment so much on that. I think for the benefit of the profession, the different stakeholders would be many, and the industries are part of them, and they play a very important role. But the people and also the organizations will need to be convinced, and that's the biggest task that we have, actually. And personally, my biggest task is actually to convince ophthalmologists that this is all for the good of the people, rather than just us trying to be known as practitioners. At the end of the day, the uncorrected refractive errors and the visual impairment is the aim. And as what Professor Naidu was saying just now, every year the Ministry of Health would have to go to the world body and answer to them, how much have you progressed? This is the first time I'm hearing this. I am so enthralled by this. Now I've got an idea. You know, the next time I speak to my medical colleagues at the Ministry of Health, I'm going to ask them that question, sir. But I'm sorry, Mr. Sikabadi, I wouldn't be able to answer the question on stakeholders that much. I lack the experience. I'm sorry. Yeah.
Yes, since stakeholders have different motives, So it's anyway, but you have to work with stakeholders as well. Yes, sir. Your opinion?
Yeah, yeah.
No. Yes.
Can someone else help me with this? I wouldn't be able to.
Naresh Pradhan, you want to add any comment on this?
Yeah.
I'm sorry about it. Yeah.
Can I? Yeah. Regarding actually, last discussion from Nepal, like our Deepak mentioned, the. Can you hear me? Yeah. And
yes.
then,
yes. Can
yeah.
you?
Then Deepak mentioned, so the therapeutic, level of care that a Nepalese optometrist gives. Actually, Sri Lanka is having from 1992. Actually, we have Ministry of Health has given a job description of having authority on diagnostic drugs. All the diagnostic drugs, the optometrist or ophthalmic technologists they can use, and then they can remove foreign bodies, do some, the diagnostic drugs are allowed here. So in Sri Lanka, one of the most lacking part, which since 2012 we have been discussing, Professor Azrin and myself, so that we have only up to diploma, and we now extended our further degree to our students to SEGI for the first time. And so this is one thing that we need from the so how we can implement BSc program as well as further program in Sri Lanka. That is what is one of the major needs that we have. And next thing is policy making. So policy making part, I suppose the Professor Naidu, Deepak, and as well as Dr. Rajiv Prasad, all these international figures, they will help us on this regard to bring Sri Lankan optometrists to optometry to uplift. And so our intention now, even Sri Lanka now say this is fourth generation optometry practice, and so first few generation, if you see, it's like in-service training. In a sense, they used to work in optical shop, and they start the optical shop, and very few people they are actually formally educated. So then second lot comes now from then we start first training those people who were already in the service. So people who were already in the service for 15, 20, 25 years, 30 years. Then gradually now for last, say last 4 batches, we get a fresh farmers from the A-level leavers, and their children, the optometrists or the optician children are coming into this thing. And so those people who has been already in the field for 20, 25 years, 30 years, we didn't have a hope that they will go for, they need to go further than diploma. So, but young generation who are, coming to IKEA Institute or coming to institute, and then getting done their diploma, we don't want to stop them to their diplomas. We want them to go further to degree and the masters. So thank you for Segi University to open this door, and we hope further these doors will be open. We can establish this program in Sri Lanka itself. That is what is our dream. One thing that we want to establish in this country. And other thing is, we want, actually, there have been lot of struggle, like now the person who is moderating, my senior, Jayu Sikru Badu, Professor Azri knows, his lot of commitment is there to uplift this industry. So we want further, to enhance, all of you will support us to, uplift this optometry practice in Sri Lanka. As Professor Naidu is very much familiar with Sri Lankan scenario also, as Brian Holton Vision Institute past CEO, right? So we hope you all support on this manner. So thank you very much.
Okay, thank you very much, all panelists, and we hope your the active participation and contribution in future endeavors as well. Thank you very much for participation. Thank you.
Thank you. Thank you, everyone.
Thank you.
Thank you, everyone.
Thank you. Thank you, team. Thank you.
Thank you very much.
සුබ සන්ධ්‍යාවක් වේවා. මහජන අක්ෂි සෞඛ්‍ය අන්ධ බව දුර්ලභම IKEA 2022 අවසාන භාගයේ දැන් කටයුතු සිදු වෙන්නේ. ඉතින් අද දවසේ ශ්‍රී ලංකා දෘෂ්ටි සේවාවට ඊ타ත්ම අනර්ග මතක සටහනක් ස්වර්ණමය සටහනක් තබන්නට හැකියාව අපිට ලැබුණා. අපි ඒ පිළිබඳව ශ්‍රී ලංකාව වශයෙන් සතුටු විය යුතුයි. ඉතින් තවත් සුවිශේෂී කාරණයකට තමයි අපි මේ මුල පුරන්න සූදානම් වන්නේ. මේ සියලු කටයුතු මාධ්‍යයේ එම කාරණා ඉටු කිරීම සඳහා අයික්‍ය නිර්මාතෘ උපදේශන දෘෂ්ටි විශේෂඥ අපේ ගුරුතුමා නරේෂ් ප්‍රධාන මැතිතුමාට මම මේ අවස්ථාව ලබා දෙනවා. එතුමා විසින් ඒ කාර්ය මනාව ඉෂ්ට කරන්නයි දැන් සූදානම් වන්නේ.
So today, we are coming to the almost final session, and I'm going to introduce, so today our key speaker is none other than Dr. Asela Avedira, right? So I think I don't need to introduce yourself, about him. So, but just for a little description that I'm going to talk to you about him. Dr. Asela Avedira, he is a South, man from Matara, right? And most of the South people, by nature, now our Sikubadu also is from South, right? And most of the giant business people in Colombo, they are all from South, right? And South is known for that, right? Something that they take, they are, they are dedicated to that, whatever the resistance comes, right? So that is nature of South that we see. And that same kind of a blood that he carries, and we have seen him a lot of up and down, and the fight that he has done for Vision 2020 to establish. And so I don't think, I have to completely rewind all those things, because of everybody has already witnessed, other than few newcomers who does not know about him. And in future, you will work with him and you will now come to know. And he has been, his primary education was done at Sudarsana Model School, and secondary education was done in Rahula College, Mahatara. Entered to medical faculty of University of Runu, right, and Karapiti Gaul, and he started his career as a junior doctor and under Dr. Manil Pascal, right, in 1999. And he started involving in his, community activities and research since the first appointment. And 2001, he got the best paper for a, ophthalmologist congress of College of Ophthalmologists. And 2006, he was granted for a full exclusive program for the master's degree in community eye health. And right, so and then 2007 he was being appointed as a coordinator for Vision 2020, and which we know, lot people knows his work on what he did on Vision 2020, and which level of eye care services was taken to, and what kind of activities that we have done in that period. We all know that, right? And so fortunately, I know that Dr. Asela fight for us, actually for Ministry of Health and as well as College of Ophthalmology to recognize Eye Care Institute optometrist as an optometrist to work for a community, this school eye examination programs. I know what struggle that he has put, and our students, they got an opportunity, our optometrists, they got an opportunity to recognize under the Ministry of Health to work, so that's always that appreciation I always have toward you, sir, and we always boo for you. Right? So then, so same, you all know that Association of Ophthalmologists, he's the, pioneer. He's the one of the, he founder. And then, so if you take about in his period of time, this, whatever we are talking, this blindness percentage, 1.1, 1.7, all these things, actually that is a major work was conducted by him between 2013, 2015. He's the one, who initiated those programs, and the walk from Batikulo to Colombo was the first, longest work that was conducted to raise the fund and for to make the mobile bus. So bus is pending, but still dream is dream is processing itself. He is still working on that, and we hope in future that all those things will definitely make definitely bloom, sir. There is no doubt, right? So time will take, but it will definitely happen, because this community needs, we need to fight against this avoidable blindness. Definitely to fight that, all those activities that you have done will definitely make a shape, and we will be always with you. And so, finally what we have to say is, so very recently you must be seeing him riding a bicycle from home to to the office, and then so he is in that campaign. You must be seeing him regularly. And so especially what I remember is this, what I see is this: why Nepal has got 0, Sri Lanka got 1. What always I believe is this: Nepal got Dr. Yantamani Pradhan, Nepal got Dr. Rohit Sanduk, Nepal got R.P. Pokhrel. All those surgeons, all those ophthalmologists, actually, they work for the community, right? And so those that, now Dr. Yantamani Pradhan, he was working in like your Bihar Mahadev Park, what we have Bihar Mahadev Park, they are called Brikuti Mandap. They are with a 4-meter cloth, with 2 orphans he took from the road and trained those 2 people as assistants, and he started his journey, right? So, right, and they see the R.P. Pokhrel, in 30 years, he made 30 eye hospitals and 246, satellite clinics, right? So which is, he has reached, his biography says, reaching and unreached, right? Reaching and unreached, which he gave me when he came to SARC conference in 2006. And right, so I got from his hand itself, right? And if you take about Sanduk Rohit, who has 50,000 cataract surgery, and then he is, say, not only for Nepal, actually he runs about more than 40 countries, right? So Tilganga Hospital today, they train even for USA, Canada, Japan, Australian. Ophthalmologists are trained there, right? Yeah, right. So then optometrists are trained there, IOLs are manufactured there, and so he carries the cheapest cataract surgery in the earth, right? One surgery, right? So still, Chanduk Rohit house, the road does not reach today also, right? Today also. So today, if you take in Nepal, if a president talks and Chanduk Rohit talks, people will listen to Chanduk Rohit, not the president. So people have such a belief on Chanduk Rohit, right? So this is what is one reason why, the public figure, since eye care professional has gone to, that surgeon has gone to, that ophthalmologist has gone to such a professional level, in a public figure, so that people start to listen to them. Like, so this is what, one thing, that if we want to uplift the condition, one thing, all infrastructures has to be developed, and some leaders has to come. Now today morning, Dr. Amila Dialvis also mentioned, what we are lacking is leaders. We have all these things in order. Only thing is, there is no leader to, right? So, and then, so actually we had a leader, and some incidents are there. So we will have again and again, and we have to, we don't need to wait for the circumstances, and we hope the leadership will, will shape it itself. And so this is not other than, so we are expecting you as a leader, Dr. Asila Vidria. So thank you very much for your, please, can we have your keynote speaker?
Sorry, mic was not on. So good evening, ladies and gentlemen. Specifically those who are here, ophthalmologists, optometrists, eye care managers, eye care planners, policymakers, and all those who are interested in eye care. And I appreciate what Naresh has been mentioning about me. So I don't know whether it's
all are, is too much. So actually, thanks, and thank you for inviting me to deliver this keynote address at this occasion when you are completing your 15 years anniversary. 15 years ago, optometrist Naresh Pradhan has started this small institute called ICA Institute. I think he may never have thought at that moment that he will go to this extent to become such a big organization, one of the leading optometric organizations in the country, and training a lot of people, changing their minds, making people not just do optometry, but to serve the country, to look at the big picture, look at the human values, and train people who can be in the community, be a part of the community, and to understand people's problems and give solutions. So that's what called community eye health. So community eye health is to serve people, to uplift their vision, and thereby improving the quality of life. So in 1999, World Health Organization and the IAPB, International Agency for Prevention of Blindness, has inaugurated a global eye care program called Vision 2020. In year 2000, Sri Lanka has also become signatory to the program, but the real program has been started in 2007 by the Ministry of Health along with the College of Ophthalmologists of Sri Lanka and many stakeholders. As Siku mentioned about the stakeholders' role. So it was a great role of all stakeholders while we were starting the Vision 2020 program. So the Vision 2020 program has opened up new avenues in eye care in Sri Lanka. So the Vision 2020 program has addressed infrastructure development, human resource development, and disease control. So under disease control, we were looking at glaucoma, diabetic retinopathy, refractive errors, primary eye care, and childhood blindness, all the topics discussed today. And the most important thing which has been mentioned over and over again by the expert professors overseas and the delegates, the speakers local, is the policy change. We need to have a correct, clear policy in eye care in the country. Nowadays, we are lacking that. So when we had the Vision 2020 program, just to recapitulate few things, we were able to do a lot of programs, projects to uplift eye care services, cataract surgeries, hundreds of thousands of cataract surgeries, which are free and offered for anyone who is living in Sri Lanka, especially marginalized people who are living in far and away areas in the north and east after the post-war season. And one of the most important projects we were conducting was that the school screening and free spectacle program. So for that program, we had to, the human resources we have in the Ministry of Health was not adequate. So we had to get more and more people into our team to conduct this program. So that time we have Eye Care Institute, we had Sri Lanka Optometric SLOA, and then I had to go back and prove that these people are qualified, knowledgeable enough to go and screen school children. So we were able to screen all 4 million school children in Sri Lanka and to give away over 300,000 free custom-made, good quality, low-cost spectacles. So that was one of the great achievements we had. And in addition, we had a lot of primary eye care programs, glaucoma, diabetic retinopathy screening programs, infrastructure development programs, every eye in the country. Especially we paid attention towards the north and east after the war. We were regular visitors to the north. And I can remember when just after the war, there were a lot of, 300,000 refugees were there at Chetikulam in Vavuniya, the IDP villages. So we used to visit IDP villages every 2 weeks for several months, and we have seen over 10,000 people who were suffered with war, and we have given away 5,000 spectacles free of charge. That was one of the programs. And thereafter, the program was, developed a lot, and the Vision 2020 program has become one of the global models. The delegates from other countries visited to Sri Lanka to see how Vision 2020 Sri Lanka was operating. So things change with time. Programs come and go, and things change. So at the moment, the deficit we have is there's no national program for prevention of blindness Sri Lanka conducted by the Ministry of Health, conducted by the government. So we need a big policy change. We need to have documented policies, documented plans to be compiled for the next 5 years, 10 years, and to reinstate a good national eye care program for the country. So eye care is not only conducted by the Ministry of Health or the government, or by the organization, but eye care is a responsibility of each of us who are in eye care services. So as I can remember the professors overseas were mentioning that the responsibility of optometrists or the optician or dispensing optician is not just checking the spectacles and selling or giving away the spectacles. So I can remember one of the most respected ophthalmologists said that there's always a person behind your eye. So it's not the eye you are treating the person behind the eye. And eye care services has become so specialized that you don't recognize that there is a person behind eye. There's a joke that a person went to an ophthalmologist and said, "Doctor, there's a problem in my left eye." So the doctor said, "No, I'm sorry, I'm specialized for the right eye. You have to go to the other doctor." So we are becoming so specialized, we are becoming so subspecialized, and we forget that there are humans, there are living individuals behind the eyes. So we need to we always need to remember that. And the other thing is that when we work together, we need to have a common forum like we had a few years ago. As Sikupad mentioned earlier, we need to have a stakeholders forum. So earlier we had a stakeholder forum composed of the Ministry of Health, the college, and the Ministry of Education, Ministry of Social Services, and optometric organizations like yours and SLOA, and the international non-government organizations, INGOs, NGOs, Sri Lankan charity organizations, a collection of say like 30-40 people gathered biannually and taking decisions, making plans, and looking after what is being happen, and evaluating end of a year, evaluating what's going on in this country. And when plans are made, plans are submitted to the stakeholder forum, and they are getting approved. So we ensure that the IKEA plans are endorsed by the responsible authorities and implemented. The other most important factor is that the leadership. As Naresh mentioned very clearly, the leadership. We had a very good leader when we were having the Vision 2020 program. That was none other than Dr. Palitha Mahipala. He was the Director General of Health Services at that time. So he has taken the lead, and he has supported us in every event, every step of the program. So that was one of the successes behind our program. So now I know now we are very much behind the schedule, so I don't want to take much time of yours. And when IKEA Institute is completing 15th year of their life, and there are more years to go, more developments are to be made, and more services are to be offered to the community. So at this moment, I wish optometrist Naresh and his team all the best, and may you have all the strength and courage to serve more people and educate more people to do community eye care services, and contribute towards a better country with people with better vision and better eyesight. Thank you very much. Good night, everyone.
ස්තුතියි අක්ෂි අසේල අබේදීර මැතිතුමනි ඊටම සතුටුයි අද දවස ඔබතුමාගේ ප්‍රකාශන ඔබතුමා කළ කී දේ ගැන අපි ආඩම්බර වෙනවා. ඉතින් මේ අවස්ථාවේ එතුමාට සමරු තීරණයක් පිළිගැනීම සඳහා මා ගෞරවයෙන් ආරාධනා කර සිටිනවා IKEA නිර්මාතෘ උපදේශන දෘෂ්ටි විශේෂඥ නරේෂ් ප්‍රධාන් මැතිතුමාට. පාලුස්වසරක් IKEA පැමිණි ගමන් මඟ තවත් ඉදිරියටත් මීට වඩා සාර්ථක කර ගැනීම සඳහා අද දවස උපයෝගී කර ගැනීමට අපට හැකියාව තිබෙනවා. ඉතින් මේ සියල්ල ඉෂ්ට කිරීම තුළ තිබෙන්නේ ශ්‍රී ලංකාවේ හෝ ලෝකයේ සිටින ඕනෑම කෙනෙක්ගේ ඇස පෙනුම සුරක්ෂා කිරීම. ඒ අරමුණ කරා යන ගමනේදී සිලෝන් IKEA දෘෂ්ටි විශේෂඥයින්ගේ සංගමය 306B කොළඹ IKEA සිංහ සමාජය IKEA දෘෂ්ටි අධ්‍යාපනික ආයතනය සම්පූර්ණ කැපකිරීමෙන් ඕනකමින් මේ කටයුත්ත කරලා තිබෙනවා. අපි හැමදාම හැමතැනම මේ වගේ කටයුත්තක් සිද්ධ වෙනකොට ඒ ස්ථානයේ සිද්ධ වෙච්ච දෙයට අපි සහභාගී වෙනවා අදත් හෙටත් හැමදාම. ඉතින් වැඩිදුරටත් කතා බහ කරන්නේ නැහැ. මම ගෞරවයෙන් ආරාධනා කර සිටිනවා සිලෝන් IKEA දෘෂ්ටි විශේෂඥයින්ගේ සංගමේ ගරු සභාපතිනිය දෘෂ්ටි විශේෂඥ නිසංසලා ප්‍රනාන්දු මහත්මියට ස්තුති කතාව කරන්න කියලා. ඉන් පසුව අපි ඉෂ්ට සිද්ධ කරනවා මෙතන කේක් එකක් කපලා 15 වෙනි සංවත්සරයේ සැමරීම කරනවා. ස්තුතියි.
Good evening, all. I dream it a great honor and privilege to propose the vote of thanks on this memorable occasion. First and foremost, I thank our special guest on this IKEA 15th anniversary celebration, Consultant Eye Surgeon Dr. K.A. Salvin, President of College of Ophthalmologists. Thank you, sir, for finding time to be here from your busy schedule. Your words and presence here encourage us. I would like to thank guest of honor, Consultant Eye Surgeon Dr. Manuel Pascual, and all the Consultant Eye Surgeons, Dr. Amila Dialvis, Dr. Nalien Gunasinghe, Dr. Asela Bedira, who participated in this program. I would like to thank also Senior Optometrist J.A.C. Kubadu for participating in this event. And Chairman of Vikramarachi Optician, Mr. Mihira Vikramarachi. So thank you, sir. And Senior International Athletic, Miss Vijay Sundara. Thank you, Miss, for participating in this event. Thank you very much who are participating through the Zoom, Professor Dr. J. Azin, Professor Kovin, Dr. Rajiv, Dr. Parkash, Optometrist Junu, Optometrist Deepak, and Regional Coordinator, Mr. Subkota. Thank you very much for your valuable time. I thank all the distinguished invitees present here accepting our invitation. I thank all the sponsors of today's program and media persons. I would like to give my heartfelt thanks to Program Director of IKEA Institute, Senior Consultant of the Matrix Naresh Pradhan, our Guru, and Madam Chairman of IKEA, Senior Consultant of the Matrix Damika Deshapriya, Madam, who always provides support and guidance to make the event and IKEA better. I thank Nilus Advertising for the lighting, backdrop, and Royal Steps Media for video recording and live coverage to take this historical event through the world. Also, I thank all who are watching us through Facebook and YouTube. Last but not last, I give special thanks Optometrist Hemidira for your commitment through the event. I thank students of IKEA Institute, member of Ceylon IKEA Optometric Association, fellows, and director board for cooperating and dedication to make this event success. Another special goes to our group leaders. Can you come forward, our group leaders? Can you come? Optometrist Nishamani, Optometrist Chatuni, Optometrist Sandun, Optometrist Prabha. Can you come forward? Sandun? Give a big clap for these people. During these 6 months, they did a great job. They helped us to do this event success. We are starting 6 months back. They did a successful program through this 6-month period. So thank you very much for your dedication. I apologize if I miss to mention among names. As a chairman of Ceylon IKEA Optometric Association, I wish IKEA all the very best on this 15th birthday celebration. Thank you very much and bless you. God bless you all. Thank you. Sorry, I forgot to mention this. Very sorry. And I also like to thank our presenters, optometrist Ranjit Premaratna, optometrist Nishamani, optometrist Deshamani, and IKEA student Ms. Sulakshana. You did the program very nicely. Thank you very much.
th anniversary of IKEA Institute. I'm pleased to invite the program director, the founder IKEA Institute, consultant optometrist Naresh Pradhan, and chairman IKEA Group, Madam Damika Deshapriya, to cut the cake. And also, senior orthoptist J.U. Sikubadu, could you kindly come forward, sir?
පහළොස් වසක අතීත ආවර්ජනය කරමින් ජයග්‍රහණ භුක්ති විඳපු IKEA ආයතනය අද සුවිශේෂී සටහනක් තබන මේ අවස්ථාව IKEA නිර්මාතෘ නරේෂ් ප්‍රධාන මැතිතුමා ඒ වගේම IKEA ජාල සභාපතිනි ධම්මිකා දේශප්‍රිය මැතිණිය ඒ වගේම අපත් සමග ගහට පොත්ත වගේ එදා සිට අද දක්වා IKEA සමග සිටින ජ්‍යෙෂ්ඨ ඍජු නේත්‍රඥ උපාලි සීකුබදු මැතිතුමා මේ අවස්ථාවට මම ආරාධනා කරනවා IKEA ඔබ සියලු දෙනාටම මේ ස්ථානයට පැමිණෙන්න කියලා. ඔබ සියලු දෙනාම ඒ වගේම අපේ වත්මන් සභාපතිනි දෘෂ්ටි විශේෂඥ නිසංසලා ප්‍රනාන්දු ඇතුළු සියලුම දෙනාට මේ ස්ථානයට සම්බන්ධ වෙලා මේ අවස්ථාව භුක්ති විඳින්න මේ සතුට ඔබ විඳගන්න
Congratulations, IKEA.
සිරිවර්ධන
At this moment, Chairman, Ceylon IKEA Optometric Association is Chancellor Fernando giving away the piece of cakes to all the members. Please keep my piece of cake.
Nishamani, in स्वल्पमත් කරුණාකර ඔබ මේ ස්ථානයෙන් නික්ම යන්න එපා. ගෲප් ෆොටෝ එක ගන්න සූදානම් වෙලා සිටිනවා. අයික්‍යා
What's the name? At this moment, we have missed one token of appreciation to give away to Miss B.L. Padma Nandani Vijayasundara, Ceylon record holder discussed through. We are really sorry about it. I call upon President of IKEA Lahiru Maringa to give away that token of appreciation. Can you come forward, Lahiru? Give away the token of appreciation to Miss B.L. Padma Nandini Vijayasundara. Sorry, we have missed it. Udeni, please attend to it. President Lion Staff of IKEA, Lahiru Malinga is now given away the token of appreciation to Miss B.L. Padma Nandini Vijayasundara. Now it's time to distribute the certificates. Kindly come forward, Dr. Masha Rajakaruna. Yes. Asha, come forward to get your certificate. Yeah, you go. Optum MSA Saki.
Optum Rashmila Ratnayaka. Optum Stephanie Fernando. Optum Sahan Pereira. We are running behind the schedule. Optum Sahan Pereira. Optum Milon Fernando. Optum Milon Fernando. Optum Darshika Devendran. Optum Mokshala Bandara, she also left. Optum Geeta Gar Vijay Sundara. Optum Prabha Pereira. Yeah, give a round of applause. Optum Prabha Pereira, Optum Kosala Jai Singh. Optum Chaturi Kodituaku. Optum Nissan Salah Fernando. Optum Lairu M. Rodrigo. Optum N. Arul Kumar. Optum Tushara Dilini. Optum Mokshala Bandara. Yeah, that's all. No certificates for me. It's okay. Not written certificate for me. Arul, come forward to get your certificate. You want? Yeah, to conclude the program, I am sure we have learned many messages to take home with us how to eliminate avoidable blindness. We sincerely hope today was a very fruitful day for all of us. And thank you for participating. And let us look forward to meet you the next year and drive safe back home and take care. Thank you very much. Action. Thank you. Sudak na tante. Oh, I mean, hari. Yes. Awa madre na po. Girls, ladies, study. मैं पोसिंग